Edgar sir, good morning.
Sir.
You must start.
Yes, sir. Good morning, everybody. Welcome to e-ASTICON. I request Honorable Dr. Bumesh Kumar Katakam, Organizing Secretary of e-ASTICON.
Yeah, very good morning and welcome to the e-ASTICON inaugural ceremony that is going to be held on today, 12th September 2021 on virtual platform. I invite the President of Indian Association for the Study of Sexually Transmitted Diseases and AIDS, Dr. S. Murugan. Sir, please come on to the dais and occupy the chair. I invite Organizing Chairman of e-ASTICON 2021, Dr. G. Narasimharao Neta. Sir, please come on to the dais and occupy the chair. I invite General Secretary of ISSTD and AIDS, Dr. V. Mohan Kumar. Sir, please come on to the dais and occupy the chair. I invite the President-elect, Dr. Satyadar Patnaik. Sir, please come on to the dais and occupy the chair. I invite immediate past President, Dr. Somesh Gupta. Sir, please come on to the dais and occupy the chair. I invite Organizing Co-Chairman, Dr. T. Rajiv Singh. Sir, please come on to the dais and occupy the chair. I invite Dr. Rajiv Singh, sir, please come on to the dais. I invite Dr. G. Chandrasekhar Rao. Please come on to the dais and occupy the chair. I invite the Scientific Chairman, Dr. G. Venkatramana. Sir, please come on to the dais and occupy the chair. I invite Dr. P. Narasimha Rao, the Organizing Chairman. Sir, please come on to the dais and occupy the chair.
I invite Dr. Bumesh Kumar Katakam. Please come on to the dais and occupy the chair.
Thank you very much, all the dignitaries. Now it is the time to inauguration of the ASTICON 2021 on virtual platform. For this, I invite the Honorable President of ISSTD and AIDS, inaugurate the e-ASTICON by lighting a lamp with a prayer song. I request all the dignitaries on the dais, please join for the inaugural session by lighting a lamp.
Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatru buddhi vinashaya dipajyotir namostute. Dipajyotir namostute. Dipajyotir parabrahma. Dipajyotir janardanah. Dipajyotir parabrahma. Dipajyotir janardanah. Dipo hartu me papam. Sandhya deepa namostute. O deepa brahma rupasvam. Jyotisham prabhuravyayah. O deepa brahma rupasvam. Jyotisham prabhuravyayah. Arogyam dehi putrausha. Matim swachham hi me san.
Thank you very much for all the dignitaries on the dais. Now it is a time to the silent prayer for the healthcare corona warriors. So we are in a special situation of the COVID-19 pandemic. Almost more than 1,500 healthcare providers we have lost during the battle of this pandemic. I request all the dignitaries and the delegates, please observe 1 minute silent prayer for healthcare corona warriors. Thank you. Now I invite the organizing chairman, Dr. G. Narasimha Rao Neta, to give welcome address.
Very good morning and welcome to e-ASTICON 2021. Faculty members from all over the India. Last year, team had conducted e-ASTICON successfully with 2,220 delegates, which was applauded by all our beloved members. In continuity of COVID-19 pandemic, EC has decided to conduct conference virtually only and given a chance to Team Hyderabad to conduct e-ASTICON on 12th September 2021. The theme of the conference is in Man Ki Baat, Dr. Ki Saath of STI and AIDS, which is perfectly suitable for the younger doctors as well as practicing dermatovenerologists. The unique theme of the conference is short talks followed by panel discussion, which will cover practical tips definitely useful in our day-to-day practice. On behalf of organizing committee, I thank our President, Dr. S. Murugan sir, General Secretary Dr. V. Mohan Kumar sir, Treasurer Dr. G. Chandrasekhar Rao sir, and whole team for giving us the second time opportunity to conduct the e-ASTICON 2021. I also congratulate my team members, Organizing Secretary Dr. Bhumesh Kumar Katakam, Scientific Chairpersons Dr. G. Venkatamana sir, Dr. P. Narasimha Rao sir, and all other beloved members. I thank one and all participating delegates. I hope everybody will enjoy this educative and scientific feast. I thank you one and all. Jai Hind.
Thank you, Dr. Neta sir. Now it's a time to give a presidential address. For this, I invite the ISSTD AIDS President, Dr. S. Murugan. So, sir, give.
It is quite unfortunate that we are not able to meet in person and interact each other as in physical conference for the past 2 years due to the pandemic, COVID pandemic. Is that we are having a wonderful organizing team that is from Hyderabad under the able chairmanship of Dr. Narasimha Rao Neta and secretaryship of Dr. Bhumesh Kumar and co-chairman Dr. Rajiv Singh and scientific committee chairman Dr. Venkatamana and Dr. Narasimha Rao. So because of them, last year also we are having wonderful conference, and we are having actually during our physical conference we used to have 400 to 500 delegates, but last time we are having more than 1,000 delegates join in the week e-conference like that. This year also they have planned very meticulously and they planned the programs and interesting topics and panel discussions. They invited super faculties to deliver lectures and panel discussion, and it will be very interesting. I am sure it will be very interesting to all the delegates join here. And that is a dermatovenerology branch is a ever growing branch, especially the science is advancing day by day, especially the fast 5 years it has immense fast growth is there. Likewise the dermatovenerology branch also, the aesthetic and laser and dermatosurgery, trichology and whatnot was increasing day by day. But in this growth we should not lose the importance of STA and HIV medicine, and we should make the youngsters to realize the importance of the STA. The STA is, as per the WHO bulletin, nearly 1 million cases per day across the world is being occurring STA cases, and 376 million has been reported 2016 new cases of gonococci, chlamydia, syphilis, trichomonas vaginalis, like that. So in India also nearly 40 million cases per annum was reported as in STA, only next to tuberculosis and malaria. So it is a very important branch. As long as human being exists, it will be there, and maybe the pattern may be changing, presentation may be changing, and it will be ever challenging one. So we have to prepare our youngsters to face this, and youngsters has to carry this lamp forever for the growth of this branch. And it is a fetching branch, and the people in the presence of anything pertaining to their genitals, they will be worrying much and they will not mind to pay. The STA practice is not only concerned with the STA and HIV medicine, anything pertaining to sexually, that is genitals and sexual health, reproductive health is also there. So we have to give much importance to this also, and we have to carry the lamp of this STA forever by these youngsters. So this is, I have to stress, very important. And the field also, the lab aspects is increasing day by day, that is advancing day by day. Even we are not able to follow like that. And the HIV medicine also, we have to update ourselves then every year, otherwise we will be lagging behind. So this is also very important thing, and we have to give importance about the STA and HIV medicine and genital problems, sexual health. So it is a very important range, and this conference will be very useful to shape yourself, to update yourself this year also. And I pray for the success of this conference, and it will be useful for all delegates. And thank you very much, and Jai Hind.
Thank you, sir. Thank you, President, sir, for your wonderful message. Now I invite the scientific chairperson, Dr. Venkatramana, sir. Please give his message.
Hello, good morning, all dear seniors, professional colleagues, and my dear postgraduates. As a chair from Scientific Committee, it gives me immense pleasure in inviting you all for this second e-ASTICON and 45th National Conference of ASTICON, organized by Indian Association of Study for Sexual Diseases, Sexually Transmitted Diseases and AIDS. This is on 12th September 2021 on Sunday. We have kept a more practical oriented theme called Man Ki Baat, Doctor Ke Saath on STDs and HIV. So this clearly shows we should be great listeners, good listeners so that the patient can share their pain, misery, and their personal problems. So, in order to make our postgraduates good listeners, we have chosen this scientific program as more PG oriented. We, all the scientific committee members, have very carefully selected the topics in such a way that our postgraduates will be benefited and they will shine as academicians in future and as practitioners also after coming out of their colleges. And our organizing committee is very much pleased in giving you free registrations. Though registration is mandatory, it is very much free. And I am proud to announce that the registrations have crossed more than 1,000. It's a very huge figure in the history of ASTICON. And this success is all yours only because of our enthusiastic registration, and this made it possible. And I request all of you to participate and make this conference a great success. Thank you one and all.
Thank you, sir. Now I request the Honorary General Secretary of IASTD and AIDS, Dr. Mohan Kumar, to give his message.
Good morning. On behalf of IASTD, I am welcoming you for the 45th National Conference of IASTD and second e-ASTICON. Our best wishes to Hyderabad team led by Professor Neta, assisted by Professor Bumesh Kumar, and Gandhi Medical College team. Best wishes.
Now the conference overview by Dr. Bumesh Kumar Katakam.
Esteemed dignitaries on the dais and off the dais, very happy morning to all. Myself, Dr. Bumesh Kumar Katakam, Organizing Secretary. On behalf of Organizing Committee, I welcome EC President Dr. Murugan, Secretary Dr. Mohan Kumar, Treasurer Dr. Chandrasekhar Rao, and all former presidents, secretaries, and treasurers, and the faculty of this e-ASTICON, chairpersons, speakers, moderators, panelists, and quiz masters, and the most important, delegates from all over India to this 45th National Conference of IASTD and AIDS, which is going to be held today, that is 12th September 2021 on virtual platform. We all are in a special situation due to COVID-19 pandemic since more than 1.5 years. But we healthcare providers delivering our services by treating the patient on one side and updating our knowledge on another side. Of course, the health and doctors are not optional for the society. We are very much essential for the society. We can tolerate the tragedy of earthquakes, calamities, anything, but nobody can tolerate the tragedy of bedroom. So that's why the genital health as well as skin health awareness should be initiated from the pediatric age group. Subsequently, the body health and national health will continue for the progression of the nation. The theme of this conference is Man Ki Baat Dr. Ke Saath of STI and AIDS, which is rightly suited to update our knowledge among ourselves and to the younger generation. The unique feature of this conference is postgraduates quiz. Each session will have quiz. Among all 5 sessions, the best 3 PGs will be selected for first, second, and third prize with appreciation certificate, memento, and many more to encourage in the field of IASTD and AIDS. To conclude, I request all the delegates and postgraduates please make use of this conference. Definitely, this conference will give lot of take-home pills by our esteemed faculty from all over India that will be useful for our day-to-day practice to maintain health in the society. Thank you very much. Jai Hind, Jai ISSTD and AIDS, Jai Telangana. Now it's the time to move towards the felicitation to the dignitaries on the dais. I invite Dr. S. Murugan. Sir, please be seated. I request the organizing team for the felicitation. Next, Dr. V. Mohan Kumar. Dr. G. Chandrasekhar Rao. Dr. Satyarshi Patnaik. And Dr. Somesh Gupta. Yeah, now I request the EC to felicitate the organizing team. Dr. G. Narasimha Neta, Dr. T. Rajiv Singh, Dr. G. Venkatramana, Dr. P. Narasimha Rao.
Now I invite Dr. Bumesh Kumar Katakam for felicitation.
Yeah, thank you very much for all the dignitaries on the dais for your valuable message. So we will conclude this inaugural ceremony with a Telangana song. I request all the members please put in a mute form. Cinema sound.
जय जय हे तेलंगाना जननी जय केतनं मुक्कोटि गोंतुकलु ఒక్కటైన చేతనం జయ జయ హే తెలంగాణ జననీ జయ కేతనం ముక్కోటి గొంతుకలు ఒక్కటైన చేతనం జయ జయ హే తెలంగాణ జననీ జయ కేతనం ముక్కోటి గొంతుకలు ఒక్కటైన చేతనం తరతరాల చరిత గల తల్లి నీరాజనం తరతరాల చరిత గల తల్లి నీరాజనం 10 జిల్లల నీ పిల్లలు ప్రణమిల్లిన శుభ తరుణం జై తెలంగాణ జై జై తెలంగాణ జై తెలంగాణ జై జై తెలంగాణ పోతనది పురిటి గడ్డ రుద్రమది వీరగడ్డ గండర గండడు కొమురం భీముడే నీ బిడ్డ పోతనది పురిటి గడ్డ రుద్రమది వీరగడ్డ గండర గండడు కొమురం భీముడే నీ బిడ్డ కాకతీయ కళా ప్రభల క్రాంతిరేఖ రామప్ప గోలుకొండ నవాబుల గొప్ప వెలుగె చార్మినారు
Thank you very much for all the dignitaries and the dais and the delegates. Now, without wasting any time, so we will move on the scientific program. So almost we have finished the inaugural session 2 minutes in advance. So welcome to the keynote address. The emerging trends in the management of sexually transmitted infections. I invite the chairpersons for this, Dr. P. Narasimha Rao and Dr. D.B.N. Murthy. So Dr. P. Narasimha Rao needs no introduction. He was a professor from Bhaskar Medical College and the senior most dermatologist from Telangana and all over India. And he was a past president of IADVL 2019. He has many more achievements on his name. Sir, welcome. Please come on to the dais. And Dr. D.B.N. Murthy, who is the senior most dermatologist from Hyderabad and from all over India. And he is the president of IADVL Telangana 2021. So he has many achievements, a very kind person, ground to earth. So thank you very much. Over to chairperson to start the proceedings.
Good morning. On behalf of my co-chairperson, Dr. P. Narasimha Rao, I give a brief introduction about the keynote speaker, Dr. Somesh Gupta. Dr. Somesh Gupta is now currently working as a professor of dermatology and venereology in All India Institute of Medical Sciences, New Delhi. He is currently
Somesh Gupta CV.
He is a current regional director and past membership secretary of International Union Against Sexually Transmitted Infections. He was past honorary treasurer of National IADVL. He was immediate past president of IAS, STD and AIDS. And he was also past president and past secretary of e-ASTICON, published over 200 research papers and authored 2 international books, including one on sexually transmitted infections. He is a recipient of All India Institute of Medical Sciences Excellence Award, first in 2013 and second one in 2015. With this brief introduction, now I request Dr. Somesh Gupta to deliver his keynote address. Over to Dr. Somesh Gupta.
Thank you, Dr. Murthy and Dr. Narasimha Rao for kind words of introduction. And I think the organizing committee and scientific committee of e-ASTICON Virtual 2021 for inviting me. And it's a great honor for me. Thank you very much. I have a long association with IAS, STD/AIDS, and I really enjoy the interaction with all of you. And I really enjoy participating in these meetings. And it was nice to see the glimpses of Telangana. The new Telangana is really much more developed and nice to watch. So in a moment, I will start. So I will be speaking in next 20 or 25 minutes on some emerging issues in the management of STI. Sexually transmitted infections have gone a dramatic change in past 3 decades in all forms. And it is not the same specialty as it used to be as venereology of 1980s and 1990s. It is much different. And how it is different, I will cover in next 20 or 25 minutes. So I will cover my these under these headings one by one. And the first thing and foremost thing, which is also on the high on agenda of international organizations, including WHO, is sex positivity. Now, what is sex positivity? Is the sexual health has been defined by World Health Organization as a state of physical, emotional, mental, and social well-being in relation to sexuality. And please note that it is not just absence of a disease or infection which is transmitted through the sexual route. It is much more than that. It is much more positive than just merely an absence of sexually transmitted infection. On the other hand, sexuality is defined as a broad range of expression of intimacy and which is fundamental to self-identification with a strong cultural, biologic, and psychological components. So sex matters. We human as a species are successful because of sex itself. So sex should not be associated with any taboo, or it should be a responsible sex by the individual, but it should be an essential part of our discussion and our overall health. So conversation about sex cannot be ignored or undervalued by any chance. So positive sexual health comprises of intersection of 3 things, that is sexual health, sexual rights, and sexual pleasure. And all of these are important, and we should accept this without being judgmental. As I mentioned here, the Martin Luther King's words, be careful not to measure your holiness by other people's sins. So we need not to be judgmental whenever a patient with STI visits our clinic. And we need to implement positive sexual health in the clinic. So how to implement? It is one simple thing is not to start immediately the questions related to STI. First, interact with the patient in relation to sexuality. You can ask some questions. What is your gender identity in local language? What questions do you have about your body, sex, or both? Are you satisfied with the frequency of sexual activity? Do you have orgasm? Does your vagina lubricate enough? Or after we are done with this, this conduct allows us to promote comprehensive and affirming sexual health care that is ultimately sex positive, regardless of our patient's gender or sexuality or sexual identity. So once we are done with this, we can start with our unfamiliar vocabulary, which we use in sexually transmitted infections. Another thing which we, as part of International Union Against Sexually Transmitted Infections, as a team, we published this about the STI-related agent stigma, and we should ensure the following 4 key approaches to reduce the stigma for patients visiting our hospital. And these are person-centered approach. What I mean by person-centered approach is a person-centered approach addresses commonplace experience of feeling judged negatively. If we are judgmental to a patient, and anybody can be judgmental to a patient, right from interacting doctor to interacting nurse to the one who is taking sample or even the counselor. So we need to eliminate this kind of judgmental attitude by person-centered approach. Then, as I mentioned earlier, we need to be sex positive. We need to be provide trauma-informed care. Having STI is traumatic to the patient. We have to be kind, and we have to be non-judgmental all the time. And another thing is community engagement. We need to engage with people who are marginalized, like sex workers or transgenders. So another question is why STIs are important. Now, there is a high burden, global burden of curable STI, as WHO states. There is an alarming increase in the antimicrobial resistance in many organisms, but two most important and imminent threats are Neisseria gonorrhoeae and Mycoplasma genitalium. And then the complications of curable STI, such as pelvic inflammatory disease, ectopic pregnancy, infertility, chronic pelvic pain, seronegative orthopathy, and neurological and cardiovascular diseases. Now, you can see that STIs discriminate on the basis of gender because many of these complications are more common in women. So men play a major role in transmission of infections because of their inherent sexual behavior involving many women. And these infections are eventually transmitted to women, and they cause complications, and they also cause pregnancy related complications such as fetal and neonatal death, premature delivery, neonatal encephalitis, eye infection, pneumonia, to mention a few of, and we have seen many of these complications in our practice. So next is regional epidemiology. So here I'm beginning with some good news. So while the WHO global estimate for 4 common curable infections, syphilis, gonorrhea, chlamydia, and trichomoniasis, have shown little change over past 3 decades. There is no change in the global burden of these diseases. However, there is a major decline in Southeast Asia in relation to the world. Now, you can see here that the Southeast Asia comprises of nations for which in our country, India, contributes 2/3 of the population. So this major decline in Southeast Asia is basically because of major decline of these curable STIs in India. So as you can see, in 1990s, Southeast Asia contributed 35% of all the global burden of these 4 curable STIs. Now in 2012, the proportion of patients in Southeast Asia's share in the global burden has declined from 35% to 11%. So that's a good control of STI, particularly the curable STI. So when we look at the India, what it was, the scenario was in 1990s, the STIs were poorly controlled. There was a high prevalence of bacterial and ulcerative sexually transmitted infections, including chancroid and also donovenosis in certain areas. These infections were concentrated in urban areas, and they were linked to rural to urban migration and mobility. And there wasn't a strong association with HIV acquisition and transmission. Now, what is happening now? Evidence of large declines in STIs between late 1990s to 2010, and decline in key populations like sex workers, MSM, and drug users and prisoners, and decline in bridge population, which are migrants, transport workers who have contact with both key population and lower risk populations. And there is a general decline in the pregnant women. And as you can see that this is also associated with some interesting finding. And one of it is the proportion of identifiable pathogens is declining in India and everywhere, is with the declining in the prevalence of curable STIs or incidence of curable STIs. So these 3 studies, one from Pune, one from Hyderabad, and one from New Delhi AIMS, which is very recent, 2021. So 1999, 2012, and 2021. So these 3 studies using molecular testing, which are very, very sensitive tests to detect these pathogens causing ulcerative genital ulcer disease. So it is declining from 66% to 62% to 48%. This means half of the patients now who present with genital ulcer disease do not have the recognized sexually transmitted infections. So what they might have? The another question is what they might have. So this means we are moving from curable STIs to viral STIs, and not only that, we are moving from infectious agents from infectious agents to infectious agents plus some unknown causes which we do not know what is happening. So this adds to the weakness of syndromic management. So syndromic management has worked very well. It contributed to decline in curable STIs, because viral STIs are mostly not curable, so they continue to remain prevalent, but bacterial STIs have gone down with time. And in syndromic management, again, as I said earlier, the STIs discriminate against women. Syndromic management policy also is discriminatory to some extent against women. How I will tell you in a moment. But first, see these two sagittal sections showing reproductive organs of men and women. Here you can see that it is very simple in men. This urethra has a discharge. It originates mostly in the urethra, sometimes in the prostate, sometimes in the epididymis or testes. So it is so simple because men's reproductive job is just to synthesize some, create some sperms and deliver them to the women's reproductive organ. And here, when you come to the reproductive organ of women, it is so complicated. It has large surface area. So many epithelial surface area makes her susceptible to a large number of infections, which may be sexually transmitted or facilitated by sex. And just to make it worse, the vaginal discharge can come from vagina itself, can come from cervix, can come from upper reproductive tract like uterus and other areas, and it can come from even urethra. To make the things worse, the anal opening is quite close to the vagina. So some intestinal flora, which are normal to intestine, can migrate to vagina or reproductive tract and can cause discharge. So it is such a complicated problem. Why this system is so complicated? Because the woman has to make the most complex structure known in the universe in her reproductive organ from a single cell, that is a human baby. This is most complex structure known in the universe. So that's why it is so complicated, and therefore the syndromic management may not work as well for women because it is very complex thing, and syndromic management is a very, very simplistic approach. So the problem of here you can see that sensitivity and specificity of STI syndromes in men and women, you can see that in vaginal discharge and in lower abdominal pain, the sensitivity is 58 and 14.5% respectively, while in urethral discharge, which is a syndrome in the men, the sensitivity is 90%. So the syndromic approach works so well in men, but it doesn't work so well in women. But we have no better option as of now because the detection tests are not so economical. But what we can do, we can add certain things, particularly in women, to the syndromic flowcharts so as to make it a little more sensitive. Now, how to do that? We can do, generally we just do risk assessment to treat sexually transmitted pathogens in women who come with vaginal discharge. If we add speculum, the sensitivity increases from 28% to 45%. If we add weight mount and gram smear, the sensitivity improves from 45% to 90%. And if we add molecular POC test, point of care test, the sensitivity and specificity both are very, very high. So this is the ideal scenario, but in the setups where resources are limited, we can rely on at least on speculum and weight mount and gram smear. This is what we can do. So there are point of care tests available, but most of us do not have the awareness about it. So here I just want to say that these are very economical, very affordable, like Sifi check. The cost is around 700 rupees for 25 tests, and SD Bioline syphilis rupees 750 for 30 tests. So why it can't be implemented? It gives results quickly. It has reasonable sensitivity and specificity and positive predictive and negative predictive values. On the other hand, for chlamydia and gonococcal and trichomonas, these are technology intensive even when they are somewhat point of care, and the sensitivity and specificity has its own problem with these. So these are still not ready for implementation. HIV can be implemented because it is also quite economical, and on the other hand, HSV2 is part of TORCH rapid test, but again it needs more workup in the clinical setting, more evaluation before it can be implemented generally. So this is our counselor's room, and here you can see this colorful poster of STI syndromic case management. And this is a very, very important initiative. This was very novel initiative by National AIDS Control Organization, in which the color-coded kits were given for different syndromes. As you all know, I'm not going into details of this, but this played its role in controlling the infections, bacterial infections, which are transmitted sexually, and controlling so well. So this was really, really, very, very novel and nice initiative by National AIDS Control Organization. And here you can see that these kits are quite easy to administer. Most of them have oral tablets. Many of them are single dose tablets, so it can be given supervised while patient sitting in the STD clinic itself. So this is indeed a very, very heartening initiative which was taken long ago. But now, as these diseases are getting controlled, as I mentioned earlier, the infective causes are declining. So many of these patients will receive treatment while they are not having these infections. For example, identified pathogens are only found in 20.7% in vaginal discharge, 44.7% in cervical discharge, and 48% in genital ulcer discharge in various studies, including our own study. So you can see that more than half of the patients will receive these syndromic kits while they are not actually having these infections. But we can't help it because still the other tests are very, very expensive. So this is again our study, which is under publication in IJTVL. Here we found that gonococcal infection is extremely uncommon in women with cervical discharge and PID. We did not find a single patient with whom we screened with gonococcal infection. So what were the other infections in cervical discharge? They were Mycoplasma hominis, Ureaplasma, and Chlamydia trachomatis. So gonococcus has become very uncommon. Why? Because of simple reason, because India was using dual drug incidentally for gonococcus as part of syndromic management, that is azithromycin and cefixime. Now WHO and CDC have recommended this regime for all the countries. So this is the syndromic management has incidentally helped us. On the other hand, when
Sir, you're muted. Please unmute yourself.
Yeah. So genital ulcer etiology using MPCR, when we did it, we found that chancroid is extremely uncommon. So the syndromic kit where we are using treatment against chancroid may be unnecessary. That is what the problem of syndromic management is. But currently, as I mentioned, there is no other alternative. Now, so what is happening in genital ulcer? There may be some non-STI infective causes. This is from the paper of late Professor Sehgal, who had published it along with Deepika and other colleagues, Deepika Pandey and other colleagues. So these are the causes which are potential causes of these genital ulcers which show no STI pathogens, recognizable STI pathogens. And there may be some other STI pathogens which we are not aware of. So we need to do some more work on it. Now coming to emerging antimicrobial resistance. So this slide shows that gonococcus is an imminent threat of becoming a superbug. And as you can see that the antibiotics used in earlier 1930s, 1940s and 1950s in the form of sulfonamide, penicillin and tetracycline do not work. Then in 1980s, ciprofloxacin came, which doesn't work. Now azithromycin from various parts of the world, high degree of resistance has been reported. And for cefixime and ceftriaxone, again, recently, the reduced susceptibility has been reported from different parts of the world, including our own AIMS data by Dr. Seema Sood, which shows a slight decline in the sensitivity and increase in the MIC of these drugs. On the other hand, M. genitalium, Mycoplasma genitalium, which is which is only recently came into discussion, but this is also a pathogen which can become a superorganism. And because doxycycline, it doesn't work, 30 to 40% resistance, azithromycin, macrolide resistance develop after 1 gram single dose. So extended dose is needed, but that is also leading to resistance. And what we do for macrolide resistance, and we can give moxifloxacin 400 mg 7 to 10 days, but this molecule also becoming rapidly resistant. So these are the issues, and these two organisms, although they are not highly prevalent in India, but this situation may change rapidly in future. This is our own study, and we found here the problem is not of resistance but relapse. Those women who come with bacterial vaginosis, if we follow them enough, majority of them, most of them will relapse. So in this study, we found that 40 women who received treatment and who were followed up, 15 relapsed in 1 month, 7 relapsed in 3 months, and 4 relapsed in 6 months. So 15 plus 7, 22 and 26. So 26 out of 40 women, they followed up for 6 months and relapsed. So this is the problem with bacterial vaginosis. Now someone can say that bacterial vaginosis is not a sexually transmitted infection, but it occurs only in sexually active women. It never occurs in women who are not sexually active or pre-sexually active reproductive age group. So it is related to sexual activity. We can call it sexually transmitted. Another issue is candida. You must have seen this scurdy discharge in your clinic. And this woman who used to come to us from 2017, when she was sexually active with a partner, then she developed this. We treated her, admitted her, and gave her intravenous fluconazole because the disease was not responding to oral fluconazole. She responded, remained well for 2 years. Then she got married to another man, and then she relapsed. So it is also related to sexual activity. The genital candida, she was free of candida as long as she was sexually inactive, and after she received the treatment with fluconazole, but the disease relapsed quickly after she became sexually active again. So this is the problem when we showed so many candida filaments, and when we cultured it, we found that the organism was Candida albicans, which was sensitive only to flucytosine and resistant to fluconazole, voriconazole, amphotericin B, and all other available antifungals. So problem is that when Candida albicans is resistant to fluconazole and resistant to itraconazole, then there are very limited treatment options. So the recommendation is that for recurring vulvovaginal candidiasis, we have to give 10 to 14 days of induction therapy with topical agent or oral fluconazole, followed by fluconazole 150 milligram weekly for 6 months. And for Candida albicans, which is the most common cause, can cause severe resistant Candida infection, and but also this is more common in other species. For example, Candida auris, Candida glabrata, and Candida parasilosis. So for a non-Candida albicans infection or resistant Candida albicans infection, we can consider intravaginal boric acid 600 milligram daily for 14 days. This is available in India. Unfortunately, 17% flucytosine cream is not available in India. So these are the issues. Another issue is which we are seeing very quite often, because these patients are not being treated at other centers. So ours being tertiary care center, we are seeing these cases repeatedly, and these are penile intraepithelial neoplasia. Again, you can say that this is not a sexually transmitted infection, but it is caused by human papilloma virus, which is a sexually transmitted pathogen. So this patient was, again, many of these patients, they show dysplasia in the histopathology, and we have to treat them continuously because they quickly relapse. Some of these patients will never get cured with whatever we have, whether it is imiquimod, whether it is other 5-FU or other anti-cancer agents. So another thing is this patient presented with persistent genital ulcer, and this was PCR positive for HSV2 but resistant to all available drugs. So we gave this patient colchicine, which led to some improvement, but it was not completely cured. So another last issue which I want to cover is incidentally detected weakly positive reactive VDRL and positive TPHA during blood donation. This patient came last week to us. So how to manage? So here I just want to say that any patient who has incidentally detected positive VDRL and positive TPHA should be treated as late latent syphilis and should be investigated for neurosyphilis if there are symptoms, ocular syphilis if there are symptoms. So these patients should be treated with 3 doses of benzathine penicillin. Please remember, we whenever in case of syphilis, we have to over treat rather than missing a case. Because when I visited Shanghai Skin Disease and Hospital, STD hospital, this whole ward was dedicated to syphilis patients. And I saw all kind of late syphilis patients, including first case of GPI in my life, which I saw here. So not to miss it. Therefore, many countries are now following the reverse algorithm for screening of syphilis, in which the treponemal test is done first, and if it comes positive, then non-treponemal test is done. Because as you know,
my apologies, sir.
Yeah, I'm
We are left with 3 minutes, sir.
Yeah, I'm about to finish. So this is what we have to do, that reverse algorithm, because we don't want to miss latent syphilis when VDRL becomes spontaneously negative. So in summary, we need to provide stigma-free, non-judgmental STI services to all sections of society. India is witnessing a decline in curable STI and a surge in viral STIs. Even with highly sensitive molecular testing techniques, infective causes are identified in about half or less than half patients with GUD, vaginal discharge, cervicitis, and PID. Syndromic management is associated with overtreatment and does not address the problem of asymptomatic infection, but currently the only option in resource-limited settings. The NACO's color-coded syndromic kits, they work well in many settings. And I must acknowledge my colleagues, Dr. Ms. Apurva, Dr. Seema Sood, Dr. Benu Dhawan, Vaishnavi, Sachin, and Sunil Sethi for their help in this presentation. And I still remember Kodaikanal, our last physical meeting which we had, and this was a picture taken when I was coming back from Kodaikanal with all sweet memories. And this was the team. I hope to see you all physically again in next year. And I once again thank Telangana team for conducting second consecutive year this very glorious virtual conference. Thank you very much for your attention.
Thank you, Dr. Somesh. Somesh Gupta is one of the most versatile dermatovenereologists of India, I should say. And of course, we always look forward to hearing his talk, and because they are to the point and highlight the issues which deserve to be highlighted. And of course, this is very good learning process for me. I'm sure it must be for all the audience who have have joined this session. And I thank Dr. Somesh Gupta for a wonderful talk on behalf of ISSTD, and I'm wish him all the best and I hand over the proceedings to the organizers of the conference. Thank you, Dr. Somesh.
Thank you.
Thank you, chairpersons. And now it's the time to felicitation to the faculty. I request the persons to felicitate our speaker, Dr. Somesh Gupta. Organizing team to for the felicitation of the chairperson. Yeah, thank you very much. So now we move on to the session 1. That's a female genital dermatosis. I invite the session coordinator, Dr. Manogna. So, Dr. Manogna, please go ahead.
Respected dignitaries, estimated members of the organizing committee, and all the delegates and all the faculty members, a very good morning to one and all. It gives me very great pleasure to welcome you all to the first session of e-ASTICON 2021. And the topic for this session is female genital dermatosis. I'm sure this session will prove to be a feast of knowledge with a wide variety of clinical topics. And first and foremost, I would like to welcome the chairpersons for this session. Dr. R.N. Datta sir, our first chairperson, is the ex-professor in HOD, IPGMR and SSKM Hospital, Kolkata. Sir has held various positions in IADVL and was also the past national president of Indian Association of Sexually Transmitted Diseases and AIDS. Sir, I request you to please ascend to the dais, sir.
Yeah, good morning.
And kindly permit me to introduce the second chairperson, Dr. T.S. Chandragupta sir, who is a retired professor of DVL and has studied in Kurnool Medical College and later has done his post-graduation also from SV Medical College as well as Kurnool Medical College. Sir has 4 national publications and has trained and taught a lot of postgraduates. Sir, I request you to kindly ascend to the dais, please. Please permit me to introduce our third chairperson, Dr. Vijay Zawar sir, who is a candidate for President-elect 2021. And sir is professor in HOD Dermatology, Dr. VP Medical College, Nashik, Maharashtra. Sir has held various academic positions in IADVL. Sir, we request you to kindly ascend to the dais.
Thank you very much.
I request our chairperson, Dr. R.N. Datta sir, to kindly introduce the first speaker of today's session, Dr. JVDS Prasad sir.
Good morning, everybody. And I thank the organizing committee to put me in this position at present. Now, the biodata of Dr. JVDS Prasad. He has done his MBBS MD from SV Medical College, Tirupati, and assistant professor of Guntur Medical College, Guntur, and SV Medical College, Tirupati. He is also the associate professor of Osmania Medical College, Hyderabad, and professor of Osmania Medical College at Hyderabad. He has 8 publications with it till date. And welcome, Dr. JVDS Prasad. I hand over the mic to the organizers.
Over to Dr. JVDS Prasad.
Yeah, sir. Yes. Good morning, all. Welcome to the day of palindrome. Today is 12/9/21. So either way, it is the same number, and it mimics the STA transmission. If a male is having STA, they are transmitting to female, their partners, and if a female is having STA, they are transmitting to their male partners. And this is how today correlates with our conference. Thank you all for the e-ASTICON for giving me the opportunity to take a session on this
female genital dermatosis, of which my topic being the practical evaluation of the vaginal discharges or genital discharges in a female. So let's have a little bit of induction into the subject proper with introduction on the subject about the genital discharges. So usually in a reproductive age woman or any woman, if they see the discharges coming from the vagina, they will perceive it as a vaginal discharge. Any discharge from the reproductive system, that will be perceived as a vaginal discharge by women, and they assume that it is a pathological one. That is the main problem. And of course, there are so many structures that are contributing for the vaginal discharge or genital discharge. It is the vagina and cervix are the two common organs which contribute for the majority of the discharges. And whether from the site from where the discharge is coming, or it can be easily distinguished by performing a simple perspective examination under the privacy and the confidentiality. And most of these infectious discharges may be transmitted from one person to other person to their partners or to their sexual partners through unprotected sexual intercourse. And if once these infections are not treated or incomplete treated, they may result in either local or systemic complications. And more importantly, the presence of genital discharge causes a lot of inconvenience to the partners of the sexual partners in the form of transmitting the infection and also in the form of the sexual distress, wherein the activity will reduce from 3 times a day to 3 times a week to 3 times a month. So this is how these genital infections or genital discharges will contribute in the transmission. And when it comes to the natural defenses, it's really a big slide to discuss topic. But however, I recommend you to go to King Holmes textbook of STD, where a big chapter is given on the genital mucosal defenses. And here, I would like to mention that it is a to simplify that natural defenses, it is the multi-layered stratified squamous epithelium of the female genital system act as one natural defense mechanism. And presence of no glands in the vaginal walls will also contribute. And most of the time, the vaginal pH, which is acidic in nature, under the influence of estrogen throughout their reproductive life, is one of the major defensive mechanism contributing for the prevention of establishment of infection in the genital tract. So this is the matrix that we have to understand. So on the left side of the screen is women in the different age groups: the neonate, the infant, the prepubertal age group, reproductive age group from menarche to menopause, and the postmenopausal age group. And right side is the type of the discharge that we see in women. It's a physiological discharge, or it may be a reproductive tract infection, which is not connected with the sexual activity. And then sexually transmitted infections, the presence of the forgotten or foreign bodies, and certain pre-malignant and malignant conditions. So if you see this matrix, combination matrix, so these are the categories of women who are more likely to have these kinds of the discharges. The neonate, infant, and prepubertal women are more susceptible for 1 to 4 types of the discharges, whereas in reproductive age group women from menarche to menopause, they are susceptible for all kinds of the discharges, whereas the postmenopausal women, the 2 to 5 numbers are more common, of which the 5th is the most seen or commonly seen in this postmenopausal women. Next, coming to the evaluation of the genital discharges. So the causes are divided into 2 categories, basically the physiological and pathological. Here I would like to give a little brief idea about the physiological and pathological discharge in men also. The physiological discharges in men happens to be the smegma, is the number 1 cause in uncircumcised men, and spermaturia, mostly in low sexual activity or no sexual activity men, and prostaturia and phosphaturia. Whereas the pathological discharge in the men contributes by mostly of the sexually transmitted infections. There are gonorrhea, chlamydia, and in a woman and a partner of a female partner who is suffering from trichomonas vaginalis is likely that men will also contact the disease, and it will manifest in the form of the urethral discharge in addition to the gonococcus and chlamydia. Then in women, if you look into the physiological aspects of the discharge, it is different age periods, the premenarchal, periovulatory, and premenstrual, and during sexual excitement under the influence of the cervical secretions, they will have more discharge. And during sexual activity, because of the Bartholin's secretions to lubricate the sexual activity, we'll see more of the discharge. Under the pregnancy is one. When it comes to the pathological discharges, I will limit my attention to only these 5 conditions, wherein the candidiasis, trichomoniasis, and bacterial vaginosis are principal causes for the vaginitis or vaginal discharge, whereas the gonococcus and chlamydia are responsible for the cervical discharge. So these are the 5 infections which I limit in this 15 minutes to discuss upon. As far as concerned, the vaginal discharge or genital discharge to the women is concerned. So if you look into the physiological causes of the discharge in different age groups, during the premenarchal age, usually before 1 to 1.5 years prior to the onset of the menarche, the girls will have more amount of the discharge, which is non-venereal in cause origin, and the causes are mostly non-bacterial, non-specific bacterial infections, and maybe of late forgotten foreign bodies, and rarely vulval and vaginal tumors that may contribute for premenarchal genital discharges. And they usually manifest with clear, serous, or mucoid discharge associated with a little bit of soreness and itching. Whereas in premenstrual or pre-ovulatory period, this kind of the discharges are seen during the reproductive age group from menarche to menopause, and they are of this kind of the type. They are white, they're clear, non-homogeneous, and they are of a serous in type. And on examination, what we'll see under the microscopy, the facilities are available. We'll see only normal epithelial cells associated with the predominant lactobacillus, which are helping bacillus for the female genital systems. And when it comes to the discharge due to sexual excitement, we'll see the contribution of the cervix, and also we'll see the contribution of the Bartholin's for the increased vaginal discharge during the sexual act. So next is the evaluation of genital discharge, and though I told you about the physiological and pathological, of which pathological there are 5 causes, we can come to a 50% or 60% of the diagnosis by taking a detailed history of the in the patient, where we must be in a position to listen to the active listening process should be there for the story what they say, what the patient will tell us, and also we must be in a position to evaluate on these lines. So is a history of age. In the history, we'll focus upon deriving certain important information on these lines: the age and the marital status, the site and type of the site from where the discharge is coming out, the patient could be able to tell us, and then the type of the discharge, which type of the discharge they are seeing, whether it's adherent discharge, whether it's free flowing discharge, like that, and the duration of the discharge. So how long is it, for days or weeks, or is correlated with their menstrual period, something like that, and the timing of the discharge. And also we'll ask into the associated symptoms with the discharge. Is there any itching, or is there any dysuria, or is there any dyspareunia? If at all dyspareunia is there, it is superficial or deep. If dysuria is there, how frequently it is associated with any passage of the urethral discharge also. All those questions, associated symptoms, we will ask the patient. And then we will ask the occupation of the patient and their spouse. Sometimes the risky, the spouse from the risky occupation background will contribute for the frequent or recurrent vaginal discharge in women. And also the sexual orientation practices of the patient and their partners. Of late, the times have come where the oral sex and the anal sex also are coming out with the normality in sexual practices. So asking for the in detail sexual orientation practice of the both patient and partner is also very important. And is there any history of the previous episodes? The similar kind of the previous episodes there in the patient that will give us a clue to whether the patient is compliant to the previous treatment or not. And is there any drug treatment in the past, or any drug reactions in the past from medical legal aspect to protect our skin? And also, is there any operative procedures is done on the patient for the reproductive system problems, wherein we can evaluate whether the cause is because of the forgotten foreign body or something like that. And also, we'll ask for the workplace environment and people associated with that workplace environment, where there may be some cause in the genital discharge of this patient. And also, we'll ask in detail about what are the increasing factors and the decreasing factors that influencing the genital discharge in a woman. So these are the angles in which we will take the history. And if further we want any detailed history, so these are the few lines that where we'll go for the detailed history, in addition to that points I mentioned in the previous slide. So when it comes to the examination, after completion of the history, we'll go for the examination. This examination is nothing but the examination of the doctor about the accuracy of his diagnosis. So there are 4 types of examination. One is visual examination. Second one is perspective examination. Third one is provisional examination. Fourth one is laboratory examination. So in visual examination, what we do? So this is what we do in the visual examination. So we'll see whether from where the discharge is coming out, the color of the discharge, and its adherence nature. The adherent discharge is telling us, giving us a clue that it could be a candidiasis or it could be a bacterial vaginosis. And if the discharge is free flowing and it is adherent, I mean, it is going in between the labial folds, labia minora, labia majora, and 2 labia minora folds, then it could be a case of the trichomonas vaginalis, where the fluid is going through that negative surface tension. So that way we can make a diagnosis. And third one is, next we'll examine the perineum and perianal area, wherein we'll know the practices, sexual practices, and also the risk of contracting the recurrent candidiasis from the anal cavity. And also we'll look for any associated erosions, ulcers, inguinal lymphadenopathy, because in STIs, the mixed infections are being more common. Here, the mixed infections means having more than one type of the infection, STIs, and we call it as a mixed infection. In STIs, mixed infections are being more common. We look for other STI presentations like presence of erosions, ulcers, and inguinal lymphadenopathy. And also we look for any senile changes in the vulva, where this will give us a clue the possibility of the risk of our patient for the malignant or pre-malignant condition.
Accept my apologies, doctor.
Yes.
We are left with 3 minutes.
Sorry, sir. So I'll make it fast. So then perspective examination, these are the areas that we look into: the vagina, the cervix, and the urethra for various kinds of this one. And in examination, the NACO tells us perform the minimal laboratory if it is available, a litmus test, wet mount, 10% KOH test, Gramscian, and also biliary, which is a mandatory test after they perform the counseling and testing. So I will skip all these individual slides. And this is how this is what I emphasize upon. Please follow the NACO flowchart on the management of the vaginal discharge, the cervicovaginal discharge, wherever it is possible, and look for the vaginal causes and the cervical causes, and treat the causes accordingly with the kit number 1 and kit number 2. And this is the NACO 127 kits chart, where the kit number 1 is advised for the cervical discharge of gonococcus and chlamydia, whereas kit number 2 is advised for the vaginal causes of the candidiasis, BV, CV, and PP. So, and partner treatment, wherever you treat the candidiasis, a cervical discharge, you treat their partner with the kit number 1, and wherever you treat the patient with kit number 2, you think and you examine their male spouse, and then you decide accordingly. So, in summary, so evaluation of genital discharge in female is a simple and effective OPD procedure that we can do it. The evaluation can be done across all healthcare facilities where it requires a minimal equipment like speculum and light resource, a little time and more of the commitment from the healthcare worker. And syndromic case management is an effective way to resource poor settings with availability of single therapy dose color-coded schedules, kits like a kit 1 and a kit 2 in case of vaginal discharge and reproductive. Thank you, and I thank all these people for textbooks, the authors, and more importantly, Dr. B. Masudan, he's a technical expert for facilitating the preparation of the slides. Thank you.
Thank you, sir, for a wonderful talk with clinical tips which were beneficial, not only for postgraduates, but also for practitioners. I now request our chairperson, Dr. T.S. Chandragupta, sir, to kindly introduce the speaker for the second topic in today's session, titled Clinical Pearls in the Diagnosis of Genital Ulcers. I request sir to kindly introduce our speaker, Dr. S. Kalaivani ma'am.
Chandragupta sir. Dr. Chandragupta sir, are you there?
Let Dr. Jawar do it.
Yeah, please. Dr. Jawar sir.
Vijay can do it. Vijay?
Yeah, I can do it.
Yeah, please.
Vijay, please.
Hi, Dr. Jawar is there.
Okay, I will do it. Don't worry. So good morning, everyone. At the outset, let me congratulate Dr. Umesh and the team of e-ASTICON for a stupendous success. This is one of the most vibrant online conferences that I have witnessed in the recent times. It's my pleasure and privilege to introduce Professor S. Kalaivani. She is Director and Professor of Dermatovenerology at Madras Medical College. She has been extremely academic with quite good number of international and national publications as well as presentation. She has received many honors and awards, including Silver Jubilee Oration Examiner at various universities. She is also NACO trainer for the medical and paramedical staff in various STI and RTI programs, and her area. Over to you, Dr. Kalaivani. Are you there, please? Ma'am, there? Audible?
Kalaivani madam, over to Dr. Kalaivani.
చెప్పేసి నా పోస్ట్ ఏం చేయాలి ఇప్పుడు నేను
మీరు
Srinivas, you stop sharing, then she will. Yeah.
Yes.
Dr. Kalaivani ma'am, please share your screen. Yes.
Ma'am, sorry, we can't hear you.
Unmute, ma'am. You need to unmute, please.
Madam, not here.
Ma'am, remove your headphones and speak and see.
Your slides also not coming.
We are unable to hear your voice, ma'am. Please.
am I now audible?
Yeah, perfect.
Okay.
Please share your screen.
Okay. Good morning to one and all. So, diagnosis of genital ulcer. Genital ulcer can be due to venereal or non-venereal causes.
Please share your screen, ma'am.
Yeah. I have started, sir, already.
No, your slides are not visible.
In the down, there is share screen is there. You click on that, then you.
I have done that. Naren?
Green button, ma'am.
Yeah, I have done, sir. Naren? Naren?
So after the green screen, ma'am, you need to click share.
1 minute, sir.
Select your slides and share.
Have you minimized your slides already?
Yeah. I have minimized, sir. Yeah. Is it coming now?
Yes.
Yeah? Okay.
Yes.
Sorry for the inconvenience, sir.
Just speak loudly, ma'am.
Venereal causes include syphilis, chancroid.
Madam, slide show, madam.
Yeah. Yes.
Perfect.
So, venereal causes include syphilis, chancroid, herpes dentalis, granuloma inguinal, and primary stage of LGV. Non-venereal causes include trauma, any drug reactions, vesiculobular skin diseases, Behçet, Reiter's, Crohn's, and pre-malignant and neoplasm. So always privacy and confidentiality should be maintained for the patient right from the entry to the exit of the STA clinic. The history taking and clinical examination has to be done properly by a qualified person who is non-judgmental and non-moralistic attitude. So general information like name, age, sex, educational status, and occupation, residence should be asked thoroughly. Then the chief complaints. If the chief complaint is of genital ulcer, the onset, duration, progression associated with pain or painless, associated with itching, discharge, associated with constitutional symptoms, bleeds on touch or manipulation, any history of previous fluid-filled lesions on the genitalia, any history of trauma, any history of vaginal or anal discharge, any history of hair loss, any history of numbness or pain over lower limbs, because you have to elicit in detail to rule out the non-STI causes also and the local complications due to the genital ulcer. So treatment history for the present complaint is very, very important, because tablets, injections and ointment can change the clinical picture of the present clinical condition. Marital history, you have to ask when she was married, what is the duration of marriage, whether living with the spouse or separated. Sexual history is very important and it has to be asked in detail. When was the last marital contact, to know the incubation period. If there is extramarital contact, you have to ask about whether it is with a known or unknown, unprotected or protected, which side, and what was the mode of sex, when was the last contact. Premarital contact also you have to ask. In unmarried, you have to ask the last sexual contact details. These children, always when they present with genital ulcer, kindly ask about the sexual abuse history. Don't think it is a cause of non-venereal. And obstetric history, you have to elicit number of pregnancy, live birth, and any history of abortion or stillbirth. Menstrual history, the menarche and the last menstrual period. Past history, history of past STDs is very, very important. Is there any recurrence? If so, what was the diagnosis? Any previous STIs was there? What was the treatment given? Whether partner was treated? And any medical conditions the patient is suffering from: diabetes, hypertension, tuberculosis, any history of blood transfusion or previous surgeries. Is the patient is on current medications or any drug allergy? General examination should start from the head to foot, and recording the vitals and all systemic examination should be done. Local examination should start with the inguinal region, look for presence of any swelling, ulcer, sinus or scar, and then palpate for the lymph nodes. And in the external genitalia, if you see the ulcer, genital ulcer, the side size, shape, whether it is single or multiple, painful or painless, the base, the borders, the edges, the floor, whether bleeds on touch, should everything be examined on palpation. The external urethral orifice also should be examined for the presence of any ulcer, discharge, erythema, and edema. Perineum, perianal region, skin, oral, and anal mucosa have to be examined carefully. Bones and joints for the presence of any swelling, tenderness, or any restriction of movement. Where vaginal examination has to be done, if vaginal discharge is found, you have to elicit all the color consistency like that. Speculum examination has to be done with a Cusco's bivalve self-retaining vaginal speculum. Look for the cervix, any erosion, edema, erythema, discharge, do the necessary investigations. Bimanual examination to rule out PID. Rectal and proctoscopy in case of anoreceptive female individuals. So primary chancre usually will be single, can be multiple also. So usually it will be painless, clean base, the clean floor with a base indurated. Local lymph nodes will be involved. Always put a speculum, because primary chancre can occur as a erosion in a cervix in 10%. Chancroid, it presents as a multiple painful ulcers with undermined or ragged edges with bleeds on manipulation, and the lymph node involvement will be an unilateral inflammatory bubo, which can occur 1 to 2 weeks after the appearance of the ulcer. Genital herpes usually starts with the constitutional symptoms and the appearance of grouped vesicles in the genitalia, which break down to form multiple painful superficial ulcers, which can coalesce to form a polycyclic border. In case of HIV positive, this genital herpes can remain for a long time. It can become a chronic and atypical condition, so the treatment has to be prolonged. Donovonosis caused by Klebsiella granulomatous can look like can mimic as a carcinoma. So it will be a single or multiple with a beefy red granulation ulcer with bleeds on touch, and no inguinal lymph node involvement will be there. So these are the few descriptions which have been given for the all the genital ulcer which are the causes for STD. So primary lesion will be a papule in case of syphilis and other condition except herpes. Then the base will be indurated in case of syphilis. The pain will be absent in all the conditions except herpes and chancroid. Lymph nodes will be absent in case of donovonosis. Recurrences is common in case of herpes. So lab diagnosis, what are the bedside investigation you can do? You can do a dark field microscopy. So you have to clean the ulcer, take the serous exudate, look it under dark field microscopy. The organism, the left picture shows the typical Treponema pallidum. They have a regular coils, they stay in the field for some time. The right side picture shows the non-pathogenic treponemes. They don't have the regular coils and they don't have a typical movements. So negative dark field examination means the number of organisms may be less. The patient may have applied some topical antibiotics, or they may be suffering from mixed infection. So DFA TP also can be done. Serological test, non-treponemal test, VDR and RPR, and treponemal test or specific test to rule out syphilis. So VDRL sensitivity is 70 to 90% and TPPA is 94%. So gram stain for chancroid, it is usually a diagnosis of exclusion. You can do a gram stain by taking a swab from the undermined edges with a calcium alginate swab and look for presence of multiple pus cells with gram-negative coccobacilli appearing in short chains. Herpes, if there is a vesicle, deroof the vesicle, scrape the base of the ulcer, do a Leishman stain, look for the presence of multinucleated giant epithelial cells and intranuclear eosinophilic inclusion bodies. Granuloma inguinale, you should do a tissue smear. Here, you have to take it from the edge of the ulcer along with the normal skin, and you have to stain it with a Leishman or a Giemsa stain. Look for the presence of large mononuclear cells with a eccentric nucleus pushed to one side, with the numerous intracytoplasmic vacuoles. Inside this, you can see the mature and immature forms of Donovan bodies. Immature forms look like blue or blue-black condensation of bipolar chromatin condensation on either side of the organism, giving a closed safety pin appearance. So LGV, usually we cannot see the transient ulcer in the primary stage, but if at all you see, you can do a Giemsa stain. So Trichomonas vaginalis and Candida can present as a multiple, superficial, painful in the sense external. It can cause external dysuria, so the ulcer may be painful for the individual whenever they pass urine. So here you have to do a Trichomonas vaginalis investigation by taking a wet film from the ulcer. With 1 drop of normal saline, you should look for the presence of Trichomonas vaginalis, a typical pear-shaped organism with a jerky motility. For Candida, you have to do a smear with gram stain or with 1 drop of 10% KOH. Look for the presence of pseudohyphae and spores. So what are the take-home messages? So privacy and confidentiality forms an integral part in the STA diagnosis, and proper history taking, because you can exclude certain non-STA causes when you take a history properly, and you should spend more time in eliciting the history. Detailed sexual history, not only of the patient, always you have to examine all the sexual partners, because we miss this angle always. And complete physical examination from head to foot should be done. Even though
Apologies, Dr. Kalaivani, ma'am. We are 3 minutes from the schedule.
Yeah, I will finish. So primary chancre can present as an erosion in cervix. So always use a pipette to withdraw the serous exudate and look it under dark field microscope. So don't think it is an erosion in cervix. For all genital ulcers, do dark field microscopy, gram stain for chancre, Leishman stain for genital herpes, and a tissue smear to rule out donovonosis. Biopsy is needed only for chronic atypical progressive genital ulcer after ruling out immunosuppressive conditions, and in case of donovonosis to differentiate between the carcinoma. All genital ulcer patients should be screened serologically with blood VDRL followed by specific test and rapid test for HIV after pre-test counseling. In high-risk patients, you have to do blood for HBsAg and anti-HCV in addition to the above test. Thank you. I thank the organizers as well as the chairpersons for giving me the opportunity. Thank you.
Thank you, ma'am, for a very illuminating talk. A wise man once said, knowledge shared is nothing but knowledge squared. With this quote in mind, let us proceed to the panel discussion on the topic of vulvar pain, malignancies, and role of surgeries. I request the Honorable Chairperson, Dr. Vijay Zawar, sir, to kindly introduce the moderator for this panel discussion.
Hello, am I audible?
Yes, sir.
Okay. Thank you, Doctor, for inviting me to introduce and invite my good friend, Dr. Neena Madnani. She is a consultant in PD Hinduja Hospital and Sir HN Hospital at Mumbai. She has been extremely interested in the vulval dermatosis, and she was the first to establish the first vulvar clinic in India. She has published several articles in peer-reviewed journals and chapters in various textbooks. She was initiator and the coordinator of the first special interest group known as female genital diseases in 2018 and 20, and it has achieved a wonderful level of academics throughout the curriculum of the throughout the tenure of her special interest group. She has received several awards and orations, and she has multiple lectures in CMEs across India and abroad on this subject. She has planned and coordinated several CMEs on vulvar diseases for dermatologists and gynecologists conferences. So we have a wonderful faculty today, Dr. Neena Madnani. Please come over the dais and take the charge as moderator for the panel discussion. Over to you, ma'am.
Thank you very much, Dr. Zawar. I'll just start sharing my screen. So good morning, everybody, and happy Ganesh Chaturthi to all of y'all. I am very privileged to be here at this very important conference, e-ASTICON, amongst all the luminaries. And I was very happy to hear the first few lectures by Dr. Somesh Gupta, Dr. Datta, and Dr. Vani, which emphasize what I believe in, that it is very important to diagnose what you're looking at for better patient care. I would like to thank Dr. Bhumesh Kumar and the Telangana team for giving me, and on behalf of my panelists also, to let you know that we are very privileged to be part of this panel discussion. Our panelists are all luminaries, and what I'm happy is they have a passion for vulvar disease. We have Dr. Dhanashri Bhide, Dr. Smita Prabhu, Dr. Kavita Thota, Kavita Raj, and Dr. Nirmala Devi. Dr. Dhanashri Bhide, she is attached at present at KM Hospital and Dinanath Mangeshkar Hospital, Pune. She has a lot of achievements and awards. She was awarded the B.B. Gokhale Award for the first rank in Pune University, authored 7 publications, and her areas of interest are dermatology, clinical dermatology, lasers. She's a scientific committee chairperson of Dermacon 2020 Pune, which was very successful, and president of the Pune chapter of IDVL. And she's a Maharashtra state branch and a member of the present SIG female genital dermatosis. Our next panelist is Dr. Athota Kavita. She is presently affiliated as a dermatologist to Paruchuri Rajaram Memorial Skin and Laser Center, Guntur. She has a number of presentations in many state and national conferences. She has awards and honors and achievements and has won the IDVL Scholarship 2016, the Jignasa Award, Andhra Pradesh, Cuticon 2019 Fulford Derma Foundation Award, and her areas of interest are clinical dermatology, female genital dermatosis, and lasers. Dr. Nirmala Devi is presently affiliated as Professor and HOD in DVL, Tirunelveli Medical College, Tamil Nadu. She has a number of publications and presentations and a number of awards, honors, and achievements. She was the immediate past president of Tamil Nadu IDVL and past secretary 2015-17. Apologies again. She is a PhD guide for the Tamil Nadu University. She has authored 3 chapters in textbooks and presented papers in international conferences like World Hair Research Society meet in Scotland, Edinburgh. She's a member of IDVL and various other associations, and her areas of interest are academics and research, community health services. Dr. Smita Prabhu is Associate Professor, Dermatology and Venereology, Manipal. She's a founding secretary, PDAI convener, IDVL KN, Associated Editor, Coordinator, SIG, Female Genital Dermatosis. Her areas of interest are psychodermatology, female sexual dysfunction, vulvar dermatosis, and clinical dermatology. She has a lot of achievements, authored 90 articles, contributed more than 12 chapters, Associated Editor of Handbook of Psychodermatology, recipient of Research Grant IDVL 2019, and winner of National IDVL Quiz Galderma Award for the Best PG South Zone in 2001. Dr. S.V. Kavita is presently affiliated as an Associate Professor of DVL, Gandhi Medical College Hospital, Hyderabad. She has a number of publications and presentations, and she has been awarded the Best Paper Award in Agra. She was a Joint Secretary, Treasurer, and CC member of TSIA DVL 2021. Her areas of interest is clinical and female dermatology. So our panel discussion today, as requested by Dr. Bhumesh Kumar, is going to be on vulvar pain and vulvodynia, malignancies, surgeries, and inputs from the delegates. I always start with the take-home message first. And the take-home message is all vulvar disease has a diagnosis. And when we make a diagnosis of non-specific vulvitis, it actually is a dustbin term and should be delegated there for eternity. Because these are the patients who do not get well. When you don't bother to do your diagnosis or do the investigations, as Dr. Vani showed us so beautifully in the previous, and Dr. Somesh Gupta also showed us how many investigations are important. We need to thoroughly work up the patient. The panelists have contributed beautiful cases, and we are going to go through all of them. And we hope that you enjoy this panel discussion. So this is the first case. So Dr. Smita, would you like to take it forward?
Yes, ma'am. Thank you, madam. And thank you, organizers. So without much ado, this lady came limping into my OPD, and she had severe pain, couldn't sit or stand. And on history, she said she had these lesions for the past 5 days, which were progressively increasing in pain. And on examination, this is what I saw. She had multiple pustules and vesicles with pseudo hypopyon sign, severe pain, erythema, and edema of the vulva. And we had an initial diagnosis, and there was also vaginal discharge, yellowish purulent vaginal discharge, which was seen pooling outside the vagina. So my first diagnosis was some bacterial infection, perhaps folliculitis and vaginitis. But then I could see a few of the pustules were sort of grouped. So kept diagnosis of herpes simplex, first episode at the back of my mind. History was not conclusive for herpes, recurrent herpes, and husband also had no lesions in history, which we often don't find. So what we did was gram stain culture of the discharge, and we sent for HSV PCR typing also. But on hunch, I started her on amoxicillin 500 QID as well as valacyclovir acyclovir 400 milligram TID. And in 3 days, the report came as Streptococcus galacticiae as well as PCR was positive for HSV1.
Can I stop you there, Dr. Smita?
Yes, ma'am.
Okay. Any other differentials from the other panelists? Dr. Kavita?
Yes, ma'am. Folliculitis and herpes are two. And in pregnancy, in the first, I think it's 11-week pregnancy. Common diagnosis, those two.
Okay. Anyone else, Dr. Dhanashree?
Diagnosis of chancroid also should be considered in view of multiple ulcers, but here they are more or less grouped. So
And they are vesicles. A
vesicles,
lot of
yeah.
them are vesicles.
So herpes and folliculitis would be my differentials here.
Okay. And now, Dr. Nirmala Devi, anything?
Ma'am, good morning. No, ma'am, I still consider herpes only in my first diagnosis.
Okay. How would you manage this case? So two important things: primary, 11 weeks, and also herpes. So, Dr. Smita, how did you manage this case? I think you said valcyclovir.
Yeah, madam, I started her on amoxicillin 500 TID as well as acyclovir 400 TID. She was asked to do saline sitz bath in tolerable warmth of water. And I actually didn't give her painkillers because of her pregnancy, but she improved in 1 or 2 days. Topical also I didn't attempt because the whole area was full of discharge and it was looking wet.
Anyone else has to add anything to the management?
Ma'am,
No?
genital herpes is one condition where the topical 5% acyclovir cream also works.
Okay.
Just as a, I mean, it's not a first line, but as a placebo to the patient because they expect something on topical to be applied always, and they get something like this. And also to avoid superheated infection to restore the flora, we can add the lactobacillus supplements, ma'am.
All right. That's another topic in itself, the lactobacilli, but thank you for bringing it in. And I wanted to know, what is the safety of antivirals in the first trimester? Anyone, any of our panelists?
As such, there is no level of evidence, madam, that as causing any sort of complications in the neonates. So as of today, antiviral seems to be, and especially acyclovir seems to be good in the first trimester. In all trimesters, especially in first, second, it's safe actually.
Yeah,
And it's better to give in the first trimester because it's a primary first attack of herpes.
Supposed to be category B, and there is a large study, Scandinavian study with some 3,000 pregnant women, which didn't show any neonatal side effects or fetal side effects. Though isolated case reports may be there. So it is actually we have to outweigh the benefit and give if needed.
Okay. So is it dangerous for the patient to have the herpes in the first trimester, or is it more dangerous to have it in the second trimester or the third trimester?
Third trimester.
Third trimester.
Because of the outcome of the fetus, right?
Yes.
Okay. So acyclovir studies have shown that acyclovir or valcyclovir is not associated with an increase in birth defects, and limited data exists for famciclovir, and therefore it would not be considered a first-line choice for treatment of herpes during pregnancy. And pregnant women who acquire HSV as a primary infection in the latter half of their pregnancies are at a greater risk for transmission to the neonates. So the reason Dr. Smita Prabhu gave us this case is because if you know that we are talking about vulvar pain. So this is one of the commonest causes of vulvar pain. Can you enumerate, Dr. Nirmala Devi, the other causes of vulvar pain?
Ma'am, other causes with lesions and without lesions, class 5. mostly with lesions we have been here, deliberations, ulcerative diseases, discharges, infections.
Can you
such
speak
things.
a little louder,
But then,
Dr. Nirmala Devi?
ma'am, can you hear, ma'am?
Can you speak a little louder,
Ma'am?
please?
Yeah, I am speaking louder, ma'am. Is it audible?
Okay. It is
Yes,
audible.
ma'am. Now, yeah, the
If you
keloids,
can
the
come
scars in the
closer to the screen or mic, that helps.
yeah. Now is it
We,
okay?
we cannot see your face.
My V
Dr.
is
Nirmala Devi,
on only. I don't know what.
I can see the upper half of your head, not the lower half.
Ma'am, how about now,
Anyway,
Okay,
please
ma'am,
carry
can you
on.
hear me? Yeah.
Very clearly now.
Keloids should in keloids, tendencies, everything. And dynia also include, ma'am. There's something called syndromes.
Anyone wants to add anything? Dr. Kavita?
Contact dermatitis we can think of, madam. Either it could be an irritant or an allergic contact dermatitis, apart from the infections and discharges. And any history of any trauma also can cause pain to it.
All right. Dr. Smita,
Inflammatory
want to add?
disorders like
Dr.
lichen
Kavita,
sclerosis.
yes.
Inflammatory disorders like lichen sclerosis, lichen planus, mostly erosive lichen planus. They also present with vulvar pain.
Okay. Dr. Smita?
Vulvodynia is one like undiagnosed cause in most patients.
Okay, so we'll come to that. Dr. Dhanashree, anything more to add?
Even vulvar malignancies can be painful. They can present as vulvar pain.
And in children, especially sexual abuse or even foreign bodies can give you the vulvar pain.
Yes.
Okay, so now we are going to the next case. Have you all seen acyclovir resistant HSV? I think Dr. Somesh Gupta had mentioned it. Have we, all of us, seen any HSV resistant cases? I have not seen any. I just thought it was very interesting that there are HSV resistant strains. So they should be
Extremely
considered.
rare, ma'am.
Have you seen any?
No, ma'am. No, I have not seen so far in medicine.
Yes, but we
I
must
have
think
seen
of
one.
it.
Yes, ma'am. One case where acyclovir is given for 6 months, and later she continued without advice for 1 year. Still, there are recurrences in the lesions.
So then there is an existence of HSV resistance, of acyclovir resistant HSV, and it should be considered, especially when a patient who has been previously exposed to prolonged acyclovir therapy does not show signs of lesion improvement while on acyclovir, or new lesions appear while being on acyclovir prophylaxis, like Dr. Kavita just mentioned. And also, these patients are treated with cidofovir or foscarnet. So we come to the next case. This was a case of a 45-year-old recently divorced, pain since 10 years. This was my case. On clinical examination, she had a total normal vulva, and her pain was in a stage of 8 out of 10. So how would you proceed with this examination? Dr. Kavita?
Yes, ma'am. First, to rule out the infections, all the causes of the regular causes of vulvar pain, like infections, inflammations, as we already discussed, like common causes, candidiasis, and other bacterial infections, folliculitis, lichen sclerosis, lichen planus, all those causes. And once we rule out everything and we cannot, after exclusion, we can come to a diagnosis of vulvodynia.
So you would examine the patient thoroughly?
Yes, ma'am.
Okay. Dr. Dhanashree?
Yes, madam, I will agree with her. First, I will like to rule out all the known causes before coming to the diagnosis of vulvodynia. And even I would involve gynecologists here to do the proper examination of this patient.
So this is one question I'm asking all of us dermatologists. Do you think it's time we all learned how to do a good per-speculum examination? And how many of the panelists do a per-speculum examination?
I do.
Anyone does? Yes.
do, ma'am.
Who does? I can't see all.
I do, ma'am. Smita.
Smita does.
I do,
Okay.
ma'am.
Kavita does. I do.
Ma'am, many
Yeah.
times, not for now, when we see the normal vulva, we tend to overlook the speculum examination. When there is
No,
a discharge of,
but do you do a speculum examination?
that's what, ma'am. For when
Wait,
there is
no,
a
no.
discharge of ulcer, we
The
generally
question.
try to.
I'm sorry.
We overlook many times.
No, I'm sorry. My question was not clear. My question was, as dermatologists, do we know how to do a post speculum examination, and do we do it when required? That was my question. So
Yes, ma'am.
3 of
We
us
do,
said,
but-
yes, we do.
Yes, ma'am, we do, but not 100% of the times.
But you know how to do it.
Yeah, yes, ma'am. We have been seeing the cases.
Exactly. So the take home message here is, I think it's time all we dermatologists learned the sizes of the speculums and how to use a speculum and how to examine, because a lot of time you don't have your gynecology colleagues around and the patient is not going to come back repeatedly. So it's time we all learned the post speculum examination. Okay. So we said that we are going to examine the patient. So here you can see she's totally normal looking. So you would say, oh, you're very normal. But the very important thing is that we need to open out the vulva. If we don't open out the lips, this is what, when I opened out her lips, I saw. So I purposely said that she was a normal vulva. But when I opened up her lips, what would you see in this? Anyone can describe it? Do you see
Ma'am,
anything unusual?
Yes, ma'am. Fox fordyce spots. I could see lesions like fox fordyce spots on the mucosal side of the labia majora,
Okay.
as well as no, labia minora actually.
Near the fourchette, down near
Yes,
the
ma'am.
fourchette. Okay. Anyone else? What could your differential be here?
There is a slightly raised erythematous flow near the
Correct. That's here. What would
yes,
you?
ma'am, near the posterior commissure.
Yes. What would your differentials be here?
No, ma'am. We have to consider what's the age, ma'am?
She was 40.
Yeah, we have to keep in mind of vulvar intraepithelial neoplasia also in after 35.
Okay.
And then we have to dealt with the deep history, ma'am. History taking is very important.
History is done. History is done. She's divorced. She had a bad sexual history in the sense that she was divorced from her husband since many years now. And this is just a recent occurrence.
Okay, ma'am.
Dr. Dhanashri, any differentials for this?
Maybe irritant or allergic contact dermatitis also, if she is in a habit of using lot of products like maybe a vaginal wash or something
Right,
like
right.
that. But there is erythema also, which is quite evident here in this particular area that you have marked here.
Right.
Are these prominent fordyce spots or they are papillae? I really cannot make out from the picture.
Right. Dr. Smita, anything to add?
You can see the area of erythema, ma'am. So erosive lichen planus or any vulvar intraepithelial neoplasia.
So can you all see these grouped papules here? Can you all see?
Yes.
Which I have circled. Yeah. So two things. One, since this, I just said as she had no problem, so that if we don't find any reason, she is a case of vulvodynia. But here, when we opened her up, there was something. The other differential, which I would like to add, is a HPV, because you can get flat warts which look like this, grouped warts. So that is something else we need to rule out. And also this patient gave a history of lichen planus. She had lichen planus. So what would my next line of management be? Anyone?
It's better to do biopsy, ma'am, first.
Exactly. That's what I was waiting for. So we should do biopsies in any of these lesions which are suspicious and when we have various differentials, because we need to confirm a diagnosis before we go for further management. So vulvar pain can be generalized or localized, provoked or unprovoked. Dr. Kavita, can you tell us about the cotton bud test for checking vulvar pain?
We should ask the patient the spots of her intensity, or where the intensity of the pain is more. And to elicit the pain, we can touch the area of the pain with the cotton bud to examine for the tenderness of the pain, so that we can localize whether it is a clitoridynia, vestibulodynia. And to know the area of the pain, we can do that.
Right. So that is known as the cotton bud test. And you have to ask the patient whether her pain is provoked. That means during intercourse or when she's wearing tight clothes, or unprovoked. That means even if she's doing nothing, the pain is there. And if she can localize the area. What is the management of vulvodynia? Anyone? How would you manage a case of vulvodynia? Suppose you found there's nothing.
Ma'am, basically, ma'am, generally all these patients who have pain syndromes without any organic lesions, generally they may have affective disorders, like to have anxiety or depressive disorders, or there may be some marital problems, which will be leading on to very sensitive. So we need to take history, ma'am. The history taking is very important, very important. And
Very
generally,
important.
I start with mild sedative antidepressants, ma'am. Initially, anxiolytic effect. Antidepressant with an anxiolytic effect. I generally prefer mirtazapine, ma'am, in my patients.
What is the dose?
I start with 7.5 milligram OD, ma'am. After every 2 weeks, like I updose it, depending upon the. Mostly, they will be happy with 15 milligram per day.
Okay. Dr. Dhanashree, anything to add?
Madam, I spend a lot of time in counseling these patients, and I also involve the partner in the counseling process. So when they come and if we just tell them that this is nothing, it is normal and you don't have to worry, then the patient is not satisfied. So you have to accept in front of the patient that you accept that it is kind of a problem that she is facing. Then they are little confident, and then I do use pregabalin also in these patients, starting with a dose of say 75 milligrams and up dose to say 150 milligrams, depending upon how well the patient tolerates it. And I also use this tryptoma 10 milligram to start with and increase it up to 25 milligrams. And locally, if it is provoked, like if it is a intercourse provoked type of vulvodynia, then I ask them to use a anesthetic jelly topical about 15 to 20 minutes before the act.
Very important points. So you, like a panelist said, that it can be, you may need to give antidepressants, anti-anxiolytics, and we also know that there can be a neurogenic pathway. So pre-GABA, tryptoma, very important. And also in addition, what is very important is pelvic floor muscle relaxation exercises. You need to have physiotherapists who know how to teach the patient how to do pelvic floor relaxation exercises. So we've talked about neuropathic pain where we give pre-GABA, gabapentin, and the psychosocial issues, which is the emotional pain, which you give the anxiolytics. So all the above domains, if affected, must be addressed for optimal results. So we come to this case. Dr. Dhanashree, your case, please take over.
So this lady presented with these lesions. The main, she's an elderly lady, about 61-year-old female, and she had these lesions for a very, very long period of time. So since last about 20-25 years, she was having regular lesions. But currently, what she was facing was severe pain in the lesions, and also it was associated with lot of itching, and that is how she presented to the dermatological OPD. Now, her pain and itching was so severe that it was affecting her daily routine, and it was even affecting her sleep. So she was bothered about this because last 20 years when it was not symptomatic, she did not turn up for the treatment. But currently, because of the aggravation of the pain and itching, she was here in the clinic. So looking at it, when I palpated it, when I saw it, there are lesions present on both the labia majora, as you can see here, and it is more marked on the right side as compared to the left side. There are tiny perifollicular cysts that are present on the surface, and on palpation, it was tender. And firm in consistency. So a long-standing lesion which is firm in consistency, tender on palpation, and associated with symptoms of pain and itching. That is what I was dealing with. So considering the consistency, I thought of say a hypertrophic scar or a keloid type of lesion, because it was very, very chronic in nature and it had not affected her otherwise. So her intravaginal and per speculum examinations were within normal limits. So it was limited only to the labia majora. So that
What were your differentials when you saw her?
First one was a scar, a hypertrophic scar or a keloid. That was my first differential. Then I also had thought of conditions like Crohn's disease, which can present like this labial swelling, but she did not have any other knife cut ulcers, or she did not have any other GI symptoms. So metastatic Crohn's was one possibility that was on my mind. Chronic lymphatic swelling like chronic itching, etc., leading to this kind of firm swelling, maybe underlying lichen simplex chronicus, which has led to this. So these are few of the possibilities I thought of. Even hidradenitis suppurativa, but she did not have any nodules. On the left side, we could see few nodules, but there were no sinuses, no discharge. So these were few possibilities that I thought of. Yeah.
Anyone else can add to any differentials, or these were good? Anyone has anything to add?
Filarial and filariasis.
Filariasis is a very important differential to think of.
LGV, lymphogranuloma.
Secondary lymphedema, ma'am.
Yeah, but I think she mentioned,
yes,
she mentioned secondary lymphedemas.
Yes, ma'am. Pseudofolliculitis can leave behind scars, ma'am. But then usually it will be papular, not a continuous.
And it won't be a continuous indurated area like this.
Yeah.
Right.
Post-tuberculosis, ma'am.
Very important. Very important.
Very artificial tuberculosis, post-tuberculosis.
Orange appearance is visible. So I was thinking more in terms of lymphedema. And if there was recent aggravation of pain, we could even have thought of subacute cellulitis.
So excellent differentials, excellent differentials. So Dr. Tanashi, in half a minute, you have to tell us what was the what you did next.
Yeah, we tried the potent topical steroids, and then we also did cryotherapy for this patient. But in say 3 to 4 weeks time, we found that everything remained just the same. We had thought of giving her intralesional injection, but patient was not ready for that. So we referred this patient to plastic surgery. So similar to what we do for earlobe keloids, these plastic surgery people excised it completely, and immediately after excision in the wound itself, they had given intralesional triamcinolone acetonide, and patient is doing quite well as far as the symptoms are concerned, and there is no recurrence. She's been followed up for last 2 years in the plastic surgery OPD. So the results are excellent in this patient.
How, Dr. Danashi, did you look up how common are keloids on the vulva? I have never seen such keloids.
I also had never seen such a keloid before.
Are there any reports?
There are like vulval keloids, there are reports, but not very common. It is very rare. And this was a spontaneous occurrence. There is no history of any previous surgery. But this patient gave a history of keloidal lesions elsewhere on the body actually, after a minor trauma. So that led us to the thought process of a keloid as a diagnosis in this patient actually.
I think you need to publish it. It is really a very good case and you have beautiful pictures. So it needs publication.
Yes, ma'am.
So this is my case of, as Dr. Dhanashi mentioned, Crohn's disease can show you a similar picture. So this was my case of vulvar Crohn's disease. So please also look out for Crohn's disease because it is not as uncommon as we think, metastatic Crohn's disease. Okay, case 4.
Yeah.
Dhanashi, this is your case again. So a minute for the presentation.
Yes, ma'am. So she was a 69 years old female and she had these itchy and painful lesions in the vulval area. So this was a short history, unlike the previous patient. It was only there for 3 to 4 months. So she was with a gynecologist who gave her some topical estrogen creams and a lubricant jelly without any relief, and hence was referred to me. So when I first looked at this patient, I saw that there was a plaque, there was erythema, there was hyperpigmentation, scaling, and few erosions on the surface. So I had thought of two possibilities. One was lichen sclerosus et atropicus, and also I kept in mind the possibility of lichen planus also, because there was a bit of hyperpigmentation and a purplish hue here in the upper part of the plaque. I put her on topical potent steroids for 1 month, but after 1 month, I found that there was no improvement whatsoever. The itching did not decrease, the lesions did not improve, and hence I subjected her to a punch biopsy.
Can you talk about the dermoscopy? You did a dermoscopy?
So we did a dermoscopy. Actually, that time we did not know what we were dealing with, but the dermoscopy then we correlated after we got the histopathology report. And what we saw in the dermoscopic examination was, you can see that there are white dots like things here. Then there are areas where
what do the white dots represent?
One minute, ma'am. And then these thick cords, and there are these clear structureless areas which we could see cloud-like areas. So this is suggestive of kind of extramammary Paget's disease, and these are the openings of the apocrine gland ducts.
And these lines, these bands?
Cords, right? Yeah. So
what are they? What are these representing?
Again, the same, like extramammary, suggestive of, these are the hallmark features of an extramammary Paget's disease.
Okay, and can you describe your biopsy quickly?
Yeah, so the biopsy, the H&E staining showed these Paget cells, which you can see that there are large cells in groups. They have a clear cytoplasm and a large nucleus, forming glandular structures also. And we did a spatial stain, that is cytokeratin 7 stain, which also showed positivity in this particular patient. There are a few more stains that we have advised, but I don't have the follow-up of that because patient is still under evaluation. So the diagnosis was of extramammary Paget's disease, CK7 positivity. And another marker which was done in our setup was HAR2, this thing, but that was also positive in this patient.
So this is a very important case you have contributed to this panel discussion, because it looks like a classic eczema. It looks like an eczematous dermatitis, which you keep treating with steroids. But remember, if it doesn't respond, please do a biopsy, because you'll be surprised of how many cases of extramammary Paget's. I think all of us have seen extramammary Paget's disease, right?
Yeah.
Most of us have seen extramammary Paget's. So it's not that uncommon. It's just that we are not publishing it, but we are all seeing.
So when there is a steroid responsive dermatosis, it responds really fast. Like if you have a diagnosis,
right.
Like so if you don't see any response, don't hesitate, or don't even
take a biopsy.
To take a biopsy. And maybe if you've taken a biopsy and if your patient is not responding, you may do a repeat biopsy, because you might have missed.
Right.
So that important message has to go here, that anything inflammatory or steroid responsive you're suspected but not responded dramatically, always think about
it. Right. What are any of the other members, what are the importance, what is the primary source of this extramammary? Because we have to find out what is the primary source from where these Paget cells are coming. So Smita, can you elaborate?
Mammary Paget's usually ductal, this is there. So any ductal malignancy has to be ruled out. Even internal solid cell malignancies, anything to do with adenomatous cancers have to be ruled out.
Right. Dr. Kavita?
Mostly from rectal malignancies or urinary bladder malignancies. They are the usually common primary sources.
Or it may be a primary source. It may be just the primary, cutaneous.
Cutaneous.
Yeah.
From these.
Dhanashree?
Yeah, so for secondary pages, extramammary pages, these two, that is colorectal and genitourinary, and also we have to examine the
Breast,
patient
exactly.
and do
Yes,
the
ma'am.
mammography, because there may
Exactly.
be a patient may be having not mammary pages, but she may be having a CA breast, and
Correct.
this can be a secondary extramammary pages disease. And
So,
to differentiate between the two, in addition to CK7, CK20 histochemistry staining also should be done, because if it is primary, then CK20 is likely to be negative, and if it is secondary, then CK20 positivity may be seen in the patients.
right. So it's very important to find the primary cause, where it's coming from. So the stains are very important. And also the further investigations, you do an ultrasound of the abdomen, you do a mammogram, you check the bladder, you do the stool for occult blood, you do your urine examination, you do a cystoscopy, you may do a rectoscopy, because you have to find out the primary cause. So we'll just end this thing, because we have a lot of the other cases. So just to tell you, it's a rare, slow-growing cutaneous. Prognosis of patients is usually good, because tumor cells are in the radial growth phase for a prolonged duration, and a majority of cases are treated in the stage of CA and C2. However, once it invades the dermis and becomes invasive, then they have a high metastatic potential. Also, surgery will give you almost a 60% recurrence, because you cannot see the micrometastasis. These are the treatments of chemotherapeutic regimes, and in a very early case you can try imiquimod. We'll end this case because we have more important also cases. So now we come to the malignancies. Dr. Kavita, please take this over quickly.
Yes, ma'am. This is a patient whom I'm following with depigmentation of the vulva. Previously, she is diagnosed as lichen sclerosis, and she comes for follow-up once in a year. And once she came again with recurrence of her pain and pruritus in the vulval area, and I noticed to see this eroded reddish nodular lesion on the left side of the labia. And again, I took a biopsy. Her previous biopsy 3 years back was lichen sclerosis. When I took the biopsy from this particular area, I got to see it as vulval intraepithelial neoplasia differentiated type.
Right. So, Dr. Kavita, can you tell the listeners that when should you biopsy these suspicious? What made you suspect the lesion? So, which are the clinical criteria where you should be doing a biopsy to rule out a malignancy?
When clinically we see either an erosion or an ulcer or any hyperkeratotic lesion, thick and whitish plaque, and on a previously normal or a just depigmented vulva, when we see these clinical criteria, and when there is a continuous pain, a persistent pain in a particular area.
Dr. Nina and team, we are just 5 minutes away from schedule.
Yes, we
You
know
can
that.
continue.
Then
Yes,
we can do
thank
the
you.
biopsy of that area, ma'am.
Right. So it was a squamous cell carcinoma.
Well, yes, ma'am.
So the clues, like Dr. Kavita said, and the incidence of differentiate when in untreated lichen sclerosis is about 4 to 7%. And treatment, yeah, this is very important. That clobetasol propionate is the gold standard for treatment. I won't go more in detail, and is also safe in children. And the non-steroidal are pimecrolimus and tacrolimus. And on unresponsive areas, you can also, after ruling out a malignancy, do intralesional triamcinolone. Okay. So this is another case where we are talking about surgery. So this was a case of lichen planus, of mucosal lichen planus, which was operated, and she was sent to me 3 weeks after surgery in order to prevent the fusion again. So this was lysed, and she even in 3 weeks, even giving her treatment, it fused again. So here what I wanted to emphasize is that lichen planus is a very destructive disorder, and surgery is very specialized. And this patient had undergone surgery when her lichen planus was very active. It was not being treated, so you cannot do surgery for a lichen planus which is active, because it's going to fuse. So this was a quick take-home message. I'll take you to the next. So I think this is Dr. Nirmala Devi, quickly.
Dr. Kavita, madam.
Oh, Dr. Kavita, sorry.
Yeah,
Yeah.
next case,
It's actually a
in 1
77
minute.
years. Yeah. The 77 years old female madam, which she was kept because she was having really a persistent pain always for the past few years. So she was also being treated for the E. coli infection, and she was repeatedly kept on antibiotic therapy for maybe more than 6 months. And she was also using estrogen, topical estrogen cream for that burning sensation which she was being complaining. So she was using this estrogen cream weekly twice for the past 2 years. So when she has come just 10 days back, when she has come, I've just seen this curdy white precipitate sort of thing. So when usually I thought initially, like, because it was really painful, so I just treated her like thinking it as cutaneous VVC, vulvovaginal candidiasis. So yesterday when I happened to see her, when I discussed with our Kavita madam also, like there was an underlying sclerosing sort of thing, like lichen sclerosis. So
She has an underlying lichen sclerosis, which
Yeah.
is very evident.
Yes, madam.
So
presently she's been given her antifungal therapy.
Okay.
And I advised her to go with sitz bath.
Okay. So this is just to the panelists. How common is candidiasis in a postmenopausal? Smita? Yeah, whoever said it, ma'am, please.
Ma'am, I'm Dr. Nirmala.
Sorry, yeah, I can't see you. Yeah.
Yeah, secondary candidiasis is very common, ma'am.
In postmenopausal?
Ma'am, this any damage to the epithelium predisposes to opportunistic fungal infections. But then even the appearance of LSA itself, because of its appearance, it mimics candidiasis. That's what I have found many times. It's not true candidiasis.
Usually candidiasis is rare in postmenopausal.
Kavita?
Yes, ma'am. this is
But then they apply something and come, ma'am. Usually, they irritate the skin. They try some native treatment or GP.
In
Dr.
postmenopausal, candidiasis is less common, ma'am, because of due to the low estrogen. Unless they are severe diabetics, occasionally we can see it. Otherwise, it is less common compared to the before 40 or 50, 40 age group.
Exactly. So in a postmenopausal, you will not see candidiasis because of the pH is very high, and that does not support the growth in this patient. Possibly why she developed candidiasis, because she was using estrogen, and that must have reduced the pH.
Yes.
Also, because a patient has lichen sclerosis, a lot of time when we are giving them topical steroids,
Yes,
they
yes,
can
ma'am,
get
that's what-
super added. But the take-home messages in a menopausal, that's why I put this case. In a menopausal woman, to diagnose candidiasis, you better be very, very sure of your diagnosis, because it is not a common diagnosis. We randomly are giving fluconazole for everything which is itchy. But in a postmenopausal, please do not think of candidiasis unless you are sure of what is the primary event which contributed to it. And like Dr. Kavita said, diabetes is one of the very predisposing factors, and I have seen with steroids. Okay, this is the last, very fun. Nirmala Devi, in 1 minute we have.
Yes, ma'am. This
Yeah.
lady was a 42-year-old female who had attended our OP few years back with just a warty kind of protuberant papillary growths along the labia majora, and then she had discharge from the vagina
Also on the perianal area.
This is actually the perianal lesion came after 6 months, ma'am. When she came initially, she didn't have any other lesion.
Okay.
So she was referred to the sexual STA clinic. So there they investigated with the RPR and the TPH and everything. But then the test came out negative. But then she was lost to her follow-up after that. Maybe she would have gone to a GP, I think. She had a resolution. So generally the GPs, they use steroids, the Dexa and
And what was your diagnosis finally?
Then after 6 months, she came with oral and as well as perianal erosions. That time we could able to do the biopsy and made the diagnosis of pemphigus. It was the differential diagnosis was actually again we should include SJS also, Steven Johnson syndrome,
Right.
as well as this one. So the biopsy gave us the clue. There was eosinophilic abscess in the epidermis, and then DIF was done, and there was a intracellular
Sorry.
immunofluorescence.
Sorry.
Okay, so she was managed like other pemphigus vegetans, ma'am. Very rarely, in about 2 to 5% of patients, it can involve the genital organs. Pemphigus
Right.
vegetans can involve the genital. It's a rare case, ma'am. We
And
also
very
presented it in
rare.
the. Yes,
And your
ma'am. We also
differential was also, I think, condyloma lata was your
yeah.
differential.
Initially, first time when we entertained, it was condyloma lata. The clue is lata is actually condyloma lata also we included. That's why we referred her to the STA clinic in the initial period. but not in the second visit, ma'am, after 6 months. That time, because of the
Okay.
erosions and painful erosions, we were
All
clear.
right, all right.
Mm.
So I'm thank you very much, my esteemed panelists, for your lovely inputs. I'm sorry the time is up, otherwise we could have gone on and on. And thank you, organizers, for giving us this opportunity. And I think on behalf of the panelists also, we have enjoyed doing this panel discussion. And I thank the panelists for giving us such excellent cases and the organizers for giving us this opportunity. Thank you.
Thank you, ma'am. Thank you, ma'am, for
sir.
all the
Thank
nice
you,
views.
ma'am. Thank you, sir.
Thank you, ma'am. That was an amazing session. I would like to conclude this by
Manogna,
quoting
wait.
Dr. Oliver Wendell Holmes.
Manogna,
Sir,
yeah, thank you.
so
So
like-
now we'll move on to the postgraduate quiz. So which is one of the innovative in e-ASTICON. So I invite the quiz master of this session, Dr. V. Manogna. So she's the budding dermatologist from Hyderabad. I request Dr. Manogna to proceed for the quiz.
Thank you, sir. Thank you for your kind introduction. So now we begin the first session of the quiz, which all of us are looking forward to. And first, I would like to tell the postgraduates that the link for the quiz is provided in the left of the conference screen. And the entry is only for postgraduates and PLMs. And here is a brief introduction to the rules of the quiz. Each session will have 10 MCQ questions. One correct answer has to be marked for each question. And the first 3 toppers in all the sessions together will be selected for the first, second, and third prizes. And the duration of time is 5 minutes for the quiz. And postgraduates will later have to submit the bona fide certificate if they win the prize. And please do not refresh or close the browser during the quiz. And all the very best to all the participants of the quiz. And there are some very, very attractive and useful prizes at stake here. So all the best. I request the postgraduates to kindly start taking the quiz. Now, simultaneously, I take this opportunity to request our organizing secretary, Dr. Bhumesh sir, to take over the proceedings for the felicitation of all the speakers, chairpersons, and panelists for this discussion.
Yeah, Manogna, you carry on. You request the chairperson to felicitate the speakers, moderators, and panelists.
Okay, sir. I request our honorable chairperson, Dr. R.N. Datta sir, Dr. Chandragupta sir, and Dr. Vijay Zawar sir, to kindly felicitate the speakers for the session. The first speaker, Dr. JVDS sir. Thank you very much, sir. That was a very, very unusual and beautiful ceremony, sir. Thank you very much.
Yeah, thank you, Dr. Manogna. So really, it was a wonderful session. So thank you very much for all the faculties, the nicely conducted with the maintaining time. So now we'll move on to another important session. That's male genital dermatosis. For this, I invite the session coordinator, Dr. S.B. Kavita. So please go ahead with your talk.
A pleasant good morning to all the e-ASTICON 21 organizing committee members and all the delegates who are participating today. And the theme for today, Man Ki Baat Dr. Ke Saath of STIs and AIDS. So the second session is going to start now, which is mostly on male genital dermatosis. And the chairpersons for this session are Dr. Rajiv Sridharan sir, Dr. Vineet Rilhan, Dr. N. Ramesh sir. So kindly take your seat, sir. I now request Dr. Rajiv Sridharan sir. Kindly display the sir's CV, please. So Dr. Rajiv Sridharan sir, he is the Vice Principal and HOD Dermatology, who has publications of around 24 with 20 presentations, and he is the President of IDVL Kerala, for which he received Best Branch Award, and he has actually he's an IDVL President Appreciation Award in 2018, and he's also IDVL Academy member and Damagyan coordinator in the year 2017. And his areas of interest are in the field of clinical dermatology as well as in venereology. Dr. Vineet Rilhan sir, Dr. N. Ramesh sir, he is the President-elect of IDVL Telangana 2021, and he is the Chief Staff Surgeon and PHOD of Central Hospital, South Central Railway in Hyderabad. Dr. Vineet Rilhan sir, he is actually a professor of Maulana Azad Medical College. He has a lot of publications and presentations, and the awards and honors and achievements. He is the National President of IDVL, and he received IDVL Appreciation Award in 2015. And he is an organizing president of North India and PGCon 2017. And his areas of interest are in the field of clinical dermatology of STIs and dermatosurgery. I kindly request our chairpersons to introduce our speakers. Dr. Sumati Muralidharan, the first speaker of this session.
Thank you, Dr. Kavita, for those nice words of introduction. And on behalf of all the three chairpersons, I take this opportunity to thank Team Telangana, especially Dr. Bhumesh, for giving us this opportunity and for this wonderful conference. I had the pleasure of introducing the first speaker, Dr. Sumati Muralidharan. Basically, she is a microbiologist and also did her diploma in STD AIDS from Bangkok, Thailand. She's a professor and consultant microbiologist, presently working in VMCCM Saptajang Hospital. She is a nodal officer for State Referral Laboratory. She is a member of many technical teams and editor of South Asian edition of the textbook of microbiology. So we are going to have the first speaker speaking to us today. Over to you, madam. The floor is yours.
Thank you, sir. I'm sorry I couldn't get this background of the e-ASTICON in my system. Yeah. Good morning, everybody. I bring you greetings.
Ma'am, switch to a slideshow.
Yeah, I have. Yeah. Is it okay now?
Yeah. Yes, yes.
Yeah, good morning, everybody. I bring you greetings from the Vardhaman Mahavir Medical College and Saptajang Hospital in New Delhi, where I work as a professor and consultant microbiologist. And at the outset, I'm thankful to the chairpersons for inviting me to speak today. And I'm extremely thankful to the organizers for inviting me to speak at this mega event, which has been beautifully organized. And another round of thanks is for the important topic that's been given to me, the importance of investigations to detect extragenital STIs, which is an oft neglected topic. Now, what are extragenital STIs? These are nothing but sexually transmitted infections which are manifest beyond the genital tract. And when we say beyond the genital tract, what does it include? The genital tract includes mostly the urethra, cervix, and vagina in females and the urethra in males. So beyond anything that is beyond the genital tract is considered extragenital. For example, rectum and pharynx, which are most common, But apart from that, you can have the conjunctiva, the lymph nodes, that is the bubo, skin lesions, etc. Apart from this, there are some diseases which are sexually transmitted, such as hepatitis A, B, C, and HPV infections, which are sexually transmitted, but they manifest in other parts of the body. So the importance of these extragenital STIs are that they serve as hidden reservoirs because they often go undetected, and yet they play a very critical role in STI transmission and also in HIV infections. Apart from that, optimal screening strategies for these infections are usually deficient in most labs, and they have implications beyond the STI because a person with an extragenital lesion would often go to maybe a general practitioner or somebody else and waste their time that way and then come to the STI clinics. It could be misdiagnosed, and here the laboratories play a very important role. And another important aspect is that the treatment for these extragenital STIs may be different from genital STIs. There are two examples I have cited here. Studies have shown that the pharyngeal gonococcus, gonorrhea, I use the word GC for gonorrhea and CT for chlamydia trachomatis, that is chlamydiasis. So pharyngeal gonorrhea is said to be better treated with ceftriaxone injections rather than oral cefixime, which is usually done for the genital gonorrhea. And for rectal chlamydiasis, doxycycline is said to be far better than azithromycin. So studies have shown this. So the treatment could be different in an extragenital STI. That makes it very important to diagnose them. And they are increasingly occurring in some key populations and high-risk groups. And more importantly, the antimicrobial resistant isolates are more common among these infections. So for all of us as healthcare providers, if we are screening and testing only the genital sites for these infections, then we must know that we will be missing about 73.8% of pharyngeal gonorrhea, 71.8% of rectal gonorrhea, and about 88.3% of rectal chlamydiasis, which is very significant. Now, coming to the global scenario, a few words about what the scene is like about in the extragenital STIs. So GC and CT are on the rise, especially among the MSMs, as per a CDC analysis in 2019. And 92% of pharyngeal gonorrhea is asymptomatic, and so also about 84 to 86% of rectal gonorrhea is asymptomatic. And rectal gonorrhea, the incidence is about 0.6 to 35.8%, and the range for pharyngeal gonorrhea is 0 to 29%. Rectal chlamydiasis 2 to 77.3%, that's a wide range, and pharyngeal chlamydiasis 0.2 to 3.2%. And it's also known from studies that in men, only 14% of chlamydiasis are symptomatic, and only about 40% of gonorrhea are symptomatic, which means there is a large chunk of asymptomatic infections which we have to catch. And another important finding is that 30% of symptomatic gonococcal urethritis is attributed to oropharyngeal exposure. So what do? We have to screen for the extragenital STIs. So how do we screen? Screening means testing for STIs at specific sites of sexual contact. It is often the butt and the throat, that is the rectum and the throat, but it could be any other site also. And there is now a growing need for routine extragenital screening, which we have started in our department also about a year now. And screening of key populations is also very important. But there are several barriers to these screening. Patient-related barriers, such as patients may want frequent, convenient, and affordable testing, which have to be arranged for. And provider-related issues include the knowledge, time, and comfort of the provider, that is the clinicians, because they have to elicit a complete sexual history and perform a thorough and complete physical examination to detect these extragenital sites. And also system barriers such as the cost of testing and some of the laboratory issues like the NATs and the kits which may not be approved. So you have to do a validation of the tests before you apply them for diagnosis. So lab diagnosis of extragenital STIs, what are the facilities available to us? CDC recommends that most of these should be tested by NAT. NAT is nucleic acid amplification tests. So these are the ones which are more sensitive, and they are specific also. And many of them are now FDA approved. That is, you have FDA approved kits for many of the extragenital STIs. Sorry, the genital STIs like gonorrhea and chlamydia, you do have a lot of FDA approved kits, but for extragenital sites, they were not approved. But the good news is that as of May 23, 2019, the FDA has cleared 2 kits which are for NAT testing of gonorrhea and chlamydia from extragenital sites, that is from pharynx and rectum. So this is just a list of all the kits that are available for the NAT testing of CT and NG. So we also have the POCTs now, that is the point of care tests. You know, now all the clinicians as well as patients, everybody wants quick results. Sample in, result out. That's how they want it. So the laboratory and research has provided these point of care tests where the results are available very quickly. That is in a matter of about 20 to 30 minutes. And most of these kits are pretty specific and sensitive too. And the other big advantage is that many of these kits can be used for multiple STI diagnosis. So for example, you have kits which can detect CT, NG, TB, that is Trichomonas vaginalis, and Mycoplasma, all of them in one kit. So this is the advantage of the POCTs, and we have several of them in the pipeline now. So what are the samples to be collected for extragenital STIs? The anorectal swabs, oropharyngeal swabs, urine first voided, conjunctival swab, and material from the buboes or the lymph nodes, and other extragenital lesions such as the skin lesions, etc. So coming specifically to certain STIs which are important. In gonorrhea, you must remember the oropharynx is a very critical site for the emergence of antimicrobial resistant Neisseria gonorrhoeae. And also when you are testing the extragenital sites in men and women both, remember the gram stain is not recommended for pharyngeal and rectal sites for obvious reasons because of the commensals. So routine screening should usually include only the NAT, that is the nucleic acid amplification tests. When it comes to chlamydia trachomatis, in women, extragenital sites are not done routinely. It is still not a rule to test. And whereas in men, extragenital sites are being tested, especially in high-risk groups. And they have found that the self-collected swabs are as good as the clinician-collected swabs. So that is a very important thing, and which makes it easier for the diagnosis. And for a lymphogranuloma venereum, diagnosis is usually based on clinical suspicion or local epidemiological data, or by ruling out other STIs. But here again, extragenital sites can be involved. So anogenital swabs can be taken, or lymph node specimens. And what you can do with this for diagnosis is culture, direct immunofluorescence, or you can use the NAT. NAT is to be preferred now for detecting this. But please remember, most of the commercial NATs, they do not identify the chlamydia trachomatis of L1, L2, L3. That is the ones causing LGV. So you have to have a NAT which is specific for LGV. Now you do have real-time quadriplex PCR-based assays where LGV can be diagnosed. But unfortunately, these are not yet FDA approved. So this is just to summarize the tests that are used for chlamydial detection. So of all the tests, you can see that NAT, that is nucleic acid tests, are the most, are the best, and they are the most sensitive. So for syphilis, since I'm dealing with the extragenital lesions, in primary syphilis, you can get the chancre on extragenital sites like the fingers or the oral lesions. In secondary syphilis, you can get the rash on the body, any part of the body. And you could also get the condyloma lata in the folds of the anus, gluteal region, gluteal folds, anus, and other non-genital sites. As far as chancroid is concerned, especially in persons with HIV, extragenital involvement is quite common here. It could involve the thigh, the anus, abdomen, hands, breast, mouth, etc. And the definitive diagnosis here in chancroid is by culture. You use specialized media for culture because there are no FDA-approved PCR tests available for H. ducreyi as of now. But believe me, culture again is very difficult because we have been doing it in our laboratory, culture for chancroid using the specialized media for over about 18 years, and the results are not really that promising. I mean, we've not got much of a success here. It is difficult because culture itself is even said to be just 50% or less sensitivity. And as far as HSV is concerned, earlier we used to conventionally say that HSV1 causes lesions above the belt and HSV2 below the belt. But now we do know that both HSV1 and 2 can cause genital infections and lesions anywhere.
Dr. Sumati, we are 3 minutes away from schedule.
Yeah. So the extragenital lesions can occur elsewhere. So the DNA PCR is the one to be tested for this. For HPV, again, extragenital lesions could be anal specimens. And in HIV, you should screen for all diseases, all STIs at extragenital sites. So some of the high-risk groups, like CDC has recommended that MSM is a high-risk group. So here, apart from clinic attendees, you have to test in asymptomatic extragenital STDs in MSM groups. And these are the sites you have to test: pharyngeal, rectal for GT as well as for CT. And here they have given a very good format where it says it's a self-testing format for MSMs, which could be adopted by other countries, where it says, do you provide oral sex? If yes, please swab your throat. And if you're an insertive partner in anal sex or oral sex, give your urine sample. And if you are a receiving partner in anal sex, you give your swab, rectal swab. So, and these are all for self-testing. It's all pictorially demonstrated and extremely clear. Transgenders, again, we must remember that their anatomy and sexual practices are very important to take into account, because even if it's a transgender male, they could have a vagina, cervix, etc., and have infections. So if the person is on pre-exposure prophylaxis for HIV, again, extragenital screening should be done in high-risk groups at least once in 3 months. So what about the ladies? We shouldn't forget that women also can have extragenital STIs, especially because they are oral and anal receptive intercourse they do indulge in. And these are not usually recommended as of now, but they should be thought of. And we have to ask the history. And if they are at risk, one has to perform tests for them also. And please do not forget partner notification and rescreening and retesting after the treatment. This again is important. Here, expedited partner therapy is being followed in some states in USA, where they give the treatment to the partners even without their presence. But of course, there are repercussions to this, but it has prevented recurrent chlamydial and gonococcal infections. Now, since I'm from the laboratory, a few words on the laboratory. Diagnostics and laboratories are often undervalued, and they are as important as the medicines and vaccines given. And a large proportion of these extragenital infections are asymptomatic. So that's where the laboratory comes into play, because screening and early diagnosis is very important. And for this, we have a whole lot of point of care tests for you to use, which can be done in patient single visit, and as well as it can be helpful in surveillance purposes, and it can be used in all levels of the healthcare system. So that is the importance of the laboratory for these, especially extragenital infections. So make extragenital testing a priority and take good charge, and that is at least 3 sites: rectal, pharyngeal, and apart from your genital sites, we have to do it at least annually or once in 3 months or 6 months if indicated in high-risk groups. So that's my message for you. Thank you for your attention, and thank you to the organizers for giving me this opportunity again. Thank you very much.
Thank you so much, ma'am, for enlightening us on this topic on the investigations to detect extragenital STIs. It was really an excellent session. I now request Dr. Vineet Relhan sir to introduce our next speaker, Dr. G. Narasimha Neta sir, who speaks on circumcision, boon or bane.
Yeah, good morning to all of you. At the outset, I want to place on record my thanks to Team e-ASTICON for making me a part of this prestigious event. And the next speaker is Dr. G. Narasimha Neta. Sir is a professor and HOD at Gandhi Medical College, Secunderabad. Sir has 13 publications and 20 presentations. He was a past president of Telangana State Branch, 2019. Sir was former secretary of Telangana State Branch 2016, and the areas of interest are dermatosurgery. In the next 15 minutes, sir would be talking about a very important topic, circumcision, a bane or wound. Over to you, Dr. Netha, sir. Hello. Please share your screen, sir.
Vinirji is sharing.
Okay, sir. Okay.
Netha sir, unmute yourself. Unmute yourself. ముందు ఓపెన్ చేసుకొని పెట్టుకోవాను.
Thank you for kind words. I have been given to talk on circumcision, bone or bane. On regarding the circumcision, as you all know, male circumcision taken from a Latin word, that is circumcidere, that mean by to cut around. It is defined as the surgical removal of the foreskin from the human penis. You can see the normal penis with foreskin. In divide of the foreskin in the circumcised penis, you can observe here. Regarding the prevalence of the circumcision, as per the WHO estimated in 2007, they says that around 1/3 of the global population has been circumcised. So that prevalence, we can understand how much it is been done circumcision. So regarding the history of the circumcision, this procedure has been practiced by the ancient Egyptians, then by certain religious groups like Jews and Muslims. You can see a photograph here. In Jews, circumcision is a part of the Brit Milah ritual to be performed by the specialist ritual circumcisers, they are called Mohel, on the day of the 8th day of the newborn child. It is also called Ketan. It is practiced nearly universally by the Muslim males. For Muslims, circumcision is a matter of cleanliness, purification, control over one's baser self, nafs. You can see the photograph here. If you talk about the indications of the circumcision, as a routine indications, as you all know, really on the basis of the religious beliefs, in medical indications like phimosis, melanocytitis, in recurrent urinary tract infections, and also indicated in limited HPV, HSV conditions. Also, as part of the treatment in vesico-urethral reflex, neonatal hydronephrosis, and the posterior urethral valve conditions. And also indicated in paraphimosis, in case of tear, when the sexual intercourse leads to severe bleeding, those conditions also requires for the circumcision, and melanocytitis, recurrent melanocytitis, those conditions is need to be go for the circumcision. Regarding the contraindications for circumcision, any genital structure abnormalities, anatomical abnormalities like hypospadiasis, epispadiasis, and ambiguous genitalia, these conditions will never be done any circumcision on the penis. Technique of the circumcision, it is a simple basic removal of the foreskin. In that can be done in neonates, infants, adults, adolescents, and old males population. Regarding the discussion of the doing in infants, certain devices has been practiced by using the Gamco clamp, last bell, and the Gogan clamp is commonly being used in the USA. This is all of you know, circumcision is being done by the some trained persons in as well as by the urologist, in general by general surgeon, and who is trained for the circumcision. Technique of the circumcision. First thing you have to see the how much skin to be removed, you have to assess. Then inner lining of the foreskin is separated from the glands. Then the foreskin of the remaining skin part is removed and stitches and given to the mucosa from the skin. To see for the bleeding should not be taken place. Hemostasis must be maintained. Certain centers they used to practice certain procedure called the plastibell technique. In that plastibell technique, what they used to do is dorsal slit they make on the dorsum of the penis and separate the foreskin and keep the plastibell instrument over the glans penis and tie it over the foreskin over that, and the excess skin is trimmed off and leave it for 3 days that fallen off. That is the procedure being practiced in some centers. What is the bone due to the circumcision? We have to understand. As per the study says, HIV infection risks by male who is practicing heterosexual sex can be is reduced by around 50% of the occurrence of the risk of the HIV infection. We can dramatically change, we can observe after the circumcision. Regarding the risk of recurrent urinary tract infections in the first year of life in male infants can be drastically reduced. In a circumcised male, you can see photograph here. Estimated in uncircumcised male is 14 out of 1,000 infants, whereas in estimated 2 in per 1,000 in circumcised male infants. Circumcision decreases the incidence of febrile UTI, urinary tract infection, especially in the first 6 months of the life. Neonatal male circumcision has been proved prevention of infant urinary tract infections like in the form of myotitis, pyelonephritis, phimosis, and protection from the viral STI and other form of the STI. The protection effect of the childhood or adolescents circumcision is definitely protective effect in the invasive penile cancer by the form of protecting from preventing the phimosis of the penis. Increased risk of cancer is related to phimosis, which can be the result of poor penile hygiene, as we all know that. It reduces the incidence of penile cancer indirectly by decreasing the chance of phimosis. The risk factor for penile cancer is phimosis, as we all know. Neonatal circumcision is more protective against penile cancer compared to circumcision performed at an older age group. Male circumcision has been shown to reduce the risk of other STIs, that is, has been proved. 2 trials demonstrated reduces the risk of acquiring genital herpes by 28 to 34%. And the risk of developing genital ulcerations by 47%. The other trials found reduces the risk of oncogenic high-risk human papillomavirus by 32 to 35%. The risk of bacterial vaginosis was reduced by 40%. The risk of trichomoniasis was reduced by 48%. The neonatal male circumcision in United States, they projected and highlighted that increased quality adjusted life years and cost saving due to reduced HIV infections and the treatment costs. The circumcised men reported increased penile sensitivity, and enhanced ease of reaching the orgasm. Another study says 97% of female partners reported either no change or improved sexual satisfaction with male partner who has been circumcised. Pain due to circumcision, I would like to emphasize. Some people believe foreskin serves as a vital purpose and protects to the penis altogether. Several problems we can discuss. They emphasize that foreskin is a very sensitive, and after removal, it leads to decrease in sensitivity near the tip of the penis. So this could affect the man's overall sexual satisfaction. As we all know, any surgical procedure may give some sort of complications like urethral stricture may be encountered. They presume that, they say that removal of the foreskin may lead to irritation of the tip of the penis, may ultimately lead to urethral stricture. They depend like that. Surgical complications. Any surgery may lead to some sort of complications may encountered that we have to prepare and give the treatment appropriately. In this case, circumcision, we can encounter urinary retention is a common problem due to the pain after the surgical procedure. And bleeding and infection is a common. This has been occurred 1 in 10 to 1 in 50 of the chances of the cases. And also due to poor technique may develop urethral injury, leads to concealed penis, phimosis, and urethra may occur rarely, urethroputaneous fistulas, and excessive skin removal may happen due to poor technique, may rarely seen inclusion cysts, and very rarely hypertrophic scar or keloid formation may encounter. All these complications can be minimized to less than 1% by doing trained practitioners and by following the sterile settings, and with proper follow-up, we can minimize up to the less than 1% of the complications. Some anecdotal report says that male circumcision.
Dr. Netha, we are 3 minutes away from schedule.
Male circumcision can cause sexual dysfunction. Take-home message: circumcision induces the chance of acquiring transmission of HIV and other sexual transmitted infections. Neonatal circumcision has been shown to have a protective effect against UTI, especially in the first 6 months of life. This is considered as an act of hygienic practice. So it has few cons like reduced sexual pleasure and lack of protection to glans penis and injury to meatal opening. It is considered as a boon, but not definitely a bane. With this, I conclude. Thank you, one and all. Thank you very much.
Thank you so much, sir, for throwing light on the circumcision. It's definitely a boon, but not a bane. I now request our chairperson, Dr. N. Ramesh, sir, to introduce our moderator, Dr. Rajiv Singh, sir, for the panel discussion. Topic: tips and tricks in the management of non-STIs and STI.
Good morning and greetings to all the delegates. Dr. Rajiv Singh has been very active in Telangana state dermatology activities, and he has been a very sincere and dedicated member of the community, very seriously involved in effective transmission of knowledge in the management of DBL, particularly to the postgraduate students and the junior practitioners. So he is right now the professor at our department in Usmania Medical College. He has several publications to his credit, and he awards and honors he has received plenty in the last 6 years since the Telangana state was separated from combined state. And he had also served the TS IIDL as Honorary General Secretary in 2018-19. So his areas of interest include dermatosurgery. Now I request Dr. T. Rajiv Singh to go ahead with his moderation. Over to Dr. T.
Thank you, Dr. Ramesh sir. You have been kind enough in speaking a few words as regards me. Yes, I was truly involved with Telangana activities right through from the inception of Telangana, which got alienated from erstwhile AP state. I thank my organizing chairman, Dr. Narasimha Rao Neta sir, Bhumesh Kumar, my colleague, Venkatrana sir, my professor, P. Narasimha Rao sir, my scientific chairperson of this organizing committee, along with myself, having tipped me for this trickish male dermatosis chapter. And I welcome Dr. Jaydev Betkarur sir, who is now the present national president. I know sir is very busy. Just now I have seen that in the ascent he has given his presidential speech and has come back. He has all this to his credentials, Jaydev Betkarur. Very sincere, very sincere, very hardworking personality. Thanks sir to be with us with this Telangana e-ASTICON organizing committee as a panelist in my panel. Thank you, Thapa sir. Thapa sir is well known all over nation. He's a national figure, and thank you, sir. He has his credentials, which is displayed here. Thapa sir has been all along good. Rashmikant Shah sir is a private practitioner at Mumbai and a very eminent dermatovenereologist. Has been the display is on for all of you. He has been 10. Yeah. Then Ilangavan sir, yesterday he was very busy in that Kerala Kyoticon, and then sir called me yesterday that I am busy. Raj, what is the schedule? Let me tell you, this is all an open discussion. It is a thrilling discussion. It will be an open discussion. These panelists, this Sivaram Reddy sir has been so simple. See, one sentence will picturize him that he is a very simple and a modest person. Right through, he was my colleague in Osmania Medical College. He was senior to me as an associate professor. Now I have moved on Padma. This is my colleague as well in Gandhi Medical College. I welcome all the people herein to concentrate on this. Now the panelists will discuss on this issue of 21-year-old male patient, known case of RVD. Since 8 years of age came with these lesions, patient denied any sexual activity. What would be the provisional diagnosis and what would be the differential diagnosis in this situation of a very thrilling picture? I request all to concentrate on this, because this is not a tailor-made, please. It is for the first time that the panelists are seeing, and that's an open discussion.
Sir, I think it could be molluscum or something like cryptococcal infection generalized, or probably histoplasmosis.
Excellent,
this could be one of the few. And this patient could be possibly immunocompromised. His HIV test has been done or not, I do not know, but that could be. Adult patient with molluscum is unusual.
True, sir. Yes. Sivaram Reddy, sir.
The site of lesions look like molluscum contagiosum. Probably he's an immunocompromised patient. If some more history can, I
good,
think,
sir. We'll project shortly. As of now, this picture depicts these two things. One is molluscum contagion, the other lesion on the shaft of the penis, sir. If you people can concentrate.
That is, HPV infection. It looks like genital wart.
Yes, sir. Yes. Anything more, sir? Yes, sir.
Because patient is on antiretroviral therapy and immunocompromised.
Correct.
I think the morphological picture is changed.
Yes, Sivaram Reddy, sir. Now please see the other part. Patient was on irregular treatment with ART. Started taking ART. Yes, sir. Yes, sir.
Sometimes both lesions can be there, Dr. Raju.
Yes. Bhumesh, could you please move the slide further, please? Up.
Rajiv, I don't know how long the disease has been there.
Correct.
Both the conditions have been there for 8 years, or one?
Correct, sir. When he was at he acquired this infection when he was 8 years age, and then
8 years of age.
Of late, they started only after having used ART. These lesions cropped up.
Correct.
patient.
So, no. Which of these, the lesions on the shaft came first or the lesions on the thighs?
Simultaneously, he says. Simultaneously, he says.
At the age of 8 years.
8
that
years,
means he's
yes.
been having it for last
2 months.
15 years.
Yes, 2 to 3 months he had. Once he started ART, then subsequent to 1 month of having taken ART.
No. I'm not getting this. You say he is since 8 years of age. That means he has been having it for the last
RVD, correct. He was
15
positive
years.
when he was 8 years of age.
Okay, but the lesions are only 2 to 3 months.
He was on irregular treatment. This very clearly written, sir. Patient was on irregular treatment with ART and started taking ART continuously for the past 2 months.
Okay. The lesions are only for 3 months.
Yes, sir.
All the lesions.
Yes, sir.
Sir, can I interfere? I'm Dr. Ilango.
Yes, sir. Please.
Yeah. The thing is, the lesions are the past 3 months after starting the ART continuously.
Correct.
Yeah, then that situation.
That's what I wanted.
The subclinical.
Yes, sir. Truly. Yes.
Subclinical has become clinical, and we have got the lesions like this. Most probably, iris may be the reason.
Correct. Perfect, sir. True. You have hit the
That's
right.
what I was thinking about. Iris.
Yes, sir. But Karur, sir, yes.
My question is whether the HIV infection has been acquired congenitally.
No, not congenital. He is not clear about that. He says he was diagnosed when he was at the age of 8 years. He was diagnosed of having a HIV disease. That's what he said when he came.
Sexual assault at the childhood.
No, sir. Never he uttered anything of that sort. He said, I just acquired infection this way. That's all. And I was diagnosed with this. He never said that I had any history of exposure and all. Never. We tried to find that fact, but he never revealed that. But incidentally diagnosed as positive.
No point in inquiring the 8-year
blood transfusion.
Possible.
Not sure, sir, but that is how he came to the OPD.
So in children, we always expect sexual assault. It might have happened 3 years or 4 years.
Maybe true, sir. Yes, it is very open. It is an open fact that must have occurred. Yes.
Dr. Raju,
yes.
I think that this patient at the age of 13 years itself is having some lesions on the genital area.
Yes, sir.
That is 8 years back.
No, not 8 years back. 8 years back, he acquired infection.
I'll just clarify. I think the whole thing is this patient was diagnosed to have HIV when at the age of 8 years. He is on irregular ART. Since last 3 months, he has developed all these skin lesions. And for the last 2 months, he has been taking ART continuously.
That is the scenario.
That is the scenario. Case. Yes?
Yes, sir. That is the scenario.
Yes. So what Elangovan is telling that it could be iris, it could be iris also. Yes. Probably he is now going into iris because the florid lesions. The other diagnosis which was projected here is that bovinoid papulosis on the genitals. This could be a possibility, especially on the shaft of the penis. So my approach would be in this case, since he is a known retropositive, so there is no need to investigate him further on that aspect of it. Since he is already on ART, I don't think we need to do anything more on part of it. Hopefully the ART is good, and he only counseling regarding the continuation of the treatment is very much necessary. The second part, I think I would, because he's got very florid lesions, I would take a biopsy from the shaft of the penis, one lesion, for confirming whether it is bovinoid papulosis or a wart. We need to confirm that. And
yes, sir. We had a
the second
done.
one, I would just put a needle and see what material comes out from the molluscum lesions. As far as my experience goes, if the ART is continued further, the molluscum lesions may disappear on their own. And at the most, instead of going for anything else, we could try KOH on these lesions. Simpler thing would be just potassium hydroxide on these lesions. And depending on the report, biopsy report, we go ahead in the management of the lesions on the shaft of the penis. if they are bovinoid papulosis, then it becomes a bit difficult to treat these guys. So, and if it is wart also, it is a bit difficult to manage this case. That is what probably the way I would approach this case.
Excellent, sir. Excellent message. Excellent message. Sir, anything else any of the panelists would like to give their
See the
suggestions? Yes, sir.
CD4, whether it is very low and whether it is effective or not. Is there the drugs are effective or not? So that thing we have to see after a matter of 6 months only. So you have to see the viral load, whether the viral load is very high, whether it is the 4th stage or 3rd stage.
Yes.
So all these things you have to see. Then whether the drug is effective or not, ART is effective or not. So all these things, if you see, definitely it will release these infections.
Yes, sir. This was finally sought by us, a group of dermatologists at Osmania Medical College. We have concluded with this. That was a case of bovinoid papulosis with molluscum contagiosum. See, one should not miss out coincidental. This bovinoid papulosis, as you all know, is a pre-malignant condition. This all we have to be very, very cautious about this pre-malignant conditions or a coexistence malignancy in a situation of when a patient is on heart therapy as well. Suppose it doesn't respond, what next, what best could be done in this situation is also very crucial. Then the second case, because time is less, sir, we have to rush up. Yes, sir. Now this is very interesting, sir. May I request all of you to kindly concentrate on this case, as we have seen that Neta sir has been insisting on the circumcision. The previous speaker had been very pioneering effect of circumcision on the male genitalia, and this is what we are seeing. What could be the probable diagnosis, sir? Very interesting, sir.
Very, very interesting, but immediately we say it is warty lesions like that. I think
very true.
Smegma getting collected and solidified.
Yes.
What is your why did you suggest a smegma as a differential diagnosis here, sir? What made that?
Clean the area after retracting, and it is there for quite long time. It will be solidified and it will be seen like this. That is my
perfect, sir.
And it
is true, sir.
Yes.
Yes,
I agree.
That is true.
I agree with Elango one that it could be one. The other one is mistreated viral wart, not been properly treated viral wart. The first one I would go for is to an unclean, unhygienic person who has not cleaned his prepuce and the corona properly, so that it has smegma has solidified and become discolored also. That
excellent
would be my first
co-factorization of
just try to remove it and see what happens.
Dermatosis neglecta. Dermatosis neglecta.
Yes, sir.
Yes. Now, the situation of COVID must have compounded the cleanliness so far as that lesion is concerned. But generally, we are reluctant and we go about diagnosing a case that it is a condyloma acuminate at this, and so we start treating a case. My request to all the the postgraduates who are observing this is to always have clean the area at the preputial or a preputial sac, and then go about diagnosing a case. Thapa sahab, aapka kuch suggestion? Thapa sahab, aapka kuch suggestion? Any suggestion from Thapa sir about this case?
I think this is a dermatosis neglecta only. It's just a smegma which is collected there. He may not have cleaned the area. After I clean that area, only then I will think about other possibilities. So if it is not removable or it is a adherent or something, then probably we have to thought about, could this be some kind of a malignancy or warts? Those are the possibility will come. Right.
Now, I would like to highlight the panelists that is a 17-year-old male patient with these lesions 2 months. There's no history of exposure. And
if it is there for a quite long time, it will be sticky. It can't be removed easily like normal smegma. It is somewhat difficult to remove that. You have to soak and remove that. Not just like other smegma. It won't be cleaned that easily. So you must be very careful while removing that. There may be mild bleeding, may be there because it will be sticky.
Yeah. There may be some kind of irritation, some some irritant dermatitis or some infection could be there underneath also.
You don't know how long he has cleaned that area. Right.
Yes, sir.
Sir, would it remain asymptomatic for so long?
True. This is all permutation combinations I want in a panel discussion, because the entire nation is on an interesting topic of this. This is what happened, sir.
Yes.
Happened after cleaning that area.
Yeah, if it is already secondary infected, you might have visited the hospital quite some time back. Since it is asymptomatic, it is
That's a point, but not necessarily. We'll come across some more such phenomenal things in the next slide. Sir, this is very interesting case. The patient came to one of my colleague. He referred it to Usmania General Hospital, where my PGs were stunned to see this case. They thought, sir, what is this? This appears to be condyloma acuminata and all that. And it was something like funny situation. What to do with this case? Then we asked him to go and get it cleaned. Once he came up with this, then we were all rest assured that it was smegma.
Yes.
That was very thrilling case, sir. The last 3 decades, I haven't seen a case having stuck up of smegma for 2 months.
Excellent case.
Sir said that is it possible that a patient with 2 months having without any absolutely nil symptoms, is it possible? But here is the case where absolutely nothing happened to that boy. As Betkarur sir said, probably COVID must have contributed to the magnifying of this situation, though not irritability or something. He was very silent. He was docile. He did not do anything, manipulate with that area, thinking that maybe he must have thought it is also a coexistent COVID condition. So probably he would have kept quiet and came to us, to Usmania General Hospital, where we had to get that thing removed and come to a conclusion that it was just a smegma. I mean, it is confirmed by the presence of an uncircumcised penis. The significance of an uncircumcised penis is important. Yes, sir. Case 3. We have a case 3 like this. Sir, 70 came with these lesions. It's 1 year duration. History of pain and burning present associated with occasional bleeding. There is no history of exposure, sir. Obviously, he's 74-year-old. But that doesn't rule out STD, please.
Raju, can it be erythroplasia of curate?
Sivaram Reddy sir, very perfect.
Erythroplasia of curate, one
Yes,
of the differential diagnosis.
True, sir.
Other possibility, first possibility should be plasma cell balanitis.
Yes.
Okay, that is also because of accumulation of this smegma only.
Extraordinary.
Extraordinary. Yeah. So that can produce both the sides. So that can produce like this, and it's also thought to be the cause of predisposing cause to the lichen sclerosis. It may be early stage of lichen sclerosis.
Wonderful, sir.
So that is also possible.
Wonderful, sir. 71-year-old.
Circumcision and biopsy will confirm the diagnosis. Circumcision.
Correct, sir. We'll move to the next slide, sir. I mean, the consecutive slide of this. Nice. One more slide is there. One more slide, sir. Now, sir, see. The same patient, this is the first picture. He had smegma accumulated there for please. See the significance of circumcision, which was told just 15 minutes back, is reflected in my slides.
Yes.
It was not randomly discussed with Neta sir that I'm going to place this slide. It is so coincidental and so fortunate is this organizing committee people that we have incidentally got this case.
No, need not be
excellent cases, sir.
Circumcision need not be stressed.
Yes. Only the smegma, the presence of smegma in a 71-year-old for 1 year, he did not bother to clean. And then when he came here, we asked them to clean that. And that is the circumscribed picture, what we are getting here. As Elangovan sir said, Papa sir said, this smegma is contributing significantly to a pre-malignant condition, or maybe will land up into malignant once we do a biopsy.
Yeah.
It can, yes.
Thanks for that eminent panelists who have been so precise in their pre-diagnosis of a smegma, creating a situation like this, which I later posted you in the picture. Thank you very much, all the panelists. So good, so efficient they are.
Now, was the biopsy done from the lesion?
Biopsy, we have yesterday he came, sir. Yes, that's what I'm telling. It is so coincidental that it is so coincidental that Mehta sir has suggested circumcision, and that is the case we have. So these are the differential diagnosis sought.
You are doing a biopsy or circumcision?
Yes, sir. No, sir. We are first going to do a biopsy and then plan for a circumcision. And ultimately,
no. It would be much better because the lesion is on the prepuce. why don't you do a circumcision itself and take a biopsy?
Correct.
Do a
That
biopsy.
is also a very good
That
suggestion.
would
Yes,
be a
sir.
better option instead of
Better option. True.
instead of this,
No,
it will act as a
71-year-old.
therapy and also diagnosis for you.
True, sir. That was true, sir. That is a
Oh.
very good suggestion, but a limitation of a patient of 71-year-old and in a COVID
71
situation.
is much better for you to do if he is not a diabetic or doesn't have a constitutional any other comorbidities. Go ahead, do a circumcision and then biopsy. So you can just put him that this could be a case of cancer. So you are ruling it out.
Is there any bleeding on touch, Dr. Raju?
There was mild, there was slight amount of bleeding was present in that case when he retracted the pubis, because as you all know, there was a phimosis situation, having smegma underneath and the smegma contributing to phimosis and then the development of an inflammation there, compounding the phimosis at that situation.
Another important differential diagnosis is candidal pyelonephritis, as you also know.
Very true, sir. Very true.
Which also should be done.
Perfect, sir. Yes, yes, yes. Obviously, the other aspect being pyelonephritis, though he was not a diabetic male, but yet we have to, the first instance, the naive case, maybe a case of candidal pyelonephritis, we have to go for a blood sugar investigation. Then the case 4. I know it's a little difficult, but an annular lesion.
Presenting with burnings. LP, I think.
Very true, sir.
Presenting with burning sensation.
A burning sensation. Yeah, he had a burning sensation for 1 month. Anything else, sir?
STI, non-STI. I would like to go for a non-STI rather than STI.
So history of
Lichen
bleeding
planus?
with Dettol and other things, irritants.
Yes.
So that is
not there. Not there in this case.
Okay. So
I'm sorry, sir.
How long
I'm sorry.
it will be
I'm
there?
making you all to
1
think
month.
twice before we discuss this,
1
because
month.
I'm sorry, but I had.
Can you tell the lesions?
To make
The
it
picture
tricky,
is not
but to make it tricky and more tricky, I want.
Yes, yes.
Yeah, I can say the inflammation and the rim of the glands and rim of the prepuce.
There is lichen planus.
Possibility.
History of lichen planus.
Possibility, yes, sir. Possibility.
LSA also could be possible.
Very good, sir.
Any history of sexual exposures also we should.
No, not there. Not very much there in this case. No, he denied history of exposure, sir.
Are you not once again showing smegma? Smegma in his
the threat of smegma is lingering large.
That is also possibility.
Yes.
The
But why should it be well marginated? That is the question. No, it is a well marginated lesion on the glands. So I would definitely
because
go
there
for
is some
a
whiteness.
non-STI,
There is some
probably a LP or a psoriasis lesion there. Unless, of course, there is no, maybe a treated case of one of these two. One. Otherwise, a 24-year-old male would be my first one.
Drug induced.
Unless it is a hyperpigmented one, I would have even thought of FDE also in this case.
Does he have some psychological issues along with, which may be causing problem?
Maybe, sir. Maybe
he is
sir.
habituated to masturbation.
Very true, sir. Very true, sir. Very true. Yes. Very true, sir. Sivramani, sir. Correct. Yes.
What is the relation between masturbation and this?
The case of traumatic.
Trauma. Okay.
Probably, sir wants to diagnose this case as a case.
But that would be more near the frenum, I think.
We did see cases in the anterior aspect, I mean, the dorsum of the glands. We have seen few of the cases which have annular lesion and erythematous lesion, the 12 o'clock lesions are maybe between 10 and 12, maybe between 10 and 2. We often have seen cases of, as Sivaram Reddy sir said, that a traumatic pyelonephritis can be there, and then subsequent application of, because of apprehension of having developed some infection, a venerophobic condition situation where he must have applied subsequently and then must have got a case of pyelonephritis with us. So that
possibility of application of some irritants and something like that.
Correct, sir. Correct, sir.
So
much likely
because that will produce maceration also and ulceration.
Also, yes, sir. Yes, sir. Yes, sir. Yes.
Is there any hirsutis papillaris there?
It appears, sir. There appears to be hirsutis. Yeah.
Appears to be.
Yes, sir. Yes, sir. Hairy penis. Yes, yes. There are some lesions. There are some
congenital.
what we sought for. So far as differential diagnosis, infective, it is bacterial Bellinopastitis, as Sivaram sir said, maybe a trauma and maybe a Bellinopastitis and subsequently the fusospirochetes and a situation. Then gonorrhea was also sought to be considered for differential diagnosis, chlamydial infection, HSV Bellinopastitis, and non-infective being traumatic FD, irritant Bellinopastitis, Zuhn's Bellinitis since it is on the glands, Circinate Bellinitis since it is on the glands, and a squamous cell carcinoma in situ.
Sorry to interfere, and a question about gonorrhea causing Bellinopastitis.
Very rare.
Highly questionable.
Improbable. Yeah, improbable that is. Yes. True, sir. True, sir. But the differential diagnosis thought was this.
Okay.
All this
Long
needs
list
to
of
be, yeah. Now the case 5, sir.
But that case was managed, or it is still a,
Yet to be diagnosed, we are thinking provisional diagnosis to be LP only, sir.
LP.
Okay, what was it?
Consider here, but we considered on paper that it is a case of lichen planus only. And
Okay. Has it been treated? Means
no, sir, no, sir. This of late these cases have come. We have straight away.
Sir, one more thing I could ask you is like something congenital diabetes.
No, sir. No, sir.
They may be causing some cuts and other things and getting burning sensation.
No, sir. He was non-diabetic. That aspect we have ruled out.
Yeah. Okay. Okay.
Next
Thank
case.
you, sir.
Yes, sir.
Thanks a lot.
No, this is very interesting again. RVD positive, inguinal swelling on the left side for 2 months.
Tuberculosis.
But
the prepuce
LGV,
can be
tuberculosis and
the prepuce can be retracted.
groove sign.
Yeah, it looks like
There was no ulcer there.
very
There was absolutely no ulcer on the prepuce. Prepuce was absolutely perfect. No erosion, no lesion on the glands whatsoever in the history.
Okay.
It can be
I don't think so.
venereum with transient
Could be LGV and tuberculosis as one of the differentials.
So what
could be some non-Hodgkin lymphoma.
Excellent, sir.
If it is, was he HIV positive again?
Yeah, RVD positive. Huh?
Other areas, whether its lymph nodes are enlarged or not. Hello?
Yes, sir. Inguinal swelling it was mass present on the left inguinal region. That's all.
The groove looks like as if it could be.
That was a
LGV.
deceptive case. Hence I posted in the group. Hence I sought for your esteemed
skin
explanation
changes
in the
are
panel.
not there suggestive of anything. So of LGV, skin should have shown some changes, inflammatory changes, but it is not seen. So probably a cold abscess. As Rakshmikant said, it could be tuberculosis, and as Dr. Thapa said, unless of course there are other lymph nodes in elsewhere, maybe abdomen, maybe somewhere else, then we could, since he is an RVD positive patient, so non-Hodgkin's lymphoma can also be thought of. So a bit deceptive. Of course, absence of skin, ulcer in the genital area rules out quite a good number of one. I don't know what it is, VDRL, whether VDRL was...
Yes, sir. The next slide, please. Bhumesh.
LGV means the abscess might have been formed within 2 months.
This was the differential diagnosis sought.
Yes. No, lymphogranular venereum, the abscess, multilocular abscess might have been gone and the sinus formation might have occurred.
It should be bilateral also, lymphogranular.
Correct, sir. Correct.
Transient ulcer could be one of the things.
Except a transient chancroid, other
chancroid, maybe a transient chancroid must have occurred and then gone, and then this.
Very unlikely.
Very unlikely, sir. Very unlikely.
I was surprised to see whether hernia is one of the differential diagnoses.
Correct, sir. Correct, sir.
I don't know whether,
perfect.
Unless you give us some history, that whether it was reducible or not reducible.
No, it was not reducible, sir.
Or non-tender.
This case, it was a non-reducible swelling.
I don't know why you put pseudobubo, because lymph node is enlarged means, I don't know why you have given the differential diagnosis as pseudobubo. It won't rise at all. You won't think of venereal granuloma at all. I don't know why you have given that, because there is no lymph node involvement except secondary infection and the ulcer in the genitalia and the secondary infection. So I think that can't be, it's not applicable.
True. The suggestions I wanted. The suggestions from the esteemed panelists I wanted for the entire nation to hear.
No, we have to palpate it and find out it is a farm, it's
Yes, sir. The approach. The trick is the approach. The trick is the approach to such an inguinal swelling. What all can be done in that situation?
I would approach this in this fashion. I would do a FNAC. Okay. Definitely. First is an FNAC. Probably go for an ultrasound in non-invasive if at all we need. Two things. Then depending on the report, yes, and of course the other routine investigations which can indicate something of
FNAC.
out towards some disease. Instead of opening it up with any other thing, I would definitely put a needle for the FNAC and see what happens. After that, we will go ahead and depending on the response, depending on the reports, we go because he's a RVD positive, probably he must be on ART as of now. So we'll go ahead with that thing. Only after that, and
would like all the postgraduates to concentrate on this. What Dr. Bedkarur sir is telling, what Elangovan said, what sir has said about a differential diagnosis of a swelling in a RVD positive. Please, the next question, the next case, please.
Non-Hodgkin's lymphoma.
Yeah, sir, that was considered as a differential diagnosis. True, sir. Sivaram Reddy, sir. Yes, the next case, sir. 25-year-old male came with itchy lesions or penis for 1 month. History of exposure denied. That is how the lesion is again.
I think you'll have to give us something more to think about.
This is more look like a lichen planus.
Correct. Tapasa. Excellent, sir. Very good.
Annular lesion.
Annular lesion. Correct.
LP or psoriasis looks like a little bit scaly on the surface. So
sir, would you suggest a trick in differentiating between psoriasis and a lichen planus in this situation, sir?
Could be a little bit of scaling, more scaling in psoriasis, and mostly on the glans.
Malacious in LP.
Yeah, and it's little white discoloration. Pointing towards LP.
Going to say again circumcision for this?
Psoriasis will not look like psoriasis as we see commonly in genitalia.
Yes. In other parts of the skin.
Because there it will be a well-demarcated erythema will be there. But the lesion elsewhere should be there.
I had seen something like a pityriasis rosea some time back. It was very, very unusual that time. And I think, this could be one of them. I don't know, probably. Could be one.
Necessarily, we must do a video.
Because once we say rare, it is very rare thing that can happen.
Correct. Yes. I would like to reiterate the fact that all these panelists, for the first time they are seeing and discussing, please. Thanks a lot for all the panelists who have given their best suggestions so far as were concerned. Thank you so much, all the panelists, sir. Now, this is what we sought as a differential diagnosis. Annular syphilis is also considered here. This we have missed.
Itching.
Annular syphilis lesion should be other lesions.
We considered. We did consider. Alangavan, sir.
We did consider. The point of itchy. Correct. Itchy lesions means we won't think of syphilis. So, anyhow, whatever the lesion is, you have to do VDR. There's no doubt in that. But since it is itchy means we will give the wrong information to the postgraduate.
Alangavan, sir, is absolutely correct. Any condition which is coming with a genital an aesthetic clinic, inevitably we are going to do a VDRL, sir. Yes, true, sir. Yes.
You can somewhat not think of syphilis. Don't think about
subsequently, yes. Though it was considered as a differential diagnosis, necessarily we must consider in all those lesions, which have annular picture, especially on the glands and all, we must consider. This is how it was treated. With the annular LP, treatment was started with topical calcineurin inhibitors. Next slide, Bhumesh. Bhumesh, sir, next slide. Yes, case 7. Now, this is an interesting again.
Oh. There are asbestos-like scales.
This is more like this is more look like some kind of irritant he has applied. Okay, so and it is a post-inflammatory scaling which is coming up. It is not micaceous that
micaceous balanitis.
No, it's not like that. That should be more thick and hyperkeratotic in nature.
All the postgraduates to concentrate on the discussion, please. The eminent panelists have been
I
discussing
would
these
definitely
issues.
agree with Dr. Thapa about this. I think this fellow must have cleaned it with Dettol direct. That is the most commonest one. That is how they do, especially if they have had some, either they have masturbated or they have had sexual contact. That is what they do, direct Dettol.
Examination.
That was the provisional diagnosis sought, genital psoriasis.
Okay.
Allergic contact dermatitis was ruled out, VDL was done.
Oh, I think you could have just managed with, see if the...
With the emollient.
Yes, sir, that's what we did. We started with topical steroids, but you were not responding. So.
See, if we are talking in terms of VDRL test and other things, and as Thapa said, we are looking at an irritant dermatitis, I would have just used a topical steroid instead of vitamin D analog, or just cleaned it with, just gentle wash for a period, 1 or 2 days, and then gone for a mild steroid, mid-potent or mildly potent steroid, and done that. And instead of going for a vitamin D analog, which is specific for psoriasis. That would be a better option rather than going for a vitamin D analog for this.
Thank you, sir. Thank you. Thank you for the excellent session. Thank you, sir.
This is SY2, I think.
Thank you, sir. This is the next case. Exposure present, sir. Now the trick here.
Rheumatoidal type of secondary syphilis, I think.
Secondary.
Excellent, sir. First DD, perfect.
This could be reiters also.
Writers could be
Excellent,
one
sir.
thing.
The reiters, rheumatoid syphilis. So but lesions,
Yes.
psoriasis
Excellent,
also.
excellent, sir. Excellent, sir.
Lesions
Excellent.
on other areas of the body.
Yes, sir. We'll show the next slide. Next slide, Bhumesh. Yeah, now see.
Look like reiters,
Yes,
more
yes.
look like reiters, or maybe papular psoriasis.
Yes.
I don't know. Papular
yes.
lesions are not there, but more look like hyperkeratotic type of lesions. I don't know what about the joint involvement.
Rheumatoid psoriasis.
So if you are giving the history of, prominent, that history of exposure is there, and that to a 34-year-old male, then the first thing that comes to mind will be, I don't know whether he is a retroviral positive. And
No, sir. No, he's not positive. No, sir.
Not. Then the
Not
first
because
thing that
if
comes
had
to
he
mind
been there, we would have displayed here.
will
No.
be syphilis. But if the history of exposure was not there, then the first diagnosis would be psoriasis.
Okay.
If the history suggestive, giving the history of exposure 3 months back was not there, then first diagnosis would be psoriasis.
So if you are thinking of, sir, if you are thinking of malignant syphilis, whether patient is toxic, toxic or not, patient having fever and other things or not.
Quite possible, sir.
Loose maligna will be a little difficult.
Toxic, it will be toxic, and you won't be able to move around and all, and the rupial form will be there. And I don't think so. It may not be.
Was VDRL negative in this?
VDRL negative, sir, in this case. Yes, VDRL was negative in this case. Hence, we confirmed with VDRL. Since VDRL was negative and there was no ulcer present, then histopathology was done, biopsy was done, then clinched the diagnosis of psoriasis, labeled it as rheumatoid psoriasis, started him on methotrexate.
Okay, right.
Next case, case 9, please.
Oh, kissing ulcer.
Kissing ulcer, sir. History of exposure present.
20 days back. So, could be
Primary
primary
chancre must be the
chancre.
diagnosis.
It's a kissing ulcer, so possibly. And there are two.
I think it is indurated, painless, probably.
Yes, sir. Next slide, Bhumesh. Yes. This is what was considered for differential diagnosis. He said, sir, primary chancre, chancroid since auto-inoculation, since kissing ulcer. Herpes genitalis also was sought. Donovan was also considered. Then we considered traumatic because it was near the frenum.
I don't know why FD was considered in this case. Such an indurated, almost like a edge of the ulcer is not suggestive
Dr.
of
Singh,
FD.
we are cutting close to time, 5 minutes away.
Yes, sir. Yes, sir. Sir, VDRL was 1 in 16 and the case was treated.
But this case was based for dark field microscopy.
Correct. We have recently spoiled our dark field, so we could not do a dark round examination, sir. We are sorry. But VDRL did confirm the case that it was a case of primary chancre. And then we started him on directly on benzethine penicillin. And this is case 10. Sir.
It was excellent case.
Correct. Sir, we are running short of time. Sir, now this is
secondary.
This case.
Okay. Syphilis.
Now, what is non-STI and what is STI in this?
SY2.
Erythema multiforme.
So far as STI is concerned, then the non-STI situation, sir.
It could be secondary syphilis, it could be lichen planus, it could be erythema multiforme.
Excellent, sir.
Erythema multiforme also could be there. But
correct, sir. Correct, sir.
Bilateral, symmetrical, both sides. So the two possibilities, secondary syphilis and that. But one is asymptomatic, other will be a little
next slide.
have symptoms.
Next slide. Excellent, sir. Next slide. Yes. Now this is the differential diagnosis chart. Palmar warts, erythema
Warts could not be a possibility.
I don't think warts could be considered.
Could be considered.
And even palmoplantar psoriasis is also.
Okay. Sir, are you still seeing lot of secondary syphilis? Because in private practice, I have.
No, sir. Many cases have been coming. Sir, next slide.
Hardly any.
Sir, next slide. We are running short of time. Case 11. This is an excellent case, sir. I'd like all the panelists to. We have very short time, but it is very unfortunate that we have got this case at 11.
Nodular scabies.
Scabies.
Nodular scabies.
Nodular scabies.
Nodular scabies. More of a nodular scabies.
Next slide, Bhumesh, please.
Again, was he HIV positive? He had so many.
Yeah. Perfect, sir. Perfect, sir. Perfect question. That is the trick. That is the trick. That is the trick. He was positive. Next slide, Bhumesh. Next one more slide. Now see, sir. This is.
Oh, yes.
Pictures of the same patient?
Pictures of the same patient.
The last picture is similar.
This could be secondary syphilis also.
This is a case of secondary syphilis. True, sir. This is perfectly a case of secondary syphilis.
Yes, secondary syphilis.
A nodular lesions on the glans penis and a nodular papillonodular type of rarest of rare presentation of syphilis. We did get case. He's the child positive. He's from Telangana, Armo district near Nizamabad, where this man hails from. He misled us saying that he's married 3 months back and then came up with all these lesions. We were really bewildered to see what is this going on. We had a nodular lesions in the glans penis, denied as such a history of exposure, said he was married. Then he had all sorts of lesions of papillonodular to consider this nodular lesions as the scabies and then to find lesions on the body and all. It was rather a more confusing picture for us.
What about itching, sir?
Itching was there in this case, sir.
Sometime in HIV positive patients, you may find itching could be there.
But itching is more of a subjective phenomenon.
Yes. Next slide, Bhumesh.
Follicular syphilis has more.
This is the same case, sir. He had lesions on the face, see, sir.
Oh my God.
Oh.
Superent, yes.
This
typical that papules, that papule and all. You can see, sir, the angle of the mouth. You can see.
Yes.
Split papules.
Yeah, you can see the split papules at
Now
the
there
corner,
is
angles of the mouth. You can see them, sir.
Right.
And the VDRL was 1 in 256.
Wow, it's too high.
The papillonodular syphilis, although less common, sir. But
was he given penicillin?
Yes, sir. He was given penicillin.
Benzethine penicillin.
Did come down. VDRL did come down.
And the lesions
There
also.
was no any other reaction post.
No, sir. No, sir. Absolutely safe.
Jarishak's
Yeah.
No, sir. Not there. Not there.
That could have been there with such a high.
It was incidentally, fortunately, it was not there for us, sir.
Okay.
Good. Excellent cases, sir.
This is all what we saw in the last fortnight at Usmania Medical College. I am posting before you, sir. Next slide. We have running short of time. Case 12. So we'll make it fast.
Condyloma.
Yeah.
Next slide,
No,
Bhumesh.
no. These are ulcerative lesions which are there.
History of exposure denied.
Ulcerative.
Recurrence present. Recurrence present. The redeeming feature. Recurrence was present.
Recurrence.
Okay. Basets.
Okay.
Basets.
Oh, extraordinary. Yes, sir. Yes, sir.
Recurrent aphthous are the basets.
Next slide, Bhumesh. Next slide, Bhumesh. Next slide, Bhumesh.
No problem, sir. We can take 5 minutes extra.
No, Bhumesh, I'm concerned more about you.
We have a lunch. Followed by we have a lunch. 5
Then
minutes we can take.
Herpes, I think.
Herpes also possibility, but then how many recurrences he is getting? What are the systemic symptoms?
This is what we sought, sir. Herpes. We sought for Behzats, as sir said, Thapa sir said that there was a sense to consider Behzats in this case. We also the oral lesions preceding these lesions of the scrotum.
Then the Behzats.
Yes.
Maybe he is using condom, and that is why he has got a lesions on this thing.
Yes, sir. Now the last case, sir. Case 13. Thanks, Bhumesh. Case 13. No, obvious case.
Chlamydia.
Gonococcal.
The 2 days.
Morning dew.
2 days.
2 days is a gonococcal only.
Yeah, gonococcal and
could we have associated chlamydia also? We don't know.
Always coexistent, no, sir. They all go together always. Without saying, they go together.
Grey color kit.
Correct, sir. Yeah.
It requires a syndromic.
No. This is odd. We thought
was smear gram stain done for this?
Gram stain has been sent.
Okay.
Yes, sir. We have sent for gram staining to find out diplococci. Yes. This is
PGs would be very interested to do a gram stain for this. PG should do a gram stain for this.
Yes, sir. We are always after them. We are always after them to do a gram stain.
And if possible, I think if the facilities are available, you could go for a culture of this.
True.
Okay, in microbiology. So that would give a better this one.
All the postgraduates to listen carefully to what National President speaks. And the eminent panelists have been speaking all along. I need to write it down on a piece of paper, all that if you can recollect. The syndromic management, the limitation, as the preceding speaker, Somesh Gupta Sahab, has said that this limitation so far as using kits in the females are concerned is very, very important. Please, to remember, all the postgraduates remember, this is case 14, the last case, very important. The last case is very important, sir. This is history of exposure denied. Short duration of lesions. Painful raw areas. Is
there any drug eruption? Drug reaction?
Oh, excellent. Sivaram Reddy sir.
FD.
Recurrent? Bhumesh, please.
Was it recurrent?
Yes, sir. Now this is a confirmatory lesion.
Yeah, FD.
Mixed drug eruption.
This is
mixed drug eruption. You may get all PGs. You must read the fact that FDE can proceed with a mucosal lesion first, especially on the lips or on the genitalia, followed by a lesion independently on the skin. Or you may have an independent lesion on the skin. Commonly, you will have lesions of that sort, but you may also have a mucosal lesion followed by. Thank you very much. Thank you very much for this panelist. Betkarur sir, Thapa sahab, Sivaram Reddy sir, my colleague, my senior, Rashmikant sahab, Alangavan sir. I'm so gratitude. I remain gratitude towards you that you have been so good with me. Especially the National President has been very busy all along, sir, was very busy. I have seen him in the ascent and immediately he came back here and was dot sharp and explaining very good, excellent. All the panelists have been so good. I'm so fortunate to have such a good panelist. I thank all my organizing co-chair persons, my people. I am extremely thankful to all of you. Thank you very much.
Sir, Dr. Raji Singh, sir, Dr. Murugan.
You have conducted very well. You have shown a good.
Dr. Raji Singh, sir.
Thank you, sir.
Very good cases, Dr. Raji.
Thank you, sir. Thank you, sir.
Congratulations for wonderful cases and your panelists. Only one comment I want to make it. That is regarding the smegma, you have focused 2 cases, 17 years and 71 years, and you have even blamed the COVID situation. I want to stress one thing. we have not taught anybody to retract the precues and clean well. They don't know. Most of the patients I have come across, they need not, if it is, there is a phimosis, circumcision is the only way.
Message
I understood.
from the Murugan sir. Yes, sir. Greatest message you have given. Yes, sir.
Yes, we don't know. We don't teach them, our youngsters and other people, how to open, how to clean, how to see the. They never saw the coronal sulcus at all. So in these cases, we have to train the individuals to clean well. That is very important rather than circumcision. Circumcision is, of course, is the indication when there is a phimosis there. Otherwise, very good, sir. Very excellent panel. Thank you. Congratulations.
Thank you so much.
Thank you so much.
Thank you, Bhumesh, everybody. And I think lunch will be served by Bhumesh.
Yes, sir. Yeah, everything, sir. Whatever you want, you can take.
We are waiting for the Swiggy fellow to come.
Whatever you want, you take, sir. No problem at all.
No, we are already waiting for the Swiggy fellow to come.
Thank you so much,
Thank
sir,
you,
Rajesh
Bhumesh.
sir, for the excellent moderation.
And Hyderabad team for an excellent job. Thanks a lot.
So, as usual, the wonderful case discussion moderated by Dr. Rajiv Singh sir and the very experienced the panelists we have kept for this discussion. Really, all 40 panelists are very excellent.
Definitely, I'm overwhelmed by all the panelists.
Lot of take-home pills,
Really.
and not only that, for the faculty. So it's a time to sensitize more on the PGs. I invite Dr. S.B. Kavita, today's the quiz master for this session. She is associate professor from Gandhi Medical College. And over to Dr. Kavita.
Yeah. So mostly the PGs might be waiting curiously after listening to this exciting panel discussion from our eminent panelists and the moderator. Literally, most of the PGs might have learned so many pearls. So it's the time for us for the quiz. So be ready for the quiz. And the instructions are, as you know already, each session will have 10 MCQs, each one correct answer. Mark only one correct answer, sorry. The first 3 toppers will be selected for first, second, and third prizes. And the duration of time is just 5 minutes. Postgraduates has to submit their bona fide certificate from the concerned HOD if they win the prize. And the quizmaster decision is final. And also, don't refresh or close the browser. There are exciting prizes. So be in a competitive spirit, start your quiz. So thanks once again, all the panelists. Really, it was really an exciting and have really learned a lot, sir, from all the eminent teachers, in fact, to say. And Rajiv, sir, the picks are really so good, sir. I'm really missing you in Gandhi.
Thank you, Kavita. Thank you so much, Kavita. Thank you very much.
Kavita, felicitation.
Yeah.
Invite
I now request the chairpersons, Dr. Rajiv Sridharan, sir, Dr. Vineet Relhan, Dr. N. Ramesh, sir, to felicitate our speakers, Dr. Sumati ma'am, Dr. G. Narsimrao Neta, sir, and our moderator, Dr. Rajiv Singh, sir.
Yeah.
And I request the organizing team.
Congratulations.
Felicitations as if it's really as if you are attending physically. It means kudos to Bhumesh, sir. I now request the organizing team to felicitate our chairpersons. I thank the organizing team for giving me this opportunity. Thank you all.
Thank you. Thanks a lot.
Thank you very much for
Thanks,
all
everyone.
Yeah. Sridharan sir, go ahead.
Thanks, everyone. It was wonderful. If Rajiv Singh could collect this many cases in a couple of weeks, I can imagine the kind of cases you get there. Thank you. Thank you so much. It was a good learning.
I better send my PGs to Rajiv Singh for 1 year, 10 days training on STIs.
Definitely.
I tell something like, Telangana never stop in teaching.
Thank you. Thank you, sir.
Thank you.
Sir.
Thanks a lot.
Thank you so much, sir.
Always sharing of
for your
knowledge
kind
from all your
words.
people. And a
Thank
special
you.
thanks to Dr. Betkarur sir, in spite of his busy schedule.
Yes.
So he has
Thank you, sir.
participated and he has contributed.
Thank you, Betkarur sir.
Appa sir and Rashmikant sir,
Thanks.
the excellent
Such a
contribution.
touchy
That's why we
explanation.
kept a senior most panelist in this session.
Senior most. Thanks, Bhumesh. Thanks,
And I
Venkatramana sir.
request
Thanks.
all these panelists be there in the valedictory also.
Yeah, don't make a senior, only senior consultant, not make a senior citizens.
Yeah,
Okay.
senior consultants only.
We
Don't
will.
call us senior citizens.
It's a test for us, and we also learn that we must be update our knowledge every day.
Thank you, Elangavan sir. Thank you so much, Elangavan sir.
Thank you.
Thank you so much. And we are on time. Pre-lunch session, we have finished 12:59 with 1 minute left. So thank you. And we will meet again at 1:30 sharp. So please don't go away. So post-lunch sessions also very interesting and the encouraging sessions are there. Please be there and encourage us. Thank you very much.
Thank you.
Bhumesh.
Thanks a lot.
Thanks,
We'll be
Bhumesh.
there.
Bye. Bye, sirs.
Bye. Bye.
Thanks, my friend.
Good afternoon, sir. Good afternoon, sir. I'm Dr. Satyeshri. Can you hear me, sir? Hello?
Hello.
Yes, sir. I'm Dr. Satyeshri.
Good afternoon, ma'am. Good afternoon. Good afternoon.
Good afternoon, sir.
Any 1:30 ka? What time they're
Yes,
starting?
sir. Yes, sir. 1:30.
1:30. Okay. Okay. I just wanted to find out whether it's getting linked or not. Take care.
Yeah.
Okay. Thank you. Thank you very much. Thank
Thank
you. You finish your lunch? Not yet?
Not yet, sir. After the session, I will.
Okay. Okay. Thank you, ma. Thank you. Thank you.
Thanks. Hello, ma'am.
Hello.
Yeah, the session will start after lunch, ma'am.
Yeah, I know. I just wanted to check in that
Yeah,
everything
just
is.
informing.
Yeah. Okay. Thank you. Thank you so much.
Welcome.
Srinivas?
సార్ చెప్పండి సార్.
5 minutes ఉందా ఇంకా?
సార్ 8 minutes ఉంది సార్.
8 minutes.
మంజుబాల మేడం ఉందా? మంజుబాల మేడం
ఉన్నారు, వచ్చారు ఒకసారి. రెస్పాండ్ అయ్యాను, వస్తాను.
And Maniyar sir also is there. And what about chairpersons?
Good afternoon, Bhumesh.
Yeah, sir, good afternoon. Welcome.
Fantastic program from morning. We're enjoying. Really
Thank
nice.
you, sir, with all your cooperation.
Had you lunch? Bonchesara?
అయిపోయింది sir.
Very nice.
Deepak Shirpata is there, chairperson.
Good afternoon, Dr. Umesh.
Please, please share your PPT madam once if it working or not.
Okay, fine, I'll share.
Srinivas, just you stop sharing.
That's
Okay, sir. Good afternoon, sir.
I think you are sharing, that is why I'm not able to share.
Oh, no, this will stop. And Srinivas, the Dr. Maniyar sir PPT, we have to share.
It is showing you can't start screen share while the other.
No, we will stop. Srinivas, you stop lunch break. That slide. Stop sharing.
Umesh, do I need to? Umesh, you have kept my CV on?
Yeah.
No, CV, my PPT.
Yeah. Shall we share or are you going to share?
No, I mean, you are going to share. Then I can go next, right?
Okay.
Listen, you want us to share? We can.
Yeah, you share, sir. Please, if you share, that is easy for you to.
After Manju Bala.
Yeah.
Right?
Just
I can't share now.
Srinivas, you stop sharing of the lunch break slide.
Okay, sir.
The two speakers, they will try for they will share.
How do you do that?
నువ్వు లంచ్ బ్రేక్ స్లైడ్ స్టాప్ చేయట్లేదు.
Sir, just give minutes, sir.
The two speakers, they will share now. Let them see. Once if it is okay, then we can. Manjubala madam, you try share. Now you start sharing.
I'll try to.
Perfect.
Yes, correct.
Just move it.
Yes.
Perfect. Yeah, stop sharing.
Yes.
Maniyar sir, you try, sir, please.
Okay. Hold on, sir. Share.
And Murugan sir also will share after this.
No, this. That's not ours.
Yeah, slide show.
I can't because the Murugan is sharing.
1 minute.
Yes, I wait till Murugan finishes.
Okay.
Once Murugan finishes, I push in.
So you put it in slideshow.
1 minute. Okay?
No, you now it's okay. Just move it. Yeah, perfect.
I will stop.
Can I?
Yeah.
I can? Yeah.
Yeah, sir,
I stop,
please.
sir. Good afternoon, Maniyar.
Good afternoon, sir.
Manjubala madam, good afternoon.
Good afternoon, Dr. Murugan. Good afternoon.
Is that okay?
Murugan, good afternoon, sir.
Good afternoon.
Madam
Is it
Manju,
okay?
good afternoon.
Umesh?
Oh, Ram Manohar Ram.
Video,
Yes.
sir, it's okay, perfect.
Thank you.
Maniyar sir, good afternoon.
ఏంటంటే సార్ మీరు
Good afternoon.
వీడియో
Good afternoon, sir.
కనపడుతుంది కానీ మీ పేరు
Good afternoon, sir. Manorji.
Yeah, namaste.
now stop.
Great.
Yeah.
Thank you.
Srinivas? Yeah.
Sir, చెప్పండి.
After 2 minutes, we'll start.
Yes, sir, sure, sir, definitely.
Mukunda.
Umesh, you're going well.
Yeah, after 2 minutes.
So you're doing well.
Thank you, sir. Thank you with all your support and blessings.
No, support of all others. I'm a veteran president. Muruganji, fine?
Fine.
You are
Excellent.
happy under your leadership.
Yeah. With your company.
Delegate, welcome delegate you put. Srinivas.
Sir,
welcome
1
delegate.
minute left.
Thank you, sir.
Sir, 2 minutes left.
Srinivas, the echo is coming. Just check any person has joined with the 2 devices. I request all the faculty, please join with a single device. If you join with the double 2 devices, echo will come. Srinivas?
Devices వేస్తే ఎక్కువ వస్తుంది వాళ్ళకి ఇది పెట్టుకుంటావా
శ్రీనివాస్ ఉన్నావా
ఇది తీసి చూస్తా వస్తుంది
ప్రాబ్లం వస్తే కష్టం
రాజేష్
You lost your technical person.
Sir.
Ready, yeah? Welcome delegate slide, I say.
Okay, sir.
That echo is coming. Why that disturbance? Srinivas? You put all the in mute form. Yeah, welcome Deepak Chitpataji. Good. Welcome.
Okay.
Yeah. We will start. Yeah, good afternoon. So we hope that you had a good lunch at your residence. Because of this COVID-19 pandemic, we could not provide lunches, all those things. So sorry for that. But definitely the next year, Hyderabad will host with the physical conference. Definitely we will provide lunch, all gala dinner, everything. And welcome to the post-lunch session. So we have post-lunch session is the HIV and AIDS session. For this, I invite the session coordinator, Dr. T. Satyasri. So over to Dr. Satyasri.
Good afternoon, everyone. Thank you, Bhumesh sir, and all the organizers to provide me this opportunity. So welcome to the session 3, HIV or AIDS session. I call upon Dr. Ram Manohar Rao sir. He is from Tamil Nadu.
Good afternoon. Good afternoon.
And he got Sri Satyasai Dhanvantri Award and Chaco Valarappa Award as the best outgoing student from Madras Medical College. And next I call upon Dr. Tarun Mittal sir. He is a senior consultant at present from Synergy Institute of Medical Sciences, Dehradun. Welcome, sir. And he's got Uttaranchal Ratan Award in 2018. Yes. Next chairperson is Dr. Deepak Shirbata sir.
Shirbate.
Deepak sir, and he's practicing from Maharashtra. Yeah. And
over to chairpersons.
Over to the chairpersons, yes.
Good afternoon. At the outset, I'd like to thank Team e-ASTICON for having given us an opportunity to be a part of the faculty. I would like to invite Dr. Manju Bala, who is an MD, PhD, She's been a former HOD at the Department of Medical Microbiology, BMMC and Safdarjung Hospital. She has been a former DDG in the Ministry of Health and Family Welfare and Assistant Director and HOD, Department of Microbiology, Delhi. She has been a recipient of several awards, and she has also achieved several things. She has been an advisor on STS with WHO headquarters at Geneva. She has got a lot of publications, around 127, of which 59 have been in international journals. May I now request Manju Bala to proceed with the presentation, her topic being present guidelines in the diagnosis of HIV/AIDS in children and adults. Madam Manju.
Thank you, Dr. Rao, for your kind introduction. Good afternoon, everyone. And at the outset, I'd like to thank the organizers for giving me this opportunity to talk about present guidelines in diagnosis of HIV and AIDS in adults and children. So I will be mainly concentrating on what NACO has advised at national level, that is for diagnosis in adults and children beyond 18 months and in children less than 18 months.
We are unable to see your PPT, ma'am.
You are not able to see?
No, yes.
But I have
not being shared.
I have shared my screen.
And Manju Bala has started screen sharing.
It is not visible on the.
I started my screen sharing. Should I
stop again? Start. You stop sharing again. You start. Restart. You'll get it.
Is it visible now?
Yeah. Put it in slide mode.
Yeah.
Perfect.
Yes, ma'am.
Yeah. So I will be in this talk concentrating on what NACO has advised at country level for diagnosis in adults and children beyond 18 months and in children less than 18 months of age. So in adults and children beyond 18 months, it is regarding the detection of antibodies in the blood sample or serum or plasma samples. And if the results they are indeterminate, then to detect it either by viral or viral products. And in children less than 18 months of age, due to the persistent or maternal antibodies, diagnosis is made by PCR test. And also the diagnosis differs in children less than 6 months of age and in children between 6 to 18 months of age. I will be talking about that in the subsequent slides. So before we go to diagnosis, first we should be knowing about the classification of HIV because the diagnosis is dependent on that. That HIV is classified into two types, that is 1 and 2. And HIV-1 is further having 4 groups. That is HIV-1 major, O outlier, and that is non-M and non-O, and HIV-1P, that is pending because only 2 cases they have been identified till now. So pending further confirmation for more cases. And in Western Europe and America and Australia, it is the subtype B, which is prevalent of group M. And in India, it is South Africa, and it is type C, which is more prevalent. As all the research, it is mainly focused on B subtype, and some research is being carried out on subtype C. So when I'm talking about diagnosis of HIV, I'll be talking about how to detect HIV infection, whom to test, how to test, what are the protocols or different strategies of HIV testing at country level, how to interpret the test results, and what is the national policy of testing. So when we talk about detection of HIV infection, clinical symptoms of HIV infections, they are not very clear cut that we can say that this is HIV infection. So, and in most of the cases, acute infection, it may be asymptomatic and infection is silent until the last stages when patient presents with AIDS indicated conditions. So then the diagnosis has to be confirmed only in the laboratory by the laboratory test. That is why laboratory carries a lot of importance in diagnosis of HIV. So in the initial stages, when the person gets the infection, P24 antigen, it rises. And then it starts declining and the antibodies, they start appearing from 3 months onwards. Even sometimes at 6 weeks also they are available. And then this anti-HIV antibody we have to detect. And after that, in the later stages, the antibody, they may start declining or they may persist, and P24 antigen in the advanced stage of the disease, it again appears. So general principles regarding the testing, it is an overall comprehensive prevention program, and testing should be technically sound and appropriate, and results, whatever they are generated, they should be quality control results. And each and every test procedure, it should be appropriate depending upon where the testing is carried out, whether it is being tested in field or in laboratory. I'm not able to move my slide.
Just to press down. You have a control. Your PPT, you have a control.
I know, but I was earlier able to move down. It is not moving.
Ma'am, bottom right one controllers is there.
I'll stop sharing again and again do it.
Yeah.
So what is the purpose of HIV testing? That why the HIV testing is carried out? To prevent the transmission through any donation, prevent the transmission from parent to child, and it is to promote the voluntary counseling and confidential testing which is being carried out in all the ICTCs, and also for diagnosis, staging and monitoring of the HIV infection to enable the early detection and ART treatment. And when we have to estimate the disease burden, then surveillance is being carried out, and this STI surveillance is being carried out in country level since 1998, and in different risk groups and general population it is carried out, and then different surveys they are conducted to define the groups which need special attention, and also for post-exposure management in healthcare workers. So whom to test? It is in link to the previous slide that all the blood and organ donors, they should be tested. All those who are practicing high risk behavior, high risk, all STD cases, spouses of HIV positive individual, clinically suspected cases of HIV/AIDS. So whenever clinician they suspect in the clinic, they should accordingly send the sample to the lab. Children born to HIV positive mothers and contacts of positive cases. So contact tracing carries a lot of importance to prevent further transmission of infection. So different kind of tests, they are available for detection, that is antibody detection, which is mainly carried out in children and adults beyond 18 months. And there are ELISA or rapid tests available. And they are also used for screening and confirmation. And if there are indeterminate results, then Western blot test is carried out. Then antigen detection test, they are not carried out because they are having very less sensitivity, that is less than 30%. So that is why they are not recommended for diagnosis. Otherwise, detection of viral nucleic acid, which can be carried out in children less than 18 months. I'll be talking about that. That is qualitative and quantitative. Virus isolation, it takes around 2 to 4 weeks. It is costly and it is done only in few labs. And then the surrogate markers like CD4 count to define the category of the disease. So different HIV antibody testing methods are available. ELISA, rapid test. Rapid tests, they are available on the basis of different principles, that is particle agglutination, enzyme immunoassay, immunoconcentration, that is vertical flow, immunochromatography, that is lateral flow. And sensitivity of all these assays as per NACO guidelines, they should be more than 99.5% and specificity more than or equivalent to 98%. So approach to HIV testing. Whenever we suspect that the HIV infection is there, then they are sent to the counseling center, and all testing should follow 5 C's of counseling, that is consent, confidentiality, counseling, correct test result, and immediate connection to the services for HIV prevention, treatment, and care. So in ICTC, first pre-test counseling is done when the client comes, and after the informed consent, If the test has to be carried out, informed consent is taken, and then the sample is collected for HIV testing. And after the test results, the post-test counseling is carried out in ICTCs. And if the case is HIV positive, then they are referred to ART for assessing the clinical and immune status. That is, CD4 count is done, and ART is accordingly advised, and follow-up counseling as and when it is required. So there may be false positive and false negative antibody test results. There are some conditions like in where we can see false positive results. That is autoimmune diseases, multiple pregnancies, multiple transfusions, hyper-gamma-globulinemia, anti-polyester antibodies, patients with hepatitis, or it can be due to sometimes technical error, that is some labeling error or something like that. False negative in window period. So that is why we have to see whether patient is coming in window period by taking the proper history. In late stage of disease, sometimes it can be positive. We have seen one case when I was in Safdarjung, that patient earlier was an HIV positive by antibody methods. But once patient comes positive, it is indicated they shouldn't be tested again. But somehow that patient sample was sent to us again. And when we checked, it was negative. And when we went into details, we came to know that the patient is in advanced stage of disease. It doesn't mean in every advanced stage, antibody test will be negative. So sometimes we come across, then we have to be very careful while giving the results. And sometimes it can be technical error. So the antibody test, rapid tests, which are used as per NACO guidelines in all the settings, they are having a lot of advantages because we don't need any complex equipment for that. Small numbers of samples can be tested, and they are cost effective in small centers, and they are having very good sensitivity and specificity, and results they can be immediately revealed. And any person who can be trained, they can be used for this rapid testing. Only disadvantage is that if large number of testing has to be carried out, then they are time consuming, or they can be slightly more expensive than ELISA. Otherwise, considering the benefits, they are much more than the disadvantages. So if the results, they are indeterminate, then the Western blot test is done in the reference labs, that is state reference labs. And if the Western blot test is still indeterminate after 4 weeks, then it is confirmed by PCR at National Reference Laboratory. And PCR tests, they are able to detect 1 to 10 copies of the HIV proviral DNA. They are having very good.
Dr. Manjubala, we are 3 minutes away from schedule. Please continue.
Yeah. So this is immunoconcentration, and this is immunochromatography. And when we have to interpret the result in the reactive test band and control band both are present, in non-reactive only control band. And if the sample is invalid, then it is repeated. And if problem is there, then again, we have to see that there is some kit problem. So testing procedures, they are unlinked, anonymous, voluntary and confidential, mandatory. Unlinked and anonymous, it is in surveillance, voluntary and confidential in ICTCs, mandatory in blood banks. So this is strategy 1 of HIV testing, which is used for transplantation safety or transfusion safety. Only one test is carried out. If it is positive, then it is blood bag is discarded, and they are referred to the linked ICTC for confirmation. If it is negative, it is considered as negative. Strategy 2, where the 2 tests are carried out, and it is for surveillance. In sentinel surveillance, this is being used when 2 tests are carried out. If first test is positive, then reported as positive. If first test is negative, reported as negative. And first test as positive, then again carry out the second test. Then it is considered as true positive. And if it is negative, then consider it as negative. Then strategy 2B, which is used for symptomatic individual. If second test is negative, then third test is carried out. If third test is positive, it is considered as indeterminate. And if second and third, they are negative, it is considered as negative. But again, it has to be evaluated whether it is high risk or low risk. Strategy 3, for the positive cases, 3 tests, they have to be carried out by different principal kits. Only then the result is given as positive. So internal quality control, it has to be practiced at every level, at the level of specimen collection, storage of specimens, during labeling, while performing the test. while using the controls and while using the kits also. So IQSUI, it carries importance at each and every step. And when we are interpreting the results, there can be some pitfalls because patient may be in window period, or there may be false positive or negative results, or there may be discordant results. If there are discordant results in high risk, we have to follow up. There can be discordant couples, then we have to retesting is required. And if still the contact is negative, then safe sex practices, they are advised. And testing of babies, I will be talking about that. So EQUAS is carried out to ensure the quality of the results. Proficiency testing, it is being carried out. That proficiency panel is prepared by the reference labs, and then they are sent to the other labs. And then retesting every quarter, the samples, they are sent by the ICTC to the linked SRLs in the first week of the every quarter. And there is consortium of NRLs for checking the kit quality, and our lab NCDC is there in the one of the 4 labs who are checking the kit quality in this consortium. When we are talking about diagnosis in infants and children less than 18 months, then PCR test is recommended. But in less than 6 months, then early infant diagnosis protocol is used. So this is the flow chart I'll be talking, because this is quite a bit lengthy. I'll be talking briefly in this slide that how we have to carry out diagnosis in less than 6 months. It is by PCR. And if test is positive by DBS sample, then another DBS sample. If repeat sample is positive, then the baby is considered as infected and the baby is referred to ART for treatment. If repeat sample is negative, then another DBS sample is taken. Then accordingly, interpretation is done. And if HIV-1 is not detected, then baby is asked to visit at 6 months age for the testing again. And if baby develops signs and symptoms in between any time. Rapid antibody test is not recommended in children less than 6 months of age. If baby is less than 6 weeks, PCR is not recommended because PCR sensitivity is quite less in less than 6 weeks. And if 6 weeks and above, then PCR is recommended.
Madam Manju,
yes.
Time up, I think.
Okay, just one slide. In children less than 6 to 18 months of age, in between 6 to 18 months, then the 3 antibody tests, they are carried out. And if 1, 2, or 3 tests, they are positive, then DBS sample is used for PCR testing. So that is very important in 6 to 18 months, that antibody test followed by PCR test. And for diagnosis of HIV-2 infection, there are differentiating kits available, which are used at ICTC level. So ultimately, HIV test, it is not done in routine because it has to be carried out wherever it is indicated. It doesn't alone never stops the epidemic. HIV test results is a snapshot of someone's HIV status today. There is no guarantee from being infected tomorrow. So HIV prevention rests on individual willingness. Thank you. Thank you so much.
Thank you. Thank you.
Yeah, second chairperson.
Sir.
Second chairperson has to introduce the second speaker.
Yeah, that's what I'm waiting.
Dr. Tarun.
Mittal.
Tarun Mittal, sir, please. Umesh sir, you can call, I think.
If he is not there, sir, continue, sir. Ramanan, sir.
Ramanan.
I have great pleasure in inviting Dr. Jacob Maniar for his presentation on the latest guidelines for treatment of HIV and AIDS. And Dr. Maniar needs no introduction. He's a stalwart. And anywhere in India, just talk about Jacob Maniar, people will say, he'll associate his name. And he has done a lot of cases. I've seen several thousands. I think it across even the year 2021 also. So Dr. Maniar is not new. Dr. Maniar is not new to this audience. I request Dr. Manya to go ahead with his presentation. Thank you, sir.
Thank you. Yeah. Thanks. My sincere thanks to the organizer for giving me a chance to share my experience with you for last 36 years now. And I would like to say that I have a distinction of completing 1 lakh case in 36 years. And we have now 26,000 patients on ART under my single care. Globally, there are 38 million people living with HIV. The unfortunate part of the story is not everybody knows about HIV status. 79% knows, 62% on anterior therapy, 53% are virologically suppressed. New HIV infection has been reduced because of the antiretroviral therapy. What's the problem?
You have to share this.
One minute, sorry. Sir, why did you touch this? Huh?
We can't see your presentation, sir.
Yes.
Yeah.
क्या है? तू सुबह हाथ लगा रहे हो?
Slideshow.
तू क्यों अरे यार तू यार you are done a mistake. क्या तू कर रहा है यार? तो छोड़ दे तू. The epidemiology of India showing 2.1 million, the third largest epidemic in the world. And I think it's an underreporting. None of my 1 lakh cases have been reported. There are several other colleagues of mine who have not done a reporting. In India, we know that there are around 79%, which again, I doubt the figure, know their status, 56% on ART, and the people who are virologically suppressed, or we don't know the exact data. The sexual transmission is one of the the main cause of transmission today. Like syphilis, it's a multi-system disease. You can't be just infectious disease doctor. You have to be intelligent physician, dermatovenerologist to pick up all this system when you see patient clinically and go ahead with the further management. These are all 8 defining illness. I never saw any subject where you got something like disease-defining illness. And this is what you see, the big list of it, and something which I never saw before HIV era, the various list of diseases that you see, they're all my own collection. This is what I have seen throughout 36 years' time. The new advancement is you can treat cryptococcal meningitis with single dose regime rather than daily injection of amphotericin B with flucytosine and followed by fluconazole. A single dose. That is one of the advancement that the WHO has declared. What's the advantage of anterior therapy, the revolutionary stage in the HIV medicine? The advantage is it cuts down the pandemic, it cuts down the morbidity, mortality, it cuts down the incidence of opportunistic event, it improves the quality of life, it extends the expectancy of life, it cuts down mother-to-child transmission, it's cut down, of course, sexual transmission, and of course, the socio-economic improvement you might see. As you say, the number of Asia-Pacific country, again, what you see here is India has 56% of people receiving the anterior therapy. There's a big gap, and you can see the various countries have the very similar problem. People talk about NACO, which I'm not into the public-private partnership, but there are a good number of people, something like over 16 lakhs people under treatment with various NACO centers. There was a WHO target of 90% should be diagnosed by 2020, 90% on treatment, 19% should be virologically suppressed. But I don't think this target has, we failed to achieve the target. What India has, 79% of people are aware about their status, 71% are on the anterior therapy, and we don't know how many number of people are virologically suppressed. I know what is the status in my private clinic of 26,000 patients who are on ART therapy. Over 85% are virologically suppressed. Now, this is something unlike leprosy. I spent a lot of time in leprosy and look at the HIV. Every year there's a new molecule. Right from 1987 till today, you have a huge number of molecules available of various classes, of various potency, of varied side effects. What does the WHO say about when to start ART? I think ART should be started on anyone who is positive, irrespective of CD4 count, irrespective of viral load, and that is the saying today. Whether it's a children, whether it's a pregnant mother and breastfeeding lady, adolescent, infant, or whatever, whoever is positive, start off. And these are the various guidelines. WHO guideline and NACO guidelines are similar. What we are using now in ART center is DTG 3TC tenofovir combination. Alternatively, 400 milligram of efavirenz, FTC, 3TC, and TDF. In the Western world, they are using bactigravir as one of the first-line therapy, along with the TAF and FTC. There are various options available. Only my question is, if you have a patient who is on zidovudine, nevirapine, and 3TC, doing very well for last 18, 19, do we really need to change? My answer is no. There are various WHO guidelines as a preferred regime, as an alternative regime. We also have second-line treatment available, depends on what is your first-line treatment failing, but make sure before you switch, to think in terms of assessing adherence. Adherence is something which is very, very important. Same day ART initiation is like syphilis. When you see somebody with syphilis, diagnosed with syphilis, treat the same day with benzathine penicillin. The same way, there's a strong recommendation to start ART on the same day. These are the various drugs with different classes. There are quite a few in pipeline that I will show you, but this is a huge list in contrast to what is in the leprosy. Again, you can see the whole evolution. In 1983, we searched HIV right from 1987, single molecule of zidovudine. Now you have integral-based single tablet therapy. There are other new drugs. Now people are talking in terms of 2-drug therapy and different ways of delivery, injectables and so on, which I'll show you. What is most important is, if NACO says there are 60 lakh people being treated, how many people are retained in the care? Retention in care is the most important requirement for optimal clinical outcome of the patient with HIV infection. Please remember retention in care. Prevention of mother to child. Every mother who is pregnant, breastfeeding, and HIV positive should, without failure, without delay, to be initiated with antiretroviral therapy. That's the only way of minimizing transmission from mother to child. If you do not treat positive pregnant mother or breastfeeding pregnant mother, a breastfeeding positive mother, there are chances of 15 to 45% rate of transmission from mother to child. And if you give an effective anterior therapy, you could almost bring the transmission to 0 level. I have more than 350 deliveries since last 5 years, and our transmission rate is 0. So remember the anterior therapy in pregnancy and breastfeeding mother. Recommended therapy, suppose you've got a patient who's positive and become pregnant, so whatever stable therapy you or she is, continue it. Or you can today use even dolutegravir, tenofovir and 3TC combination, which is more or less safe. Again, what's the problem with the current anterior therapy, mainly integrase inhibitor? Weight gain. Please remember, today the talk of the anterior therapy field is weight gain. Almost every anterior causes it, especially integrase inhibitor, number 1, and 2, the new molecule called TF causes more weight gain as compared to TDF. Despite anterior therapy, people after starting anterior therapy have an immune recovery and they still fall sick. It's called the reconstitution syndrome, which can occur at any age. It can occur after 4 to 8 weeks of therapy. And the number of percentage of people who get immune recon syndrome varies, right from 5% to 25%. There's something like paradoxical iris, that is the worst, the current illness getting worse, or unmasking iris, that means appearance of the newly diagnosed OI after initiating ART. Please remember, as soon as the opportunistic infection has been treated and the treatment is well tolerated, you should start anterior therapy, except in few cases such as TB meningitis, cytomegalovirus infection. One should delay the anterior, or cryptococcal meningitis, we should delay the anterior therapy. These are the pictures of the immune reconstitution syndrome clinical pictures such as herpes zoster, leprosy, tuberculosis, lymphadenopathy, and HSV, or PCP, stomatitis, progressive multiple leukoencephalopathy, or autoimmune thyroiditis. What were the causes of death before ART era? TB, non-tuberculous mycobacteria, PCP, toxoplasmosis. Now it's an anti-liver disease, kidney disease, non-Hodgkin lymphoma, heart disease, and so on. The important point is that what's happening with HIV in aging? Our aim is to suppress the viral load. All the people are now living with HIV and they're doing very well. But the life expectancy is almost 10 years gap, lesser than the general population. People still fall sick. Why? It's because of the comorbidities or non-communicable disease development, cardiac disease, cardiovascular disease, hypertension, non-age cancer, osteoporosis, kidney disease, cognitive decline, or a liver failure. There is an urgent need to integrate multi-specialty treatment with HIV. Managing comorbidities involves drug-to-drug interaction. PEP is an emergency intervention to abort HIV acquisition, either due to occupational exposure or non-occupational exposure. It should be started within 72 hours. The drug of choice today is tenofovir, Aptisi, and dolutegravir, and there are various alternative drugs too. The risk of the risk is aborted after PEP up to 80% if well taken. Second point is, for a sexual exposure, if HIV positive SARS is documented to be undetectable viral load, there is nothing to worry about PEP. To tell Manju Bala to add to what she says, even the people seeking pre-exposure prophylaxis should be HIV tested. It's one of the best treatment today in absence of vaccine and cure to end HIV epidemic. It is the treatment that is given to uninfected individuals who are at high risk behavior. The drugs that is approved are two drugs called tenofovir and Aptisi, or TF and Aptisi. And now we have monthly injectable cabotegravir, ripivirine injection intramuscularly, and make sure the people who are on PEP are well periodically seen. They have to be tested for STDs and HIV every 3 months so that we can intervene any progression. Undetectable equal to untransmissible. That's very important finding for last couple of years. And we have a project of offering parenthood to the discordant couple or a gay couple. And it's a natural sexual relation. We are almost 320 couple, both serocordant and serodiscordant. None of the children are infected. And we have 5 gays whose semen was injected into the surrogate mother and the babies are non-infected. We now think of 2 drugs. Why 2 drugs? Why not take 2 drugs when, if it works, rather than take 3 to 4 drugs, the less cost, fewer side effects, and you spare the menu. And nowadays it's an era to start dolutegravir, lamivudine, which is a non-inferiority viral suppression instead of 3 drugs or 4 drugs. Once the patient is virologically suppressed, you can switch over to 2-drug therapy, that is the dolutegravir and 3TC. Nowadays, there's a feasibility that even in a test and treat policy recommendation, you can start off with the DTG and 3TC as a first-line treatment. And during workout, if you find that the patient's got a transmitted resistance or hepatitis B co-infection, you can make the drug triple. There is nothing lost in that particular period. Or now, person who are on 3 drugs, virologically suppressed, can be given long-acting cabotegravir and rilpivirine therapy every month. This is one of the options. There are other 2 drug regimens are dolutegravir, rilpivirine, cabotegravir, rilpivirine, or islatravir and doravirine. There are now, you can use implant, you can use patch every year. And the last slide, what we have learned in last 25 years. ART controls viremia. It enhances immune function. It prolongs survival. It prevents HIV transmission. The current ART is potential, is tolerable, is convenient, and increasingly available. What are the challenges? Drug resistance, toxicities, cost. It doesn't cure HIV. Or life expectancy remains reduced on ART. Ongoing morbidity on ART. Funding lifelong ART is possibly unlikely. Thank you.
I request Tarun Mittal sir to continue the further proceedings, calling the moderator. And thank you, sir. Thank you, Mania sir, for the wonderful presentation.
Dr. Tarun Mittal and Dr. Shilbate, both. One will invite the moderator and other the panelists.
Mittal sir, are you there?
Unmute yourself. Tarunji, unmute.
Yes, I am there, Dr. Bhumesh. So at the outset, I would like to congratulate the whole team and Dr. Bhumesh for this wonderful conference. And it is a really good one. And post-COVID, this is what I feel.
Sir, your voice
words,
is
I would request the moderator.
Yeah.
Problem. Hello.
Your voice is breaking. Carry on.
Okay. So I would request Dr. S. Murugan, sir, as the moderator. He is a consultant in sexual medicine and HIV medicine at Shifa Hospital, Tirunelveli, and he is a former professor of dermatology venereology at Mukambika Institute of Medical Sciences and a former professor at STD, Government Mohan Kumar Mangalam Medical College, Salem, and at Puducherry. Has published more than 64 papers, has been an executive member of CSEPI, national president of IASTD, has so many laurels to his. I would request Dr. Murugan sir to kindly come forward for the moderating this session.
Dr. Shirubate will introduce the all panelists. Please go ahead. Srinivas, next panelist. Dr. Shirubate ji. Dr. Shirubate is there?
Sir, you continue. I think he is.
Yeah.
Somebody is sharing the screen.
No, Shirubate is there?
Should I continue, Dr. Bhumesh?
Yes, sir. Yes,
I think you can go ahead.
You do one thing. The Srinivas, stop sharing.
Yes, stop sharing. Now, shall I share?
Hello.
Yes. Now, am I visible?
Yes.
You can hear me?
Yes.
Yes, sir. Continue.
Yes. Good afternoon, everybody. Thank you, the organizing team, for wonderful arrangement and giving me an opportunity for sharing my view also. And this session is going to be having clinical progression of HIV disease. One should understand the clinical course of any disease before going to management. If we are not able to understand exactly understand the whole process of the progress, if it is syphilis, if it is tuberculosis, if it is psoriasis, we have to understand the progression or clinical course of any disease. So this is the topic, and especially in HIV, it is a complicated one. So we are going to discuss about this clinical progression of HIV disease. And I am having wonderful panelists, 6 panelists are there. First panelist and Dr. Sudhakar Babu. He's a medical superintendent and professor HOD in academic coordinator in AIMSR Chittoor, and he's an ex-serviceman, and he's a wonderful. He has published many papers also. Then next panelist Dr. K. Mahadevan, and he is a professor and HOD in PhD Institute of Medical Sciences Research in Coimbatore. And he is a lifetime awardee of IASSTD and also in Coimbatore IMA, and he is a past president of IASSTD and AIDS. Dr. B.N. Reddy is another panelist. He is a professor of City Institute of Medical Sciences and retired from Usmania Medical College, and he is a organizing chairman of PTCon previously. So he is also there. And Dr. Parthasarathi is a young man. The Deputy Director, Accelerate Project of John Hopkins Institute, Hopkins University School of Medicine, Baltimore, based in Telangana, the Hyderabad program. And he's very much interested in HIV prevention, and he's a specialist in program management and clinical monitoring. He's also with us. Dr. Rajesh Rajagopal is a professor of and HOD in Skin and STD in Government G Road Medical College, Perundurai, and he is associate director for IGSTD and AIDS. Dr. Vasiki is professor of dermatovenerology in KPV Government Medical College, Trichy in Tamil Nadu, and she is also physician. She is attending every conference, and she is very much interested in HIV and STD. Now, before going to the subject, prevalence of HIV in Indian context. India has the 3rd largest HIV positive population in the world, next to South Africa and Mozambique. Nigeria was in the 2nd place. Now, the 2019 statistics says Nigeria came to 4th place, Mozambique. Between Mozambique and India, only just 1 lakh cases were different. Maybe India came once again the 2nd rank as previously. So we have to be very careful when handling this disease and preventing aspect. Nationally, we estimated nearly 2.3 million cases, and they say ranges also. Annually, we are having nearly 69,000 cases HIV new infections. Now, my panelists, I am asking one question. Do you think this 2.3 lakhs, 2.3 million cases of HIV is true, or what is your opinion? Dr. Parthasarathi, you are in prevention. Dr. Parthasarathi, please.
Sure, sir. Thank you, sir. First of all, thank you, Dr. Bemis and entire organizing committee for this wonderful opportunity. Basically, any chronic disease we can only go for estimate rather than any specific measures and so on. So that's the only reason why we have to rely on estimates. The question here is like, is the estimate accurate enough? The point here is, these estimates are based on UNAIDS approved strategy of spectrum modeling that uses AIDS impact model, which is generated which is followed across the globe by the epidemiologists. The nitty-gritties of this model is it uses the AIDS mortality, HIV-related mortality, segregated by CD4 count, segregated by age, and segregated by ART status, whether on ART or death happened without ART. In addition, it also segregates the data based on key population and children. So in that context, to estimate the disease prevalence or incidence in the community, they also look out the fertility rate, especially fertility rate of key population, that is high risk group, because in India, our epidemic is concentrated more among the high risk population, including female sex workers, men who have sex with men, people who inject drugs, transgender population, and so on. And another limitation here is like most of the times these kind of models are based on the practice from Africa, not from any other continent, although there is some scope to integrate models from the learnings from India as well. And the other limitation is like we don't have key population estimate after 2008 and 9. That was the only time when we did, the country India did larger estimate of the key population. But it is only regional exercises there. So these are all some of the limiting points of these estimates. But despite these limitations, all the data points, whatever program points, whatever available, sans the issue related to the quality of data such as duplication and so on. And again, as Dr. Maniar mentioned, the private sector data. These are all few additional practical limitations of these estimates. But despite all these estimates, the UNAIDS endorsed the model practically applies whatever is best possible with any given country to come out to do these estimates. So this is not only the issue of India, but also across the globe. So most likely for any program management monitoring, we have to rely on estimates, although we don't know exactly whether this is.
Thank you, Dr. Parsal.
Yes, sir.
More than technical, what is your general opinion, Dr. Vasi, madam?
Sir, as he and Dr. Maniar pointed out, I want to emphasize on private sector notification.
Yes, that's what I want.
Some HIV practitioners may notify the disease, but not all. So that is my opinion. NACO has built up this with the private and
correct. That's
program.
Rajesh.
Yes, sir. Like COVID, we have to have a formula for identifying and bringing it to the thing. And another thing is that the HIV epidemic, which is peaked in 2000, is declining over the years and stabilizing. And of course, there is a slight rise of HIV in the Mizoram, Nagaland, and Manipur as per the 2021 statistics. So definitely, we have to see to it that those cases are brought. And then, except for that, those states which are reporting more, that is 55% are from Tamil Nadu, Andhra, Karnataka, Maharashtra. And they have seen that other states, there is a slight rise in the people living with HIV/AIDS. So we have to have a stringent measure so that our NACP is implemented well.
Ready, sir? Ready, sir? Dr. Mahadevan?
Sir, in spite of having this public-private partnership, I definitely say it's underreported. And even if they come forward, since it's a chronic disease associated with a lot of stigmatization, they don't come forward testing. Even if we test also, I don't know how many of you are reporting to the NACO. Example, now I heard Dr. Maniar's lecture, he has got 1 lakh cases.
Yes.
I don't know whether they all are reported to NACO or not.
Correct. Mahadevan, please. Yes. Last month, I have seen 4 cases, new case. In my OP, my place is not a cosmopolitan city. And this month I see 1 case. And Dr. Maniar is telling he's treating, already had seen 1 lakh cases. There are so many private practitioners handling HIV cases. All these cases are really included or not. It's a very doubtful thing. I think even though they have put, there is a range is there, they have put, even then it must be more than that it should be, I think. Next. WHO staging of HIV disease. This is the old staging, but it's no longer holds good because after the policy of treat all. So we are not bothering about that. But anyhow, the clinical progression of HIV is window of opportunity, window period, acute infection or primary HIV infection, clinical latency, and AIDS. The window of opportunity, that is 72 hours, that when the organisms gets entry into either mucous membrane, through mucous membrane or the skin, and it's recognized by the dendrite T cells and taken to the lymph nodes and presenting there, and the lymph nodes is processed and enters into the circulation, and in the circulation it finds the CD4 cell, and transcription takes place and the integration takes place. Is up to that it is entering into the nucleus and settled. Once settled means we cannot do anything. So up to that we can do. That is called as window of opportunity, that is 72 hours usually. So this is in that 72 hours, if we are giving PEP, we can modify the disease, but we are not going to touch window of opportunity much. And we are going to discuss about the window period, acute infection, clinical latency, and AIDS much. So AIDS defining disease, as Dr. Mania told, not only defining disease, AIDS indicators are there, AIDS letters are there, so many things are there. So according to the immune deficiency in the patient, the disease patterns differs. Normally, the CD4 count is anything range from 700 to 1200. If it goes below 450 and the patient manifests, and mostly the HIV manifestations are due to immune deficiency. So this is the, according to the immune deficiency, the disease advanced conditions are AIDS different diseases are coming. And window period. So window period is one of the thing. Time taken by the body to develop antibodies against HIV infection. Any infection, the body will take its own time to develop antibodies. That is called window period. Normally in HIV, it is around 4 to 8 weeks, and it may up to 12 months and never up to 6 months. Test, usually antibody tests we are usually do, point of care tests are cost simple enough and cheaper. So we are depending mostly on antibody tests. These antibody tests are negative during this window period. That is very important. So during blood transfusion or during transfusion, they used to screen the individual with the antibody test only. So in that situation, there is a likelihood of transferring when the patient is individual is in window period, they are infective and the blood will be transfused, the individual may likely to get the infection. Likewise, he may be able to, he is otherwise healthy, sometimes he may transmit the infection to others. Whereas the molecular test may be positive, that's also some difficulty is there. A 25-year-old married man was brought to, unmarried man was brought by his mother, his father no more, and for the complaints of melancholy and depression with a suicidal tendency. Some noise is coming. And he had sexual intercourse a week back under the influence of alcohol along with his friends. Somebody told that she was HIV positive. He was crying in my OP and he wants to get suicide. And his mother was very much upset. He was having severe tendency for suicide and consoling was not effective. Somehow or other, I managed with the HIV, the DNA PCR test. I made him wait and convinced. Such a condition we will come across. The HIV phobia is very, very common. Nowadays, especially online also, we are getting daily, monthly 3 or 4 cases. Everything, touching, itching, and nail scratching, everything they are doubting. Am I audible?
Yes, sir. Yes, sir. Continue. Yes, sir.
Some noise is coming. I will remove my, I will remove my, I think. So, just by molecular test, I was able to convince him, but every panelist would have come across such a situation. What is your experience about this? Even the molecular test, that's a molecular test, HIV-1 only will be positive. We have, if you want to rule out both HIV-1 and 2, we have to go for separate PCR test for HIV-1 and separate PCR test for HIV-2. That is another thing. And also the molecular test also will be more reliable, even though it is become positive within 7 days to 10 days. And it may be more reliable after 3 to 4 weeks. The patient may not be able to wait at that time, till that time. So patient will be agitated. So many cases are there. What is your experience about these things, Dr. Parsari?
Yes, sir. So we have come across many such cases in my practice as well as in during when I was in government service, sir. The primary thing what we follow here in these cases are the counseling with respect to the suicidal ideation or tendency whatsoever. So that should be the primary thing. Especially even referral to psychiatric department if the client is willing will be the better strategy. And second, as you rightly said, the PCR test has to be done at least to give some kind of evidence-based counseling and guidance. But of course, we cannot rule out any HIV positivity within 6 weeks, even if it is PCR or whatsoever, P24 antigen and so on. So counseling and tests with serial follow-up of antigen antibody tests should be the strategy in similar cases, sir.
Thank you for sir. Dr. Vasi, madam, what is your experience?
It's the same thing. I am telling the same psychiatric counseling and referral to a psychiatrist if the patient is so panic. Because even with more sensitive assays, there is a blind spot in diagnosing immediately after a sexual exposure or take a needle stick injury. We cannot diagnose immediately after those events. So the patient has to wait for 3 to 4 weeks. Till that time, counseling will help.
The HIV phobia is sometimes very difficult to manage, and even they may not. Sometimes they may refuse to go to psychiatrists also. When they're and sometimes some other patients with the repeated counseling, they will be able to be pacified. Dr. Rajesh,
single test is not enough to say. Actually, in HIV medicine, any positive test should be again reconfirmed. Moreover, this is a DNA PCR whose sensitivity is less than 50%.
Sir, we know, but it is just to pacify him. We have to convince him whether it is enough or not. That is different. But we have to reduce his anxiety, tension. That is very important. That is Dr. Rajesh.
Yes, sir. This is a typical case of HIV phobia. First of all, we have to have a proper sexual history, whether he is having any previous sexual exposure and all. After that, anybody phobia patient, which is an illness anxiety disorder, referral to a psychiatrist should be considered only in the 3rd or 4th sitting. By the time we can tell the patient, and we can have a serial battery of tests, what I have told you, and then patient himself may know that it will be positive by 3rd week or 4th week, like that and all. So we can buy some time. Meanwhile, we can put the patients on some antidepressants and anti-anxiety agents ourselves. Otherwise, we can have a colleague side by, so that maybe in the next chamber we can take the patient there and then do it. Instead of definitely referral, I don't do it at all. I take him to the clinic. He says that he is a bigger doctor. He will do much better counseling. By that, I have learned therapeutics as well as counseling also. So see, we can have to buy some time.
Thank you, Rajesh. Dr. Mahadevan.
Qualitative PCR, sir. It is not quantitative. We have to do qualitative PCR.
Yes. Dr. Mahadevan is there?
Yes, sir.
Sir, what is your opinion about this window period and HIV phobia, sir?
So, the phobia is always there. Even among the COVID period, people have gone to massage parlors and other areas, and now they are afraid that I have got a creeping sensation. Everything that, as you told, they are telling all sorts of things. But it is not only DNA PCR which is going to help him. We have to counsel him that this test, around 50% of the time, it may be positive or negative, we can take it. But anyhow, you have to go for the regular test afterwards. 6 to 12 weeks later, you have to go for that. We have to counsel and counseling again. That is the basic thing. And it is still very difficult. We have to send them to the psychiatrist. And 90% of the patient will not go to the psychiatrist.
Yes.
They will come back to you only. You tell, sir. So what I do in my practice is I show them the books, and this is what the book says. And we are following the books only. You just read that. And I will, with the book, I will explain. So now they are a bit okay. And the problem with many of the people is they go to the Google, they search for the symptoms.
That's another problem. Yes.
Symptoms only, they look for the symptoms, and they don't believe the blood test at all. They are oriented towards the symptom that aggravates the phobia. So that is the problem.
Yes. Thank you, Mahadevan. Acute infection or primary HIV infection or seroconversionness. Usually the symptoms of primary HIV infection may include non-specific flu-like symptoms such as fever, swollen glands, a sore throat, oral ulcer, thrush, weight loss, tiredness, body ache, vomiting, or a rash. This is also called as seroconversion illness and usually occurs 2 to 4 weeks after the infection. Symptomatic seroconversion illness occurs in the 50 to 70% of the patient individuals, not with all. Immune system is weakened, CD4 will go down, and viral load will be very high.
Others, please mute yourself, please.
Mostly it's self-limiting, resolve within a week or two. And but this stage is usually go undetected, as these flu-like symptoms are common with many illness. We will not suspect primary HIV infection unless the individual reveals recent history, present as an ordinary cold or sore throat, used to be treated with tablet paracetamol or sometimes at the next stage antibiotics. By the time we start investigating, it will subside. So the physician will forget and the patient also will forget. So usually go unnoticed. So what is your opinion about these panelists? Dr. Rajesh?
Sir, I have seen a case of 2-3 cases of acute HIV.
Very good.
First, actually, the patient was presenting as a rash. So at that time, he was in a private clinic. I diagnosed as a case of some evolving pityriasis rosea, and he gave history of exposure around 3 weeks ago. So it was, and then I instituted an azithromycin and topical emollients, and then asked him to bring back. On the third day, he brought with the test. So he had, because since he had 3 weeks of exposure, I advised him to go for qualitative PCR. Then at the time, it was not, CD4 cell count was quite good, sir. So second case was that he was from a house surgeon. After listening to the lecture from Dr. Mohan Kumar, he went and in a case of acute diarrhea in the ward, he elicited the history of exposure, and he came and asked me whether we can do the test and all. Since the patient was affordable, he could do, and then that patient also passed. So these are the 2-3 cases which I have seen. Sir.
Okay.
So only thing is that symptoms are non-specific.
Yes, that's correct. But whether we can confirm, this is due to acute infection, only with the history and other things we can do.
Yeah.
Mahadevan?
There are no specific signs and symptoms for.
Mahadevan, please.
I had a case last week, sir. Some 4 weeks back, he had a contact with a transgender, oral and anal both, insertive and receptive, all things. And he came with a sore throat. I thought about pharyngeal gonorrhea or something like that, or any chancre is there. I looked for those things. Then I sent the patient to the ENT department. They said nothing is there, mild congestion is there. He came back and ordered for DNA PCR as well as ELISA also I got, because he had previous contacts also 1 year back. So I ordered for ELISA also. Both came as positive, and he got only running nose and sore throat. We also did it for COVID also. We did the test. It was negative. And this was seeing
Thank
this.
You, Mahadevan. Dr. Vasi, madam.
Sir, I also had long ago, I had 2 patients. Those are marital partners of HIV positive individuals, and they presented with this non-specific symptoms only. But at that time, ART, that is the diagnosis after starting ART after diagnosis was not there. So I treated only symptomatically. And recently I had an MSN, and he presented with flu-like symptoms, and I started him on ART.
Very good, madam. Sudhakar Babu.
Yes, sir.
Highlight your experience.
Sir, sir, I have seen.
Long ago, I had 2 patients. Those are marital partners of HIV positive individuals, and
not heard properly.
Hello.
Yes.
Sir. Sir, I had
disruption is there. Ready, sir?
Yeah, it's actually very difficult to diagnose. And maculopapular rash, what we get as a viral exanthem in some cases, because of our skin color, Indian skin color, very difficult to diagnose. Even if you confirm with available tests, and only in 2 circumstances we can diagnose. One is post-exposure prophylaxis, and another is in discordant couple where there is a transmission. So in 2 such situations, actually we should suspect and do the proper test, and you should start ART as early as possible once it's confirmed.
Sudhakar, want to tell something?
Yeah, yes, sir. Regarding acute infection, I had about 2 to 3% of my cases wherein they could point out the flu-like symptoms. So they keep on asking for the test. If we do it and say negative also, they will go to several labs and get it done.
Yes.
Won't believe you, because they Google it so much that it gets into their brain that they are having disease. So
Yes,
as
yes.
you said in the first slide, so we have to sometimes we have to get the test done, antigen PCR screening test for pro-DNA or DNA, and then convince the patient, ask him to come back again. We should not leave the patient unless we have the confidence that patient is following and having confidence.
Okay, we'll have some other case. Sir, you told something about some case, some test is there to detect earlier rather than the DNA PCR. Is there anything like that?
Yes, sir. So there are two kinds of, one is practical modality, other one is emerging research-based modality, sir. Practically what British guidelines and other people say is like, when we suspect this kind of acute HIV infection or so-called primary infection, they say qualitative test to diagnose HIV and then antibody test also along with viral load test. So if somebody is positive with antigen or qualitative PCR with a high viral load in the quantitative PCR with absence of antibodies, that means that that individual fits to the diagnosis of, as per laboratory diagnosis, fits to the category of primary HIV infection, and we have to treat the individual at the earliest with highly active antiretroviral therapy, sir. This is regarding the practical modality, but right now CDC and other global bodies are coming up with a test called recency testing. So recency testing, basically it depends on the avidity of antibody. See, technically, you know, I'm afraid to talk about microbiology in front of stalwarts like Dr. Manjubala. Just a quick line. Avidity of the antibody means a binding capacity of the antibody. The older the antibody, the better the binding capacity with antigens, so that it will form a strong antigen-antibody complex. Whereas recently developed antibodies, they don't have that kind of binding capacity. So we use limiting antigens to detect those recently developed antibodies. If a person is having antibody of a recent development, not of a chronic antibody with high avidity, that means this is recent infection. That is called recency test. And Stadia and Maxima are two brands available right now, but still they are not available commercially. It is still available in the
very informative
purpose.
Thank you, sir. We will lack of time will rush.
Sure, sir. Thank you, sir.
25-year-old lady got married just 8 months ago. Till then, she was very all right and had suddenly developed fits, became unconscious 1 month back and got admitted in a corporate hospital in Madurai nearby my place. And after 1 month, she brought to my place and she was unconscious, reactive for HIV1 and viral load was 285,500 copies, Western blot reactive for HIV1, CD4 count 254 cells. Antibodies against CMV, HSV1, rubella were detected both in blood and CSF. She was started on ATT ganciclovir in the Madurai itself. It's the previous hospital itself. Patient was on ventilator for 3 weeks and she had respiratory failure because she had respiratory failure. Ganciclovir stopped after 3 weeks after coming here because severe neutropenia was there. Patient was put on tablet valcyclovir 1 gram twice daily and response to painful stimuli was present. Response to commands variable and unpredictable. She was respond to only to her mother's command, not anybody else. But she was not at all respond to other thing. Patient was put on valcyclovir tablet, cotrimoxazole, ATT through Riles tube. Patient succumbed to death without responding to drugs after 2 weeks. Prior to the date of her illness started, she was healthy, absolutely healthy, active as per her relatives. No obvious history of previous illness. Her husband was reactive HIV1. He is in a stage of refusing and not cooperating. He is not ready for any other test. He looks otherwise healthy. His attitude is denial. And in the previous treated corporate hospital, her condition was suspected to be CMV encephalitis, and they started ganciclovir as a presumptive and also presumptive ATT. There was no response to ganciclovir or ATT. Instead, ganciclovir toxicity made her worse. Her parents were non-reactive for HIV and they are healthy. Now, panelists, what are the possibilities in this case? Dr. Vasi, madam?
This could be, as far as I know, I am not a neurologist, this could be a HIV meningoencephalitis. Acute infection may present, rarely may present like this.
Yes, acute infection so severe. We used to come across flu-like syndrome, rashes, but such a severe syndrome, could it be acute infection? Because no other way. She's recently married, recently exposed. Dr. Mahadevan?
She may be a rapid progressor sometimes. Sometimes because it is a
Mahadevan, your voice is little low.
I think now it is okay.
Yeah.
Yes, sir.
Yes.
It may be an acute HIV infection because it is a neurotropic virus. Even in the first stage itself, it can be a neurological manifestation.
Direct AIDS virus infection. Okay.
Yeah, sometimes it can happen. Otherwise, it may be a rapid progressor going for these things.
Yes.
That is another thing.
But one more thing, the presence of HSV1, CMV, rubella antibodies, usually many of us will have. If you have been tested, madam, you are a physician, you may be telling more.
Antibodies commonly present, antibodies to all this are commonly present. Only if we deduct the DNA PCR of these ages, it is confirmative.
Reddy sir, want to add anything?
Yeah, as we advance in age, we become positive because of all these viruses you mentioned, CMV, HSV1, and definitely I will consider ART treatment, thinking it's a acute HIV infection.
Toxoplasmosis cryptococcosis has not been ruled out in this case because she was very ill. We have not able to transfer to MRI. Dr. Sudhakar, want to tell anything?
Sir, yes, sir. I have to say that firstly, precocious AIDS is known for all of us. Precocious AIDS.
Precocious syphilis, like precocious syphilis, precocious AIDS.
Precocious.
Okay.
And secondly, they might have the test was not done prior to marriage, so we don't know when was she infected. So husband is just positive, whereas the wife has developed all the rapid progressor symptoms and she died. So maybe PMLE, progressive multifocal leukoencephalopathy, associated with cryptococcosis or CMV meningitis. These are all the things which may be there, but we cannot rule out the infection before marriage. That's one point I would like to stress.
Okay, good. Rajesh, want to tell anything?
Yes, sir. Yes, actually, I agree with Dr. Mahadevan, sir, as it's a case of rapid progressor. And also, she can be rapidly deteriorating in the acute stages. The viruses like Epstein-Barr virus, cytomegalovirus, and bacteria like treponema and tuberculosis, these organisms, they get triggered or activated in the stages. So they could act as a co-pathogen in mortality and morbidity of acute HIV, sir.
Yes, that's possible. But what is the thing which can trigger? That's also we have to look into. Okay, we will see. Rapid progressor are defined as progression of HIV infection into AIDS within 3 years. So, okay, this is a possibility. Another case, that is a middle-aged man, male patient who was on ART treatment, suddenly developed fits, unconscious, disorientation, MRI suggestive of, that is a progressive multiple leukoencephalopathy. CD4 count was above 500, that is 500 cells. We lost this patient also. Usually, PML is one of the AIDS defining disease. And another case also we have seen PML and that's what 400 cells per cubic millimeter. Usually that PML is caused by JC virus, John Cunningham virus. And this John Cunningham is not a doctor, he is a patient first who suffered from that. And is no specific treatment, only the ART and the immune boosting only is a correct treatment. And but in this patient, what is important is usually PML is AIDS defining. This is usually occurring when the virus CD4 cells below 100. But here, these both patients, we are getting the CD4 cells more than 400. So some patients, other AIDS defining diseases also, sometimes we get patients who are having CD4 count more than 350. This is also one of the puzzling thing. I think, what is the opinion of panelists? Dr. Mahadevan?
Usually, you have not mentioned how long he is on ART and other things. So we don't know how long the patient was having the infection. To PML to occur, it should be a very long period classically because the CD4 level has to come down. But here the CD4 level is not bad. And still he has developed this thing. So
yes,
maybe
rather than duration, the CD4 count only will be usually a marker.
That is the only marker available now. So again, he may be a rapid progressor, and the CD4 count has suddenly dropped, and he has developed PML.
Rajesh?
So,
Actually, I agree with Dr. Mohan, sir, Dr. Mahadevan, sir. It could be a case of rapid progressors, sir. So we have several type of progressors like slow progressor, long-term non-progressor.
Yes, I will show. But
Yeah,
rapid progressor, the CD4 count should come down. The CD4 count remains good and progressing to age-defined disease is a controversy. That is a paradox. Not Vasi, madam.
In the post-ART era, AIDS-defining diseases are occurring at a higher CD4 count. That is something.
Yes.
This is your experience or coming up with any literature?
Experience, sir. I have studied and I have told that.
Okay. Sudhakar?
Yeah, sir. Sometimes the virological failure due to the resistance developed for the regime. So that is one thing. So the treatment which was being given may not be sufficient to control him. And as my predecessor said, it may be rapid progressor also, very rapid progressor. But there must have been some comorbid condition which has caused this.
Okay, next case.
A quick point to add, sir, Murugan sir. See, always we bother about the quantitative CD4, but we forget the quality of the CD4 as well.
Okay.
Quality as well with respect to cytotoxicity and things like that, sir. So
competent, the T4 cells are not so competent enough.
Yes, sir.
Okay.
One more thing, CD4 count, diurnal variation is there. So at the sometimes it varies due to spurting. So we cannot take one test as the standard test. That it might have been gone to 200 also. 500 is one test, one time.
Usually the spurting or blips are just 50 cells, not more than that. Yes, okay. That's we'll go to next case. 43-year-old male found to be HIV reactive while trying for an immigration clearance at his age of 22 years, confirmed by ICTC in 2002 and 2003 by ORG Care Chennai, and he was promiscuous previously, and he is a state level kabaddi player in 2000. During 2000, he is a leader for positive people network since 2003. His CD4 count is during 2004 was at 1276, and he at that time he was not fit for ART because treatment was not there at that time. He married a HIV positive woman. Previously married, that lady was married to another man and having 2 children for her first husband, and that was during 2006, and she also positive for HIV-1. She was on ART since 2003. Prior to that is in our center, we government national rollout from 2004 only came. A sample program started Tambaram in 2003 itself. She had 2 children for her first husband, and they have 1 child and born to them, and the child is also non-reactive, and that man is practicing unprotected sex till date, sometimes coitus interruptus as a measure of preventing further conception. Her CD4 count is maintained above 700. Her viral load remains undetectable. This man remains CD4 count remains more than 800 always. That is in the 2018 898, 2019 1100 and 1297, 2921 and 21,397, and his viral load is 3,671. So 22 years after this infection, and he was not on ART, and he is maintaining the CD4 count above 3,000 cells. Every parameter, other CBC and other things, WBC count is 11,900. That is a differential count, a lymphocyte 32%, and everything, that is hemoglobin was normal, everything was normal. Every one of us treating so many HIV patients in since 3 decades, we had seen patients manifesting symptoms after 7 to 10 years or more, and some instances even 13 to 15 years. But we observe all these cases slow and steady decline of CD4 cells as a rule. But those manifesting symptoms after 12 to 15 years are called as long-term non-progressor. But in this case, the individual remained immunocompetent with a normal CD4 count even after 21 years with taking ART that is called as elite control. Elite controllers are HIV positive subjects who control the viral replication without antiviral therapy. The subsets of elite control was further distinguished viral control, viremic controller who is having mild viremia.
Dr. Murugan, just a reminder, you're 5 minutes away from the scheduled time.
Oh, different controllers are there. Where elite control, viremic controller, exceptional. That's a viremic controller. That's how it is possible for some. They remain without ART, without taking anything, and remaining immunocompetent for very long time. Is there any possibility?
Sir.
Yes.
There are
yes, they may be having potent T cell responses, and also
Yes.
the physical and mental well-being and nutrition is very, very important. And they may have some genetic factors behind this also.
Yes, yes. All the individual is having detectable viral load in this blood. We cannot tell them labeling as sterilized cure is functional cure only. These patients are supposed to have protective HLA alleles, potent T cell response, as Dr. Rajesh told. Multiple factors, the viral factors also there, and these are the factors. Long-time non-progressor. And another girl I have seen that is in utero transmission. That is another case. Sorry, 28 years old man referred to me for HIV positive with extreme cachexia, oral thrush, thin belt, difficulty in move about, and he is an engineering graduate. His parents were no more and said to be died of HIV 10 years back. Possibly he acquired it through mother-to-child transmission. Patient was detected to have HIV infection during 2008, but was multivitamins and is cotrimoxazole. ART started in 2018 with the TLE, tenofovir, lamivudine, efavirenz combination, onward diet, etc. But he was not at all taken a single pill. Attitude of denial, refused to believe, thinking all the drugs are bad. Before got admitted, he into the hospital. Due to sickness, he was taking it for the 15 days, half a tablet, half a pill, and he had broken all the tablets into half. And his CD4 count was 30 cells, and viral load was more than 6 lakhs copies. Extensive oral thrush was present, and the patient was in utero transmission. HIV positive individual can pull off his life 28 years without taking ART, and disbelief, denial status for the refusal of treatment. Modification of treatment on their own, believing all the drugs are. Can we call him as a long-term non-progressor? Rajesh?
Sir, we cannot say like that because now that he is deteriorated, and of course, since actually the
till 28 years, he was not taking treatment. Now only he had very bad shape. Vasi, madam?
Yes, sir. We have come across cases like this, not up to 28 years, cases diagnosed at 25 years, vertical transmission like that we are having, but the rate is less. But long-term non-progressors can have vertically transmitted people can be a long-term non-progressors.
Oh, that's correct. Parthardi?
Yes, sir. Like a similar discussion what we had in the earlier case, this patient also may have mutations related to surface antigen or HLA allele or to the viral fitness. So this may be one of the reasons why he's progressing very late.
So another girl also 17 years old and remaining hale and healthy was seen 12 years back, not now. 500 cells at that time, treatment policy was not there. I don't know, she lost to follow. So more HIV, that is a empty city patients remaining healthy for longer time.
Sir, we cannot generalize like that, sir, because childhood.
Many. Mahadevan?
Many of the empty city babies who are positive, I have seen them to develop symptoms very late only. I have been wondering actually what happens to these children.
Yes.
Previously, we were telling they will not cross the primary school. Now, sometimes we are identifying the patient after 21st year. When they are getting married, they are found out to be thin. Then they say, my mother died of HIV and other things. This is happening on and off now. So there is something beyond our allele and other things,
yes,
especially for these girls who are boys and girls born to positive people. We have to find out the cause.
Next case, 49-year-old, recently started on ART. Government ART center came with complaints of intermittent fever, severe vomiting, dehydration, and just 8 days ago. He was thin built and found with mild oral thrush. Give me 5 minutes. CT thorax and abdomen revealed both pulmonary tuberculosis, extrapulmonary tuberculosis. ATT was started along with the ART, and tenofovir, lamivudine, dolutegravir, that is he was put on along with the ATT, and that is the dolutegravir 50 milligram BD dose. He has his wife who was free from HIV. 2 children were non-reactive. He denies extramarital or premarital heterosexual relationship, but MSM relationship 20 years back he was having. CD4 count was just 37 and CD4 7.4. He was on ATT, but he was given DTG 50 milligram dose. In this patient, efavirenz combination would be a better one. This patient knew his HIV status since 12 years, but he does not reveal to anybody. Got married and had children in spite of working with the NGO who caters for needs of PLHV and HIV positive patient. Only he felt sick. Severely he sought help of and started treatment. Fortunately, he recovered from with PPA and antiemetics, so he was discharged. Now switchover was not necessary. In this case, his wife was non-reactive. Zero discordancy is nearly 30 to 40% of the cases remain zero discordant. Why some remains zero discordant in spite of sexual contacts for years? In this case, vomiting may be due to irritants, gastric irritants may be there. So what is the zero discordancy is an important thing we have to talk. Dr. Vasi, madam?
The explanation could be already discussed, sir. So they are immune competent to the infection, HIV infection, or immune resistant. So even after unprotected sexual intercourse, they are remaining.
Anything else?
No, sir. No, sir. Nothing. Madam, what she has told, I agree with.
Mahadevan?
It is the viral load in the source positive patient that also should be counted, and the frequency of the sexual contacts between this husband and wife, that should be there, and the natural immunity of the lady, that has to be considered. So all these multiple factors are going to work regarding the transmission from the husband to the wife.
Sudhakar?
Sir, apart from the statement given by my predecessors, I have to say one more thing. That is, some people, less than 5% of the infected people, they don't have CC or 5. So such people will be having a virus in their body till they die because they cannot replicate. So, but they can transmit during that short time, but they will not suffer from the disease.
Good.
Recorded, sir. So, and now that Meravirak, such things, Vicrylic, they have come for even subsiding the CCR5 and CXCR4.
Okay, we'll finish. Carry on. Carry on.
Yeah.
Thank you, Sudhakar. You are correct. There are lots of mystery, even the natural progression and course of HIV disease yet to be revealed and understood. Some rapid progressor, many are chronic progressor, long-term non-progressor there. Few are elite control, viremic controllers. Some progressor faster than source, their source of the infection. Some are able to remain zero discordant. When all these things can be understood, we may be able to achieve a sterilized cure even with the HIV disease instead of functional cure. Just to follow your patients carefully. Maybe you are the one to get the knot release and throw more light and complete cure. Thank you very much. Sorry for delay in finishing it. Thank you very much. Sorry. Thank you, panelists.
Thank you, sir. Thank you. Thank you very much.
Thank you, sir.
Sorry, I am not giving all of you due importance because of lack of time.
No problem.
No problem, sir.
Thank you, my co-panelists.
Stop sharing.
Yeah, now, thank you, sir. Thank you very much for the wonderful session with a lot of take-home pills. Now it's the time to sensitize our postgraduates. For this, I invite the quiz master, Dr. Satyasree. She is associate professor from Gandhi Medical College, and she has 9 years of clinical experiences, and she has a vast experience in the field of DVL. So over to Dr. Satyasree.
Thank you, Bhumesh sir, for the kind introduction. Now, best of luck to all the postgraduates. So now I'm going to tell the instructions. So each session will have 10 MCQ questions. You should answer one correct answer, and the first 3 toppers will be selected for the first, second, and third prizes. The duration is for just 5 minutes. The postgraduates has to submit a bona fide certificate from the concerned HOD if they get the prize. And the quiz master's decision is final. And please don't refresh or close the browser. And best of luck, PGs. Go ahead. Yeah, thank you.
She's associate professor from Gandhi Medical College, and she
Glad
has
to meet you, sir.
medical experiences, and she has a vast experience in the field of DVL. So, Srinivas,
yeah, you quiz, Srinivas.
Hi, Dhruti. Yeah, Dhruti.
Go to Satyasri.
Yeah, yeah. Now the felicitation starts. Yeah, I request the chairpersons to felicitate chairpersons Dr. Ram Manohar sir, Dr. Tarun Mittal sir, and Dr. Deepak sir to felicitate the moderator and the panelists.
And the speakers.
Dr. Manjubala ma'am, first speaker. Dr. J.K. Maniar sir. Dr. Panelist Dr. Sudhakar Babu sir. Dr. K. Mahadevan sir. Dr. B.N. Reddy sir. Dr. M.R. Pardasarthi. Dr. Rajesh Rajagopalan. Dr. S. Vasuki ma'am.
And Quizmaster Dr. Satyasri.
Thank you, sir. And now I request the organizing committee to felicitate the chairpersons. Dr. Ram Manohar sir. Dr. Tarun Mittal sir. And Dr. Deepak sir. And thank you for the organizing committee for giving me opportunity. Thank you very much. Over to Dr. Bhumesh sir.
Thank you, Dr. Satyasri. Now we'll move on to another important session, the pediatric genital dermatosis and vaccines against STI. To start the proceedings, I invite the session coordinator, Dr. V. Shirisha. Over to Dr. Shirisha.
Thank you, sir. A very good afternoon, one and all. We'll be now beginning with the next session, which is on pediatric genital dermatosis and vaccines against STI. It's my privilege to invite the chairpersons for this session, Dr. Dinesh Mathur sir, Dr. Shamanta Barua sir, and Dr. Madhubabu sir.
Good afternoon.
Requesting the technical team to please display the CVs. Yeah. Welcome, sir, Dr. Dinesh Mathur, sir. Sir is MBBS, MD in General Medicine and Dermatology and STD, MBA, and Fellow HIV/AIDS, Fellow ICMCH and Indian Academy of Dermatology. Currently, sir is a professor and head of the Department of Skin and STD, JNU Medical College, Jaipur. With more than 90 publications and 500 presentations, sir has various awards, honors, and achievements to his credits. His main areas of interest are STD, HIV/AIDS, clinical dermatology, and cosmetology. We welcome you, sir.
Thank you very much.
Our next moderator is Dr. Shamanta Barua, sir, Dr. Madhubabu, sir, who is a professor. Okay. Let me invite Dr. Shamanta Barua, sir, who is the head Department of Dermatology, Assam Medical College and Hospital, Dibrugarh, Assam. Sir has various honors and awards. He has been awarded the Economic Times Inspiring Dermatologist of India in 2020 and Dr. Ellen Sinha Memorial Award at Dermacon 2015. Is a reviewer of 8 national international index journals and has more than 100 presentations and publications. Sir is the president of Association of Cutaneous Surgeons and member Specialist Advisory Board, National Board of Examination. Welcome, sir.
And recently has conducted a wonderful hybrid conference of e-ASTICON. Thank you very much, sir.
Thank you. Wonderful to be here. Thanks.
Our next chairperson is Dr. Madhubabu, sir. who is a professor and HOD of DVL, Department of DVL, Kakatiya Medical College, Warangal. Sir is a senior consultant dermatologist, STD specialist, cosmetologist, HIV, AIDS, and sexual medicine consultant. He has held various posts like organizing secretary in the 33rd AP State QTCon 2013 and as joint secretary for AP State QTCon 2005 and 2009. Sir has conducted several workshops and guest lectures for healthcare providers on HIV, AIDS, and sexual problems. And he has 10 original index publications in national journals and has acted as a state coordinator for AP SACS for sentinel surveillance for a period of 5 years. Welcome, sir.
Thank you very much, Agnes, Gamti, and Sirisha.
I now request the chairpersons to introduce our speakers.
Nothing is coming on the screen.
Yeah. First speaker, CV Srinivas.
Yes, this is, we welcome Dr. DSS Srinivas Prasad, who is a MD in DVD, and he has got present affiliation and designated professor in Department of DVL, Guntur Medical College, Andhra Pradesh. And he has got more than 7 publications and presentations many. And awards and honors, he has won scholarships in international conference in e-ASTICON and AIDS held in New Delhi. He won scholarship twice in National Conference of HIV and second prize twice in National Conference of HIV. Papers and posters and state national conferences in various conferences. As speaker in CME and CME on Dr. Natraj and zonal CME of Andhra Pradesh and zonal CME of IADVL. Besides that, he has presented many research papers and authors and co-authors in many chapters, and he is instructor of BCLS course in Guntur Medical College, and he was SAC State AIDS Clinical Expert Panel member in Andhra Pradesh. Because I remember there were lot many meetings at Tirupati at that time. I do not know whether he was there or not. And he was a resource person of AP SACS. So we welcome Dr. DSS Srinivas Prasad. No audio is coming to me. Is it?
Thank you, sir.
Right.
Shall I proceed?
Yes, please.
Good afternoon, everybody. I would like to start my talk by paying homage to my divine parents and thanking my teachers.
Make it full screen, Srinivas.
Yeah, I'm doing
Make it full screen, please.
full screen.
Down right on your computer, and then you will find an icon. Or even you can get it done by top left. Down right, there are 3 icons. Right of yours.
Sir, right next to the volume.
Yeah.
These are the references. The ones that are yellow, in yellow are the genital discharges. These are the pediatric STIs. Now, what are the modes of transmission of sexually transmitted diseases in pediatric age group? Well, all of you know, it is not only the sexual mode of transmission through which the STDs are transmitted to the pediatric age group. Maybe transplantal transmission, it can be intrapartum transmission, it can be postnatal transmission, or as in adults, it can be contact transmission through blood, and it can be sexual transmission. Respected seniors, dear colleagues, and my dear PGs, the topics that I am going to cover today are child sexual abuse, need for counseling, and the approach for the counseling. As most of the delegates here are the PGs, my target audience will be PGs, and my topic will be simple because of 2 reasons. One, that my target audience are the PGs, and two, because of the time constraints. I have slightly modified this definition by Barnard regarding counseling. The means by which one person helps the second person to clarify his or her situation so that the second person can decide the future line of action. That is what is counseling. Now, whom to be counseled? Is it the parents? Is it the children? Or is it both the parents and the children? No. What is the need to counsel? Or in other words, why should the parents and the children be counseled? The parents should know that it is not only through sexual contact that the sexually transmitted diseases will be transmitted. And second thing, the parents should understand that there will be a lot of trauma because of the physical and psychological impact because of these STDs. And there will be immediate and long-term consequences because of the sexually transmitted diseases to the child. There are various modes of support like medical, psychological, social, and legal supports for the child and the family. And the counseling will help them to know about these supports. And finally, it is mandatory on part of the counselors to tell about the POXO Act. So these are the needs for counseling. Now, whom to be counseled? As I already mentioned, is both the parents and the children should be counseled. Now, we are discussing about child sexual abuse. Though there are different modes of transmission like transplacental transmission, intrapartum transmission, and postnatal transmission, we are discussing in this slide and the earlier slides regarding child sexual abuse because the transplacental, intrapartum, and post-placental transmissions are on a decline, on a steep decline because of the rapid advances in the management. Whereas the sexually transmitted diseases in pediatrics because of child sexual abuse are on an alarming rise. There may be some cases of sexually transmitted diseases in adolescents because of sexual activity, but child sexual abuse is bearing the main bulk. Now, what is child sexual abuse? It is the involvement of a child or an adolescent in sexual activity which he or she cannot fully understand, or for which the child or adolescent is not developmentally prepared, or that act which violates the laws of the society. So this is the definition of child sexual abuse. Children can be sexually abused by both the adults and other children who, by virtue of their age and state of development, are in a position of responsibility or trust or power over the victim. CSA involves the intent to gratify or satisfy the needs of the perpetuator. Sometimes it is not the perpetuator. It can be another third party also who is seeking power over the child and who may be forcing the perpetuator to commit CSA. The true prevalence of CSA is difficult to estimate due to various factors like inadequate data, which in turn is due to underreporting by the victims and their families and social agencies because of various reasons. Now, CSA is totally different from sexual play and has to be distinguished from the sexual play by the healthcare professional. What is sexual play? It is the sexual activity by adults and children. It can be of same or opposite sex and separated by not more than 4 years. That is almost of the same age. And in sexual play, there will not be any force or coercion. This slide is self-explanatory. The types of CSA, first one is contact CSA. It can be penetrative or non-penetrative, or it can be non-contact CSA in the form of exposure of the child to the pornography or taking sexually explicit images of the child. It can be exploring of sexuality between the minors. These are the types of CSA. Now, when to suspect CSA? These are the increasing indexes of suspicion. Disclosure by the child, recurrent urinary tract infections, and pregnancy should give us a strong, in fact, the strongest index of suspicion. Likewise, sexualized behavior in a child and symptoms of post-traumatic stress disorder like nightmares and flashbacks should give us a moderate index of suspicion of CSA. Now, definitely there will be severe consequences of CSA. Why? Because the trauma is experienced in a stage when the understanding of the self, others, and the world are being formed in the child. In this stage, this trauma is being experienced. So definitely there will be immediate as well as long-term consequences like psychological trauma and as well as STDs and pregnancy. There will be cognitive problems like confusion, negative self-evaluation, insecure feeling, and self-estrangement also. Now, coming to management of CSA, it is a multi-step process and it is a multidisciplinary involvement. The first thing is we have to assess if CSA has been really taken, if CSA has been really done. It is by interviews and history taking, and counseling should be done, not only for the child, but for the parents also. It should be followed by physical examination, psychological evaluation, evaluation for the STDs, necessary investigations, and finally treatment. Treatment should be both psychological as well as pharmaceutical. Follow-up is compulsory in cases of CSA. What are the interventions needed? It can be medical interventions, it should be psychological interventions, psychosocial intervention, and legal interventions also, along with medical intervention, and proper care regarding these 4 types of intervention should be provided by the healthcare professional. But the first priority, please remember, the first priority should always be given to the medical care. When to be counseled? It, as mentioned earlier, it is a multi-step involvement, and the counseling should start immediately on contact with the victim and her parents. It should be during the interventions, and if needed, it should be done during the follow-up after completion of the interventions also. Now, coming to counseling the parents. Counseling the parents is important because of 2 reasons. Number 1, the parents will understand and they will counsel the child and will bring the child for counseling as well as for management. Number 2, it is the parents who can assure and instill confidence in the child after the incident has taken place. For this purpose, counseling the parents is very much important. What are the psychological impact on the parents? First, the parents will deny, but finally they will accept that CSA has taken place. It will be extremely distressing for the parents to know that the child is sexually abused, especially if the perpetrator is a known or family member. The distress will be more. It will start with anger on the self. There will be anger on the self because for letting this incident to happen. They will be frustrated on the child with the misconcept that the child has allowed this to happen. There will be anxious in dealing with the child emotions after the CSA has taken place. If the perpetrator is a family member, they will be anxious regarding the maintenance of relationship with the perpetrator, and they will fear that the CSA may take place again and again if the perpetrator is a family member. And there will be also a sense of loss of family member also, to be frankly speaking. Now, coming to the stages of counseling, it's building of rapport, defining roles and boundaries, ongoing support, and closure of the session. It is always advisable to address the parents by name of the parents and use respectable language and neutral tone to build immediate rapport. Looking at them rather than looking at the table, etc., will give an impression to the parents that you are actually interested in what they are saying. Don't stare at them. It will make them feel uncomfortable. Setting aside other distractions like mobile again will increase their confidence in us. Explaining and ensuring confidentiality and reiterating that whatever they say will be highly confidential will allow the parents to open up immediately. Subtle copying the body posture and mimicking their body posture rather than maintaining a rigid and formal posture will help to instill the confidence in them and build the rapport immediately. Allow them to gradually unfold the events rather than forcing them to narrate in a hasty and immediate manner. Now, coming to the second stage, that is defining roles and boundaries. Explain what will happen during the rest of the session so that they will understand that why they are sent to you, what is the purpose, and what is your exact role. Establish their needs, decide what are the immediate
Dr.
and what
Srinivas
are the long-term
Prasad,
needs.
you're just 3 minutes away, sir.
Right, okay. History taking and assessment should be done during this stage. Coming to ongoing support, emphasize that it is not your role, but it is the parents' responsibility to decide the course of action. But you are there as a facilitator to provide them and explaining the options and implications. As if they are in right frame of mind, and if they are in right frame of mind and the counseling relationship, but make sure that they feel better compared to the beginning of the session before ending the session. Closure is not permanent, and let the parents understand that they can call back if needed. Now, what is reflection in counseling? It helps to get to the wavelength of the parents. In a conversation, there will be words which you hear, but there will be feelings beneath these words. Reflection helps in getting to these feelings. Suppose you use phrases like, it seems like, I think you may be feeling like. If you use these phrases, you can get exactly to the wavelength of the parents, and you can assure that what you are assuming the meaning of what the parents are saying is true or not. During counseling, just reiterate that all genital lesions and discharges are not sexually transmitted, but genital lesions and discharges can be sexually transmitted irrespective of age and sex. Don't reiterate to the parents not to blame the child. Explain that the doors are always open. The parents can always come back if a need arises. Explain about the POSCO Act. Now, coming to the POSCO Act, which was enacted in 2012, it is mandatory to report to the police or magistrate by anyone who has received information about CSA during professional or personal relationship with the child. It implies that as healthcare professionals, you have to intimate. Before closing, it will be improper and inappropriate to close the session without counseling the child. So what are the main objectives of counseling the child? There are three main objectives. First one is to make the child understand and apply the personal safety concepts. Number two, to enable the child to understand and report the sexual abuse. And number three, if the child is already sexually abused, to empower them to keep themselves safe in the future. In window approach, you will be approaching the child not by directly telling about the sexual abuse, but you will be discussing other topics that are related to the sexual abuse, so that the child will feel confident and will open up. These are the various themes that we will be using in window approach for counseling the child. To conclude, HCP should have a keen eye of suspicion and should be apt for counseling also along with medical management. Counseling of parents helps in better management of the child. Let the flowers blossom. I thank the organizers for giving me this opportunity, and I thank all the delegates for a kind and patient hearing. Have a great day. Take care.
Thank you, sir. Thank you for such a clear and lucid talk on a sensitive issue. I request the chairpersons to invite our next speaker, Dr. Bhumesh Kumar, sir.
I take the pleasure of inviting the next speaker, none other than the dynamic Dr. Bhumesh Kumar Katakam. He is an associate professor at GTHEMC, and he has several publications and book chapters and presentations to his credit. He has won several awards and honors in both regional and national fora. His areas of interest are pediatric, allergic and infectious dermatosis, and pediatric HIV and AIDS. And I request him to start his presentation. He will be speaking on how children get STDs. Over to you, Dr. Bhumesh.
Yeah, respected chairpersons, thank you very much for your kind words, sir. So my talk today is how children get sexually transmitted diseases, STD. Before that, we all should know that children are not just small adults. They need separate diagnosis. They need a separate approach for the diagnosis, as well as for the treatment, as well as counseling. The STDs in children are not uncommon in India, though the systematic epidemiological to determine the exact prevalence are not available. They can be acquired via sexual route, maybe a sexual abuse or voluntary sexual activity. Uncommonly, via non-sexual route, such as accidental inoculation by a deceased individual or perinatally. The childhood syphilis, gonorrhea, condylomata acuminata, chlamydia must always be considered in the differential diagnosis. 95% of acquired syphilis in children are transmitted by sexual abuse. That is an area to be noted. The route of transmission mainly depends on the age of the children. The intrauterine or perinatal transmission is more likely at 2 years or younger age group. Between 2 to 10 years, sexual abuse is common, etiological factor. Near puberty, the voluntary sexual activity and sexual abuse. The adolescents mainly, they'll go for voluntary sexual activity because the adolescents, they are neither children nor adults. Always they are for experimentations, exploitations, and subsequently they will be landed into complications. Of course, sexual abuse, rightly spoken by Dr. DSS, I won't go in detail. The Ministry of Women and Women and Child Development, Government of India, conducted a largest national level survey among more than 17,000 children and adolescents in the age range of 5 to 18 years to estimate the burden of sexual abuse, and the results were shocking. It was found that every second child in the country was sexually abused. Among them, more than 52% were boys and 47% were girls, mostly in the age group of 12 to 15 years. Assam reported the highest percentage of sexual abuse, followed by Delhi, Andhra Pradesh, and Bihar. Most common perpetrators are either neighbors or relatives. Most of the abused children belong to the lower socioeconomic group. And important thing is the myth about the cure of sexually transmitted diseases by having sex with children were one of the important factors for the sexual abuse. Children who have sexually abused or exploited frequently suffer from severe mental, emotional, and behavioral trauma. In addition to acquiring STIs, which manifests itself in a social isolation, low self-esteem, and inability to have a normal sexual relations. Child prostitution. So the studies and surveys sponsored by Ministry of Women and Child Development estimate that there are about 3 million prostitutes in the country, of which an estimated 40% are children. The human trafficking, young girls may be victims of sex trafficking. About 7,000 sex workers migrate to Indian metropolitan cities, especially Mumbai, every year, and approximately half of them are minors. They may be sold by their parents, or deceived with the promises of marriage or lucrative job, or kidnapped and sold to brothel owners. Young girls are generally not able to negotiate safer sex, such as condoms, which is very important for the prevention of HIV as well as STDs. A study of HIV prevalence showed that very young girls, the 14 years or young at the time of trafficking, was associated with over threefold increase the risk of HIV transmission related to trafficking at the age of 18 years. And important, the STDs are becoming increasingly common in pre-adolescent age group. The because of early sexual maturity, then increase promiscuity, the greater sexual liberation, and sexual offenses are the probable causes. More adolescents are now sexually experienced due to change in cultural and more moral values. The sexual activities generally is very high in homeless street children and putting them at a risk of acquiring HIV infection. And burden of STDs in India, last 2 decades, an increase in the prevalence of STI in children. The various studies resulted represents only a tip of the iceberg, as many infections in children remain undiagnosed due to failure to recognize the problem in this age group. So that's why we need sensitization, we need high index of suspicion in the pediatric age group to search for the STDs. And stigma attached to them, and asymptomatic nature of the infections, and fear of the perpetrators. So these are the important factors. And many healthcare professionals often do not screen children for these infections. In children with STIs, boys usually outnumber 50 to 78%. This reflects the greater possibility of sexual adventures in adolescent boys, increase in homosexual practices, greater attendance of males in hospital compared to females, and of an asymptomatic nature of STDs in females. Only few studies have mentioned concurrent HIV infection. This is seen only in 1 to 5% of all pediatric STIs. The maximum prevalence of pediatric STIs about 2/3 in the age group of 11 to 14 years. This may also point to early onset of voluntary or consensual sexual activity occurring in this group. The homosexual and bisexual behavior increases the chances of acquiring STDs, including HIV at an early age. Most of these children with STIs are illiterate and belong to low socioeconomic background. Few are from the remand home for juvenile delinquents. The prevalence of homosexuality among the children with STIs gradually increased to 10 to 11%, and a study from Gujarat has reported history of homosexual contact about more than 40%. So the guidelines for the screening for STDs in pre-pubertal children: when a suspected offender is known to have an STD or be at higher risk for STDs, you have to screen. When a child has a signs or symptoms of an sexually transmitted diseases, or when the prevalence of STDs is high in the community, in those conditions we have to screen for in the prepubertal age. And syphilis, the secondary syphilis, the percentage of prevalence of acquired syphilis among all STIs in children has also gradually declined over the last two decades. And the most common presentation of acquired syphilis in children, usually secondary syphilis, most commonly manifest as the condylomata. The lymphadenopathy and cutaneous rashes are other common manifestations, but when you see soft papules, always you have to rule out from, you have to differentiate it from condyloma acuminata clinically and lab-wise. And the gonorrhea, like other bacterial STIs, has shown declining trend as spoken by many speakers. And this is a 17 years male adolescent, the history of unprotected sex with a known person. After 5 days, the classical presentation of purulent discharge. And the prevalence of chancroid in children with STIs has also decreased dramatically. There is no data about donovanosis in children. And when you diagnose, you have to treat accordingly. I won't go detail, and it was discussed elaborately in previous sessions. Viral STIs have shown an upsurge in the recent past, in that genital herpes is the most common the STDs, and followed by condyloma acuminata is another important viral infection. And this is a child. The history of genital ulcers 1 week back, and history of exposure, the vesicles on upper lip 5 days. And the features are not classical of genital herpes, but we have done the JONC, there is acantholytic cells from upper lip, and even the HSV1 and 2 was positive, and we have treated accordingly with acyclovir 20 mg per kg 4 times in a day over a period of 7 to 10 days. After that, it was subsided. When you see the anal warts, perianal warts, always we need to remember whether it is abuse, sexual abuse, or any accidental inoculation, or active sexual activity. So these are the 3 important areas. In these 2 children, based on the history, there is a history of sexual abuse. Once if you label any, that is, if you see the genital perianal or perianal warts, once if you rule out the immune status, the next step is how to clear the lesions. Whether to go with the medical therapy or surgical therapy. And an important thing is, when you diagnose sexual abuse, rule out immune status, and the counseling part is very, very important in the pediatric age group. Always in my practice, I will follow the instructions of the formula of M square. The medicine as well as the mind, that is a counseling. The counseling, pre-adolescent counseling is different and adolescent counseling is different. Medicine, as a doctor, my role is 50%. As a mother or a caretaker, if it is a pre-adolescent, you will need to involve the caretaker or mother, because the pre-adolescent children, they won't take care of themselves. Whereas the adolescent, they won't follow the instructions of anybody, whether it's a mother, father, or a doctor, you involve them. Unless until you involve the adolescent, so the treatment is inadequate. So this another child sexual abuse, HIV was non-reactive. So after 2 injections of MMR in Gandhi, they have done a study with myself, Dr. Mehta, and Rajiv Singh all. So this is another important immunotherapy. When you initiate the role of immunotherapy, especially MMR, you have to label the child should be immunocompetent, and if the lesion is perianal. So this is one of the important options. It should see that it should go to the intradermal levels to stimulate the dermis and subsequently the immune system that will clear. This is the MMR vaccine. It's a powder form. It has to be distilled, and the distilled water has to be added. One thing we need to remember: this is a it's a live vaccine. So once if you give live vaccine, so the cold chain is very, very important. So if you won't maintain cold chain, the treatment is just like it won't help at all. So and the dilution, when you
Dr.
are diluting
Bhumesh,
always,
sorry to intervene.
yeah.
You're 3 minutes away, sir.
Yeah. When you are diluting, so don't shake the vial, just you rotate it and you have to give the cold chain, and the dilution is very important steps. And mixed infections are not uncommon. So to conclude, the antenatal screening of all women should be carried out, and if found to be infected with STIs, they should be treated adequately to prevent the perinatal transmission. The congenital syphilis is a preventable disease. Even every case of congenital syphilis indicates towards failure of maternal and child health services in the country. The STDs in children are a worrisome problem, so always we need high index of suspicion. The diagnosis of an STDs in a prepubertal child must raise the concern for the possibility of sexual abuse, and it has to be evaluated. And subsequently, it has to be reported. And the prevention and treatment of adults are the main step to prevent these infections in children, because the child abuse is one of the important factors for the STDs in the pediatric age group. The comprehensive sexuality education should be every child's right. It's the birthright of child. So psychological support should be provided to the victims. Health education along with the behavioral therapy and regular screening is required for high-risk groups like street children and children at work. So stringent laws against sex trafficking and child labor has to be implemented, and it is important to improve the awareness among children, parents, and adolescents and general population to decrease the incidence of sexually transmitted diseases in the pediatric age group. So finally, take-home messages: always the healthy penis is healthy vagina, and subsequently healthy skin, so then the healthy body and healthy nation. So the awareness and counseling should be started regarding the sexual health education should be initiated from the pediatric age group. Subsequently, we can prevent complications and decreases the chances of sexually transmitted diseases. And I request all, because we are seeing almost more than 1,000 PGs are participating. I request all PGs, please look for and sensitize for healthy skin and healthy sex, subsequently healthy body and healthy nation. So please sensitize another 10 people. So for healthy skin and healthy sex. So thank you very much for your kind attention. Thank you.
Thank you, sir. Thank you for an excellent presentation. We'll now move on to the panel discussion. I request the chairpersons to introduce the moderator, Dr. K.A. Sitaram, sir.
Thank you, Sirisha, and thank you, organizing committee, for giving this opportunity as an chairperson. Now is the time for the panel discussion. The moderator for the panel discussion is Dr. A. Sitaram, sir. He is the professor, Department of DVL, GSM Medical College, Rajahmundry, and he is a state medical registration. There's a lot of publications and a lot of achievements. He is a reputed national, international dermatologist. He has a lot of publications, and he has been with a lot of guest speakers and a chairperson, moderator, and has conducted a lot of quiz programs, and has contributed a lot of publications into the author for so many textbooks. And he's one of the most reputed dermatologist practice for more than 3 to 4 decades. I take the privilege of introducing Dr. Sitaram, sir. And the topic for today's panel discussion is sexual, non-sexual genital issue in pediatric genital dermatosis and vaccines against STIs. Now I invite Dr. Sitaram, sir, to come onto the dais and introduce his moderators, introduce his panelists to the session, and start the session of panel discussion. Over to Dr. Sitaram, sir.
Thank you, Madhu. Thank you very much. Good afternoon. Okay. So can we see the screen?
Yeah.
Okay, right. So good afternoon, everyone. Thank you very much for the e-ASTICON team, e-ASTICON 2021 team, especially Dr. Nrsimha Rao Neta, Dr. Bhumesh Kumar, for inviting me to be here as the moderator today. And the excellent sessions are going on since morning. So with a lot of messages in each session. So the PG quiz was really innovative. The students are very much interested. So that's wonderful. So coming to the panel now, so it's mainly the pediatric general dermatosis, both STI and non-STI, and then something on vaccines. So we have extreme panelists here today, Dr. Rajiv Sharma, Dr. Vibhu Mendaretta, Dr. Sridhar Janjhala, Dr. Resham Vasani. Unfortunately, Dr. Arun could not join us today because he has some unexpected emergency issues at the university, as is the dean of the BLD University, Bijapur, so he could not make it. And Dr. Rajiv, my close friend since the MD days, and we all know him as the past Honorary Secretary General of IADVL, and he has conducted the International Congress of Dermatology at Delhi, and he is the consultant dermatologist with a lot of publications and of course numerous presentations, and he has received the Professor D.B. Chandra Memorial Veneration, Dr. K.N. Saxena Memorial Veneration, and then he had worked as the president of Indian Society for Pediatric Dermatology, and very lot of special interest in the pediatric dermatology, acne, and pigment disorders. Welcome, Rajiv. And we have Sridhar Janjhala. He is working as the professor and HOD at the Dermatology INHS Ashwini, Mumbai, and he has a number of publications, and is a member Purvi IADVL Task Force Against Topical Steroid Abuse. He is a deputy editor at the Indian Dermatology Online Journal, and he has delivered the Silver Jubilee Veneration of Institute of Venereology at e-ASTICON 2016. We have Dr. Vibhu Mendaretta. We all know her, and she is the head and director professor at Lady Hyderabad Medical College with more than 160 publications and numerous presentations. And she received Commonwealth Fellowship in Pediatric Dermatology and a Developing Country Dermatologist Award in 2007, and ICMR Fellowship in Pediatric Dermatology, WHO Fellowship, and then Founder Secretary for the Society for the Pediatric Dermatology Delhi, worked as President Delhi State Branch, and received Sardari Lal Memorial Veneration Award in 2015. Welcome, ma'am. And now the young and dynamic lady, Dr. Resham Vasani from Mumbai, and she is a consultant to the various hospitals at Mumbai, and a lot of publications, nearly 60 publications are there. She contributed to 14 chapters and numerous presentations. She has the Das Award of Excellence Dermatology in 2019. She is an assistant editor and on the editorial board of various journals of the IJDVL, IJPD, IDAJ, and she is a member of SAG Pediatric Dermatology, and she worked with us as a member of IDVL Academy during 2016 and 2017, and winner of the National AMLA MD Gold Medal, and a lot of international scholarships. Welcome, Dr. Resham. So I hope all of you are there. Yeah. I could not see the people. Right. Okay. So basically, we will go with a few case-based discussions, and then some take-home points are based on that. And okay, let's see the first case. This is a case of a 9-year-old male with white tissue urethral discharge for last 3 days. There is no foul odor, there is no burning nutrition, and there is slight, mild, well-demarcated erythema over the shaft vein. So you can see the next slide. See this here, and there is mild erythema here and the shaft penis, and then this whitish cheesy discharge, superficial discharge. So how one should approach? This is a patient of 9-year-old male. Anyone? Dr. Ma'am, if you're moderator, would you like to take it up?
Yeah, so hello, Dr. It's a pleasure to be here and on this platform. So you said that it's a 9-year-old boy who presents with this whitish discharge, and there is no history of any sexual exposure or any sexual activity or any abuse. So I would like to actually first rule out any STI, associated STI, because the idea is that any involvement of the genitalia in a young child, we must always exclude possibility of any sexual exposures and any sexually transmitted infection. Now, with this particular case, as the discharge seems to be subprepucial discharge, yes. So subprepucial discharge. So we will like to see this, and this could be. We have to, retract the prepuce and see from where the discharge is coming, and we have to ask in the history, any history of dysuria, burning micturition, or any other associated complaints. So if there aren't any, so subprepucial discharge generally is due to the poor hygiene in this age group. So it is because of the collection of smegma, which gets collected, and that needs to be cleaned up, and one must counsel the adolescent and also the parents regarding the need for regular cleansing of this area by retracting the prepuce. So, and in case, so there is redness also. There could be some associated, because collection of smegma can give rise to secondary balanoposthitis.
Yeah, so, this redness is because the history when we are taking, this is nothing but they have applied some Jendu balm because there was some swelling there and they shoved the penis because of the collection there. So they applied the Jendu balm. So that was basically the erythema produced by the irritant part of it. Irritant part. Yes. Yeah. So, Rajiv, would you like to add something?
Sir, in history, first of all, I'd like to know whether there was some phimosis initially or not, whether the parents were regularly clean, because it is how you want to know the approach.
Yeah.
So if there was phimosis, then whether it was being cleaned or not. And this subprepucial discharge appeared suddenly, or it appeared over a period of time. And of course, Dr. Vibhu has mentioned about the sexual activity and sexual habits of the child. But still, since there is no foul smell or there is no irritation, it is less likely to be an infective process per se. It may be secondary to something like smegma she has mentioned, if it has been retained for long. That could be one of the reasons. So the examination part, again, retracting might be painful at this stage for the patient.
Yeah, we did.
You have to handle with care.
So that's what we did, Dr. Rajiv. We tried to retract the things and cleaned all the discharge seen around. And that's only one point. At one point, we were able to see that white cheesy material coming out. The rest of the thing is clean, and there was no discharge from the urethra as it is.
So it's smegma pearl or something like that.
Yeah, so that looks like, there is no foul smell, as I mentioned. There's only a whitish cheesy discharge coming like that. And then if you go after 5 days, so the entire thing completely subsided, including the erythema or by producing Jendu, even that has gone away. So that is no discharge at all. The only advice we gave was just retract and clean as much as it comes every day, 2-3 times a day. So that was completely the discharge subsided and there is nothing. So that's true that as Dr. Fu and you said that it looks like only a smegma. But only thing is producing such a huge subprepucial discharge, large amount. Morning also I heard from Dr. Rajiv Singh's panel, smegma producing the concretions, collections like stones, and they have shown 2 cases, and then the balanoposthitis also. That's true. Here also again, another case, we are seeing that with a lot of subprepucial discharge, There is no foul smell, there is no burning, there is no irritation, except that the discharge was there for the last 3 to 4 days. So that was the thing. So the only entire idea is bringing that is, and of course we all know this. This is white cheesy material without any foul border, and the smegma pearls and smegma stones. It forms like concretion, sometimes very hard, and these stones can produce the vellum prostatitis also. So this is one of the reference article saying that the smegma can form these stones in that. And right, is smegma carcinogenic? Sridhar, would you like to comment on that? There are some statements, some made, some myths.
Smegma is a physiologic discharge. It's unlikely to be carcinogenic, sir. I mean, the fears of the parents, etc., on this ground should be allayed, because there is no real risk of carcinogenicity of smegma. It's just a collection of epithelial cells with some inorganic parts. Hygiene and as has been brought out by the other panelists, hygiene and regular cleaning. And if there is any phimosis, correction of that, these should be emphasized. There is a chance of, since there is a chance of recurrence of this.
Yeah, so that's true. As you said that, so there's a lot of studies are there saying that there has no role at all. It is not at all carcinogenic. Just to emphasize, we say that this is not carcinogenic. So the message is that all the superficial discharges are not STIs. The smegma, a collection of epithelial cells, can cause balanitis sometimes, and a proper hygiene, regular cleaning, and a counseling to the parents are essential in this. And then smegma is certainly not carcinogenic. Anybody would like to add any comment in this? Yes. Yes, ma'am.
I would like to add a comment, small comment here.
Yeah, please.
That although it has been, the myth has been busted that it is not carcinogen. I was reading somewhere that smegma may be associated with the development of lichen sclerosus heterotropicus, LSCA, I think. So which is again, so I think like all triggers which give rise to chronic inflammation or chronic infection, they are responsible for inducing some dermatosis. And LSCA could be, associated with long-term smegma buildup.
Right. So indirectly, if you want to say that, yes, there was a discussion that was in the morning. Smegma in the long-term collection, if they are not properly cleaning, it can induce lichen sclerosis. Yes, that point was very well taken. So, but in general, normally it is itself is not carcinogenic. Okay. Yeah. As
sir,
we
can I make a point?
Please.
Sir,
please,
sir, can I make
yes,
a point?
Rajiv, yes.
We are discussing smegma only in men or males. It does happen in females also.
Correct. Yes.
So it is important both male and female children should be taught how to clean.
Yes. Would you like to say something more on that?
So the cleaning of the labia is as important, and the clitoral hood is as important in females as it is the cleaning of the subprepucial area in the males. So, and it is said that retraction of prepuce should not be attempted very early in life. It should be started only when the child is 4 or 5 years old, because it is only then the retraction becomes easier. But the Indian tradition, I think, is to retract it much earlier. So I think our teaching should change.
Yeah. Taken. Well taken. Your point is it is both there in the males and females. We should counsel both the sexes with the parents. Yes. So let us go to the case 2. So of course we all know this is lichen sclerosis. So this is because we commonly see, but again, a lot of issues in the management and a lot of problems about the confusion about the vitiligo. So let us share some knowledge about how to differentiate it clinically from vitiligo and how to manage this. Is there any risk of malignancy in this, in children especially? And does it resolve? All these cases, does it resolve at puberty? So these are the 4 things we try to answer. Dr. Resham, would you like to say something?
Yes. Lichen sclerosis, to differentiate it from vitiligo, both of them look depigmented. But on the history, there will be history of associated itching, associated pain, dysuria, and constipation is a very important symptom in the pediatric age group especially. If we go on to the clinical examination in patients with lichen sclerosis, we would definitely see, many a times we see that figure of 8 pattern, which is lacking in vitiligo. Also, architectural disturbances in terms of sometimes the burying of the clitoral hood, eating away of the labia minora. That is a thing. Architectural disturbances are what are seen in lichen sclerosis, while these are absent in vitiligo. Also, when we palpate the lesion, the induration of the sclerosis is much more appreciable in an evolved stage of lichen sclerosis versus the smooth and the soft skin in patients with vitiligo. Nonetheless, we should be aware of a fact that there is an entity which is called as vitiligoid lichen sclerosis. Now, in these patients, they may not be as symptomatic as in lichen sclerosis, but on histopathology, they definitely show evidence of lichen sclerosis in terms of the band-like infiltrate, the atrophy of the basal layer, and deposit and the collagenization of the dermis. So I think that is one thing that we should be aware of.
Are you also, I think, a dermoscopist? Dermoscopy, does it help in
Yes, sir.
differentiating these two? Yeah.
Yes, sir. Yes, sir. It does. In patients with lichen sclerosis, we may see white homogeneous areas. Sometimes we may see follicular plugging, telangiectasias. While in patients with vitiligo, we will be able to see sometimes the milky white areas associated with evidence of repigmentation at a few sites.
Yeah, so we have a lot of features to differentiate both vitiligo and the lichen sclerosis, as Dr. mentioned. Yeah, Rajiv, please. Rajiv, go ahead.
Apart from what Dr. Resham has said about the vitiliginous LSA, the repigmentation also occurs faster in those patients who have got an overlap of vitiligo and LSA. And they tend to heal like vitiligo lesions, even though the histology is that of LSA.
Okay. All right. Sridhar, would you like to add something?
Yeah, one point I'd just like to add regarding the clinical assessment. The Fordyce's spots, for example, here in the margins, we can see certain, possibly, physiologic sebaceous papules called Fordyce's spots. These would be conspicuously absent in the sclerosed area of lichen sclerosis, whereas they could be present in normal vitelliginous skin. So the vitelliginoid LSAT is more of a vitiligo with some features, which is probably a Keebnerized vitiligo because of the irritant response of the urine and the acidic secretions. So the differentiation is very critical. If we can home on to LSAT early in the course of this thing, we can do a world of good for the patient. Dermoscopy with saran wrap showing follicular plugging, as Dr. Resham has said, that more or less clinches this thing. There's very rarely a need for a biopsy.
Okay. Dr. Vibhu, you have some publications on this. Would you like to say something? Yeah, please.
Yeah, I would like to just add here that early diagnosis is really very important, and early diagnosis is difficult because here the picture that we see here is something which is already evolved into a sclerotic and atrophic phase, because we can see that the skin is tight and the labia minora, and they seem to be little atrophic, and there is a fusion taking place, and there is erythema. There can be some possibility. Yes. So these are the signs which are of the advanced stage, sclerotic atrophic stage of LSA. So here, but the right stage or the critical stage at which the diagnosis has to be, made is early stage. And early stage, again, we have to do dermoscopy because clinically it may not be possible. You may palpate if the lesion is not well, the extent is not this big. A figure of 8 comes very late. It may not come many a times. The child will be symptomatic. What I have seen in my this thing is that in vitiligo, it is just the parent who notices and the white spot. And here the child, the parents would notice that the child is symptomatic. There would be itching, there would be burning, there would be, if the child is able to, like a young child. So sometimes there is burning, there is constipation, there can be dysuria. So again, this awareness has to be given to the parents that this can happen. So early diagnosis is high index of suspicion and any white spot disease there. Dermoscopy must be done in all cases who are presenting early. Palpable, we must palpate the lesion because the textural changes can only be appreciated if we palpate and touch the lesion. Right. So that is what my take is.
So well taken. So the clinical examination is very, very important. Just feel the lesion, palpate it, see is there any induration and everything is there. Of course, the erythema will be evident. And the architectural changes, the patient has mentioned it. And dermoscopy, yes, certainly plays a good role if you are in suspicion. Now, what is your first choice, Rajiv, to treat this patient?
Should I answer?
Yeah, go ahead.
Yes.
No,
So if potent steroids, I'm not using super potent. So for as far as I'm concerned, I'm only using betamethasone, valerate. Up to that, I'm not using clobetasol. So I'm using that for a good period of say 2 to 3 months regularly, twice daily application, along with an emollient, usually a vitamin E preparation. And then once the skin becomes, there are changes in the texture, it is no longer hard and the pliability is better, then I step down to tacrolimus for another, maybe say 6 months.
Rajiv, do you differ anything? Will you continue the same?
Yeah.
Please.
I try to kickstart with a super potent steroid for about 2 to 3 weeks. Then I step down to mometasone or fluticasone, and then I switch over to tacrolimus.
Right. So I also start with the potent steroids certainly, and then slowly, as ma'am said, we will lower it down, tap it down. Okay, Resham, what are the chances of malignancy in children in these patients?
The risk of malignancy with pediatric lichen sclerosis is up to 1%. Hence, it is very important to counsel the parents and the child for a regular follow-up. And ideally, the follow-up has to be at least till puberty. And 75% of the cases, they also show symptoms after pubertal age. So it's important that they are counseled for a regular follow-up. We monitor them for any evidence of any ulceration, any hyperkeratotic plaque, any other evidence of any malignant change. And ideally, the monitoring is for a lifetime.
So it's usually less common compared to the adults, but definitely a follow-up is required. So, yeah, this is the thing, depigmentation, constipation, dysuria are both prominent. And if it is the triggers, nocturnal enuresis, urinary incontinence, and sexual abuse are the common triggers in children. And hymen is affected if it is a sexual abuse, but not routinely in the LS. The vulvar squamous cell carcinoma is uncommon in children compared to the old age. And it may not resolve at puberty usually. So the residual signs still, they may persist to the thing. This is one of the articles which we published in the IJPD, the vulvar lichen sclerosis in children. The prospects over 3-year period. And we have seen around about 25 for 80 and 186 were having the LSA. And these are the predominant symptoms again, the depigmentation. The figure of 8 appearance, as Dr. Guru said, that's seen in only 4 out of 25. It's not that common. It was seen, but it is less. And topical potent steroid was the mainstay in that. So this is the vulvar message is the itching may be there and figure of 8 appearance may be present. Topical potent steroid is the mainstay. SSC is uncommon in children and it may not resolve at puberty. Okay, let us go to the case 3. Yeah, Rajiv, would you like to say anything?
Yes, sir. Sir, the importance of occlusive undergarments has been published and some papers should always be made. Children are using very tight undergarments, tight clothing, and that somehow prolongs the course of LSA also.
Right.
And Dr. Somesh, I think, has published something on this in a journal. So that should be a part of management strategy.
Counseling, yes. So thank you for bringing that. This is another case contributed Dr. Resham. Dr. Resham, would you like to talk on this?
Yes, sir. So this was a 6-year-old girl, and as we can see, she had warts over the inguinal area. The reason why she came to me was the intense pain and multiple ulcerations and erosions on the inner aspect of the labia majora, as well as involving the labia minora. And the pain was severe enough for her to go into urinary retention for around 16 hours before the patient presented. And as for the history, the parents were applying topical imiquimod over the warts, which was prescribed by the dermatologist. And as per the history, they were precisely applying the cream only over the affected areas. On the rest of the examination, the oral cavity palm soles was absolutely normal. Non-tender inguinal lymphadenopathy was present, and there was no history of any preceding vesicular lesion. So looking at it, the first impression was herpes genitalis. So to rule it out, we did a Zank smear, which came out to be negative. Also, the other members in the family, the mother, the father, and the caretaker were examined, and the female caretaker, was found to have warts on her palm. So that explained the heterologous transfer of the HPV virus causing the warts on the inguinal area. And there was no other evidence of any sexual abuse. The HIV, VDRL, HPSC, it was completely negative, and the antibodies were also negative for HSV. So at the end of the history and the examination, it was thought that imiquimod, which was being applied for these warts, was actually the culprit, and this was a kind of a paradoxical distant site reaction because of imiquimod. The explanation that is given in the literature is that whenever we apply imiquimod, 1% of it gets absorbed into the skin. Now, when we are applying it to a inguinal region of a child, the absorption is likely to be higher. Also, it would take around 15 days for the imiquimod to achieve a concentration in the serum. Now, this imiquimod is further acting upon the toll-like receptors which are present over the mucosal areas, and this leads to the infiltration of the leukocytes and consequent mucositis and ulcerations. As we can see, intriguingly, wherever the imiquimod was applied, that area is completely normal, and majority of the inflammation is only on the area of the mucosa. So that is what was interesting.
Yeah, thank you, Dr. Ashram. It was really interesting. So, I have not seen any other panelist. Would you like? Have you seen like this, or any comment to be made on this? Imiquimod inducing the ulcers.
Yeah, not in the perigenital area, but for molluscum contagiosum on face, there have been children who have come with oral ulcers. I have seen 2-3 patients who have done.
You have seen? Okay, great. Yes, I was just coming to that. There are a lot of reports. The people who have applied on the molluscum contagiosum developing on the ulcers. That is true. So these 3 questions have to be answered. There is no answer, I hope. Why is it not occurring on the sites applied, and why is it occurring at the distant places? And why only mucosa? Why not the ulcers at the other cutaneous parts? And why only mucosa? Any insight into this? Anybody, any thoughts? But I could not find any answers in the literatures for this. So the pathogenesis of the ulcers, Dr. Ashram has already pointed out. So these things are still unknown. And these are the various reports. The oral ulcers, after 5% imiquimod treatment in children. And so this is one case documented in the pediatric case group also, but adults, there are many. In the children, it is only one case reported so far. And the distant mucosal lesions appear to be a rare and underreported side effect. After ulcers, erosive colitis after imiquimod for facial warts and molluscum contagiosum is known in adults. So no alteration of the application sites. And definitely a close vigilance of the adjacent and the distant mucosa is recommended. And we all should be aware of such a potential side effect so that we can stop the imiquimod and so the patient will improve without unnecessary other treatments being given to them. Yeah, Raju, would you like to, want to say something? Right, okay. No. So that's about the imiquimod, certainly interesting. Thank you, Dr. Ashram, for contributing that. Yeah, this is a 16-year-old obese having these type of lesions, multiple sinuses and nodules for the genitalia and the axillae for last 3 years, and they are recurrent. And that's partial improvement with the antibiotics sometimes. And yes, we thought of hydrogenated suppurativa because the perineal genital involvement and the axillary involvement are there. Chronic duration, 3 years, recurrent, painful, multiple nodule sinuses. So we thought of hydrogenated suppurativa. So how do we approach this case? Sridhar?
Yeah, the diagnosis of HS seems to be fairly certain in this case, and it all depends upon the staging. The early stages, 1, 2, and 3. This particular patient appears to be falling into either stage 2 or stage 3. Now, stage 3 is interconnecting sinuses. That needs to be ascertained on clinical examination. So stage 2 to stage 3 in an adolescent girl Firstly, we also we look at any other comorbidities which are already there, and I think in this case you said she is obese.
Yes.
So management of these general measures, that is your management of the risk factors, metabolic syndrome, etc., etc. These have to be looked for and managed. Counseling, of course, this is going to be a lifelong condition or a long-term condition, and that needs to be done. And thereafter, the definitive treatment will depend upon the stage of the disease. In this case, since it's stage 2, I would go for a course of antibiotics, possibly clindamycin or augmentin-based.
Do you consider tuberculosis at all in this patient?
Yes. See, the presence of sinuses, one is extragenital Crohn's. This is the one possibility. Those knife cut ulcers, this is a classical description, extragenital Crohn's. Crohn's is again very closely related to tuberculosis. Tuberculosis, yes, but she has got already, you mentioned, sir, distant site involvement in the form of axillary involvement in an obese girl with presence of multiple sinuses. Tuberculosis definitely has to be ruled out prior to.
Yeah, that's right. So just I want to make that point very clear, Sridhar, because so we had seen one case, similar case, not this lady, but having these lesions in the both axillae because and the genitalia, thinking that it is HS. It was treated for a long time, and finally, when a biopsy was done, it proved to be a scleroderma, and the PCR was positive. Finally labeled as a multicentric tuberculosis. So it's possible in our country. So I think we should not underplay the tuberculosis in any case. Definitely, we should rule out that. And of course, anyway, this is certainly HS. Are there any differences between children and adults in HS, either in presentation or in treatment approach? Dr. Resham?
Yes, sir. The presentation in children, we see that it is more commonly associated with obesity. Smoking per se is not as common to be a contributory factor in hidradenitis suppurativa in a child versus an adult, though passive smoking is definitely attributable. Further, if the age of onset is earlier, the chances of it becoming a chronic and a more severe presentation is more likely in children versus an adult.
Okay. Rajiv, would you like to say something?
Same, but I always think that we should always keep in mind hypothyroidism. Okay. We always overlook that and we think only of about diabetes and obesity. Yeah. Hypothyroidism may be equally important in such patients, and passive smoking in a smoking family can happen even in young children. So that should also be kept in mind. And in children, weight reduction, if possible, helps to a great extent in helping these lesions to resolve earlier. If they are picked up earlier, at this stage, it may not be very helpful, but if they are picked up earlier, they do work wonders for them.
Dr. Vibhu, you have a publication on this here.
Yeah, so first of all, I would also like to, add here that pediatric HS generally is seen, usually there could be a possibility of a family history, some genetic predisposition can be there. So other than obesity, it gives us an opportunity to, screen the child for associated polycystic ovarian disease. That is, I have seen in 2-3 of my patients, adolescent girls. Obesity is important, diet has to be looked at. Then the metabolic syndrome, some of them do have, insulinemia, insulin resistance, it may be associated with. So that basically gives us an opportunity to screen the system for all the underlying metabolic derangements that may be associated with obesity. And also smoking is not common in pediatric age group. So certainly exclusion of tuberculosis is very important, and then lifestyle modification is the first thing, and that we have to, and we also have to counsel them regarding the hygiene measures, weight reduction, avoidance of tight clothing, taking a diet which is rich in polyunsaturated fatty acids and reducing the intake of saturated fatty acids, controlling their blood sugar. Physical activity is very important. You have to encourage them. Yeah,
Yes.
exercise,
Excellent.
physical exercise.
Correct. So that's the most important. So we only in children, you may have a positive family history. The obesity may be more, and the metabolic association of the comorbidities are much more when compared to the adults. So that's the main thing. And the treatment anyway, the general counseling, general measures, Dr. V has pointed out, that's very, very important rather than the pharmacological treatment. And of course, we have stage-based treatments and we all do that. But the importance is the counseling and the general measures, as Dr. V has pointed out, that should be our first line. So the pediatric HS is not that common. And if there may be a positive family history, the comorbidities are more and obesity is more and smoking component as the age group is, it is less. And the topical oral pendamycin, rifampicin, and biologicals are the treatment of choices along with the general measures. And finally, at the end, maybe the partial or the complete excision of the entire area. Yeah, this case is only for discussion. I also don't know the diagnosis. Let me be very frank in this. See, the 6-year-old boy started these lesions during his second year. There is no diarrhea, and lot of investigations were done, including the endoscopy. There are no malabsorption syndromes. You see the other figures also first. He has these lesions also elsewhere around the nasal and the perioral, hands and the joints also. And endoscopy, there were no malabsorption syndromes. Serum alkaline phosphatase was normal. Serum zinc was normal. And despite that, because of the distribution, everything we thought clinically it's only acrodermatitis enteropathica, and the zinc supplementation given, even with the higher dose, more than 3 mg per kg, 3 mg per kg per day, and he did not improve. So despite that, for months it was given before me and with me also, but it did not improve. So how to go? Any comment, anyone?
Sir.
Yes, Sridhar Raju, please go ahead.
Please, sir, go ahead.
Sridhar, please continue.
Sir, please go ahead.
Okay, I was saying we don't have a real glazed appearance of the skin and we don't have diarrhea. So acrodermatitis enteropathica or zinc deficiency would not come to mind. I would think if a presentation with this type of onset at 2 years of age, did the patient have any neurological symptoms?
No.
Or any hearing loss?
No,
Any
nothing. Otherwise, his
symptoms?
milestones were very normal. And when he came to me, he is 6 years old. It started at second year, but he came to 6 years old. And at this point of time, he was very fine. Milestones were normal. He was going to school. Yeah.
We'll have to do audiometry. Audiometry should be done because if there is hearing loss, then we can think of multiple carboxylase deficiency or biotinidase deficiency. We can think of these two conditions which are rare, not so common probably, and we often don't even have the facilities to work them out. But this type of presentation in some journals are there of such cases.
I didn't
but
do
they do
loss,
have neurological problems.
Yeah, I will do.
Neurological problems. Neurological problem and assessment of these enzymes can be done, though biotin assessment is not very common. But the biotinidase and the carboxylase things can be done in some labs.
Can be done? Okay. Sridhar, you want to say something?
This definitely appears nutritional, sir, some way or the other. Zinc is the most obvious go-to diagnosis. But still, if it is not zinc, then we have to go look for the other nutritional disorders as brought out by Rajiv, sir. In fact, the hand lesions look something like a pediatric, like Hartnup, the pediatric version of pellagra. But then covered sites. So it could be also a multiple etiology of nutritional deficiency where multiple nutrients are deficient. Sometimes trace elements, magnesium, these also can produce perioral lesions. So these have to be looked into, sir. Very rarely, of course, if it's very long-standing, then we have to look at those, pemphigus, because there are some serpiginous lesions, especially in the margin of the pemphigus vegetans type of lesions. But
those were done. Yeah, those were done. Sridhar, I did not know all those things because of time. Those are all the investigations were done. Everything was excluded, including the neuroforcing studies, histopathologies were done, and nothing was coming out. So as Raju has pointed out, could it be a biotin deficiency? We were, in fact, So we gave him along with zinc the other nutritional elements, as you pointed out, which contained biotin also. And he improved on that. Let me show you the, this is the clinical improvement when we give him the, added the biotin. So at that time, we never realized it is biotin deficiency. But with the zinc, when we added the other nutritional compounds which contained biotin, he improved like this. But whenever I stopped that nutrient and continued zinc, again he developed this. So then I thought, could it be only a biotin? Because whenever we were giving biotin, he was improving it. So I tried to find out whether could we do
Dr.
biotin.
Sitaraman, I'm sorry, you're just 5 minutes away, sir.
We are completing, no problem.
Thank you.
So that's how could it be biotin. So we tried to find out whether it is, I mean, anyone who can do biotin estimation, but as Raju said that it is just not possible. And that was something interesting which you had seen in this case. And he is still on biotin. And whenever I reduce the biotin and I stop the biotin, it completely comes back. Zinc I have stopped, and he's still only on biotin. Yeah, Raju, please.
Sir, this is very typical that if you administer biotin in biotinidase deficiency or multiple carboxylase deficiency patients, they improve.
Yeah.
So this dramatic response is seen more in these patients. The biotin levels, in fact, may be normal. The enzymes are lacking.
Is it available? Can we do that testing?
Yes, sir. It can be done. I think you can inquire from the labs.
Okay, fine.
It can be done,
inquire
sir.
from various labs.
It can be done.
Yeah, please. Where is that? Is it available?
We send our samples to the metabolic lab we have at Maulana Azad Medical College in the pediatrics department. So the biotinidase estimation is done there, and plus, the levels will be mild deficiency, moderate, and severe deficiency. So what the picture that Rajiv was talking about is for the severe, deficiency where they will have convulsions, seizures, and a neurodegenerative picture with severe seborrhea, stunted growth. But this child seems to be, otherwise overall normal. Doesn't have any seborrhea, just has
that's right. So thank you. We will get it done if it's possible. Yeah, Raju, please.
Multiple carboxylase deficiency should be kept in mind. It has varied presentation of different severity. Even
if it is available there, we will,
deficiency varies in individual. Yes, sir. Even somewhere in down south in a good metabolic lab, these things could be done.
I didn't think of the enzyme levels as such, but I inquired by team, but it was not possible. But now, based on your inputs, I will look into that.
Dr. Vibhu is always there to help.
I know. Thank you very much for pointing out that. So this was, I thought I will just share with you, and this is what is happening. Improvement with only biotin, right? So because we have STA vaccines also in our part, and just last two questions. So these are the two things I think specially practiced. All others are in experimental only. We all know that all the vaccines are available here. And this is the Indian journey, most of us know. So started from 2008 and till 2019, various steps are there, including the IARC study and the HPV vaccine, 2 doses versus 3 doses. That was the IARC study. Sridhar, would you like to say something? Because you have presented also this last time. And
yes, sir. Most certainly, sir. This is one of the few viral vaccines which we have against STIs. That is one is HPV and HPV. And HPV has vaccination has been dramatically successful in the West, especially in Australia, etc. In India also, it is taking off. I advise it to all the young girls who come to my ring. I have a daughter. I have vaccinated her as well. She's just 11, first dose taken. The point is the number of doses. The American guidelines recommend just 2 doses, and I think which are followable in India, considering the cost. And the vaccine which we can go to is the Gardasil vaccine. So that's available. It's costly, but that is recommended. If you can have the.
Is it the same price? It's mentioned here. Is it the same or something more?
Sir, it's increased now.
It's increased now.
Yeah, sir. It's actually for Gardasil, it is 3,570 is the MRP. Okay,
fine. So anyway, all others are in experimental stage. So nothing much to talk about those things. And HIV is another one. So the 2 vaccines are in practice, HPV and HPV. Others are in the preclinical stage. Yes.
Yeah, regarding this HPV vaccine,
it's a high time to sensitize, because in IAP there is a lot of awareness and sensitization, and the age is very important. The at 9+ is the ideal age to initiate the vaccination, because once this virus enters, the efficacy may be there, but not up to that mark. So 9 to 14 years, 2 doses with the gap of 2 months is ideal. That will give the sufficient 100% protection for the warts, but even more than 95% for the cervical intraepithelial. Even though if it is more than 14 years, we can give a booster dose with a gap of 4 months. What we are practicing regularly in a month, I have 4 to 5 cases I'll give. The thing is, the Gardasil, when you are giving the vaccination, always please keep that child in a lying down position. After that, let the baby or parents will be there in our clinic for 30 minutes.
Okay, thank you, Bhumesh, for that input. Yeah, Dr. Mania, sir.
Bhumesh, this HPV vaccine now is used as a treatment for what even? The perineal wart, vulval wart, it's been now tried as a treatment for what even? Dr. Sitaram, would you like to say something?
So the therapeutic efficacy of this is not established. In fact, patients who already have warts, if we give them vaccination, the protection is against the leftover strains, other strains. Suppose the particular wart is a strain 11, the person gets protection against 6 and 16 and 18. Therapeutic properties of this has not been proven, sir. It is mostly still a prophylactic. Hunt is on for therapeutic vaccines also, but the Gardasil is only a prophylactic vaccine, sir.
So thank you very much for all the panelists. Dr. Sridhar, Dr. Resham, Dr. Vibhu, and coming in, Dr. Bhumesh, for coming in the last time, Dr. Maniar, sir. So thank you very much for joining us. And Dr. Rajiv, so thank you. Thank you for the inputs of the biodetonase and the carboxylase. I will try to get it done. Thank you very much for all the panelists. Thank you for the organizing committee for giving us this opportunity to have this panel here. So thank you. Thanks a lot. Bhumesh, over to you.
Thank you, sir. Thank you very much. As usual, the excellent moderation with a lot of take-home bells. So this is the area we need to sensitize in the even in the initial stage, we thought of some people even why this pediatric genital dermatosis, does it have any significance? Definitely, it needs high index of suspicion. It needs more and more the awareness. Even IAP, they are doing a lot of awareness activities in the adolescent age. It's even behalf of IAT, well, it's high time to sensitize more and more in the pediatric genital dermatosis. So thank you very much for all your excellent inputs. It's the time to sensitize our younger doctors, the postgraduates, because they are the main pillars for the institutions and the future generations. Now I invite the quiz master for this session, Dr. V. Shirisha, a good academician and fellowship in the pediatric dermatology from CMC Vellore, and she is assistant professor from Osmania Medical College. Now over to Dr. Shirisha.
Thank you, sir. It's now time for the interesting part of the session, the PG's MCQ quiz. I'll repeat the rules once again. Each session will have 10 MCQ questions. You have to mark one correct answer, and the first 3 toppers will be selected. Duration of time is 5 minutes, and the quiz master decision is final. Please do not refresh or close the browser. All the best for all the PGs. Please go ahead with the quiz. Meanwhile, it's time for felicitation of our faculty. I request the chairpersons to felicitate the speakers, moderators, and panelists of the session. Dr. Srinivas Prasad, sir. Dr. Bhumesh Kumar, sir.
Excellent session, Bhumesh. Excellent presentations. Really very nice.
Dr. Sitaram, sir.
Dr. Sitaram, as usual, superb.
Dr. Arun Inamdar, sir.
Missed you.
Dr. Rajiv Sharma, sir. Dr. Sridhar Jandyala, sir. Dr. Vibhu, ma'am. and Dr. Resham ma'am.
And to the quiz master, Dr. Suresh.
Now I request the organizing team to felicitate our chairpersons, Dr. Dinesh Mathur sir, Dr. Shamanta Barua sir, and Dr. Madhubabu sir. I thank the organizing team for the wonderful opportunity given to me. Thank you, sir.
Thank you, everyone.
Yeah, thank you, Dr. Sirisha. Now, the last session, today last session of this e-ASTICON, but a very interesting and very important session. We are covering here the COVID and sex and skin and the sexology. So for this, I invite Dr. J. Tulsi, the session coordinator. Over to Dr. Tulsi.
Thank you, sir, for giving me this opportunity. Good evening, everyone. I'm to our session. I would like to invite the chairpersons, Dr. A.K. Jaiswal, sir. Technical person, please share the slide of A.K. Jaiswal, sir. Yeah, sir is a senior consultant, former professor and HOD of AFMC and DRAMC, and serves as former additional director general of Armed Forces Medical Services, and ex-vice president and general secretary of IADL, ex-president and vice president of IASTD and AIDS. Sir has written 20 chapters in IADL, API, and IAS-STD textbooks. And sir was honored with 8 awards and 9 orations, and honored with 3 highest national awards. Sir has 150 national and international publications. Warm welcome, sir. Please chair the session. Next, I would like to invite the second chairperson, Dr. V. Manohar Kumar, sir.
Mohan Kumar.
Mohan Kumar, sir, who is working as associate professor in the Department TVL of Government Hyderabad Medical College, Peranduran. Sir has 14 publications, 10 presentations, and has so many honors and awards. Sir's areas of interest are STIs and HIV and AIDS. Well,
And sir is the honorary general secretary of IAS-STD AIDS.
And third chairperson, Dr. B. Janardhan, sir. Sir is having 6 national and 6 international publications. Sir is working for 15 years in different teaching colleges, now working as a professor at Bhaskara Medical College, Moinabad. And a very warm welcome, sir. Please chair the session.
And the treasurer of IADL Telangana. Yes.
I request A.K. Jaiswal, sir, to invite our first speaker, Dr. D.G. Sapre, sir. Jaiswal, sir.
Jaiswal, sir.
Respond.
So if sir is not there, we'll move on to the Dr. Marpatias. He is not picking up the phone. So we'll move on to the second talk.
Okay. I would like to invite the second speaker, Dr. Yogesh S. Marpatias, sir.
Srinivas, Marpatias are PPT.
Yes.
I request Dr. V. Mohan Kumar, sir, please invite Dr. Yogesh, sir.
I invite Professor to invite our editor IJSTD, past president of IASTD, the Commission for Excellence, Professor Yogesh Marpatias, sir.
This also present.
Hello, is I'm audible? Yes. I'm an immense pleasure to invite our Professor Yogesh Marpatias, sir, our past president IADVL and IASTD, our IJSTD editor for the past 2 decades. Over to Marpatias, sir.
Thank you, Dr. Mohan Kumar.
And thank you, Bhumesh Kumar and team.
Marpati sir, PPT.
Yes, my PPT. See, thanks for giving me a different topic, at least out of box topic. Usually, I am not in a habit of talking on such this thing, but I have taken this challenge. Thank you, Bhumesh. My PPT may be projected now.
Srinivas, Marpati sir, PPT project.
I have already submitted it.
Yeah. Ah,
Yes, thank you. See you can come to the second slide. Yes. So, yes. So my topic is skin and sex. Next. See, our domain of dermatologist is not only dermatology, it is venereology and leprosy as well. And patient coming for treatment of STI or venereal problems, they are more comfortable to discuss about their sexual issues. So we are at advantage while handling sexual problems. Next. Why skin is very much important? Skin is very much important because it is not the largest organ of the body, but it is also the largest sex organ. It has got surface area between 1.5 to 2 square meters. In addition to perceived visual importance, skin is our largest sensory organ. 5% of blood pumped through cardiac output reaches in the skin in healthy conditions, and in particular, touch sensations plays a vital role in initiation of sexual response. Next. So, on an average, there are 650 sweat glands per square inch. There are 20 blood vessels per square inch, 6,000 melanocytes, and very profuse nerve supply, that is more than 1,000 nerve endings, and it is up to 8,000 in clitoral skin. Next. So genital skin is specially tailored by unique glands, erogenous and elastic tissues, profuse blood supplies, nerve supplies. It has got a very favorable endocrinal milieu, and it is suitable for sexual attraction and interactions. Genital skin is an inseparable part of sex organs. Any disease affecting genital skin will have a profound impact on sexuality. Next, please. Yes. So research has shown that human babies need touch not only to survive, but to thrive. Touch can also have biologic effects, such as by helping to promote the release of oxytocin, which is described as bonding hormone or cuddle hormone. Touch can have psychological effect of helping people to feel loved, happy, accepted, calm, or reassured. Women are 5 to 10 times more sensitive to touch as compared to men. So one of the most pleasurable parts of sexual intimacy is the experience of touching and being touched all over. Next. So skin is very active endocrinologically and reflects endocrinal changes occurring in body throughout the life cycle. It is an important organ of immune system. Skin and brain originate from neuroectoderm. Skin is a point where mind and body meet. It is an organ of expression. So skin is an important part of non-verbal communication, including psychosexual communication. Next. Yes. So anything that affects skin health in terms of appearance, this includes systemic disease, mental illnesses, generalized skin diseases confined to genitalia and erogenous zone. They will have tremendous impact on sexual health. Next. So impact of systemic illness or skin diseases is in terms of reduced self-esteem, anxiety, depression, social avoidance or isolation, and it will have a lot of impact on sexuality. If we don't take proper history, we will never get it. Such patients usually go to sex therapists because many of us now, we are sort of averse to practicing in this dimension. So, I mean, some awareness is required. Next. So generalized skin diseases like chronic vesiculobullous disorders, connective tissue disorders, erythrodermas, atopic dermatitis, psoriasis, lichen planus can have negative impact on sexual health. Chronic debilitating skin diseases can lower testosterone levels as well. Decrease or loss of sexual function in many chronic skin diseases has recently attracted significant attention owing to its impact on quality of life. Next. Yes. So coming to genital dermatosis and its impact on quality of sexuality or sexual life. So genital dermatosis like hidradenitis suppurativa, lichen sclerosus, erythroplasia of Quera or Zun's balanitis, or even simple vitiligo localized to genitalia and other erogenous area. They may not be considered mild. See, whenever we assess any disease like psoriasis, we go for PASI score. But having lesions, only psoriatic patches to genitalia and not all other part, it is as important as a high PASI score. So the message is that whenever there is any generalized dermatosis dermatosis affect predominantly genitalia, it should be scored in accordingly, and it should be not be considered mild and to be treated adequately and aggressively. So in short, while evaluating such dermatosis for DLQI or quality of life, not only physical but mental component must be taken into account. Next. Pruritus and genital contact allergy. So genital pruritus is very embarrassing and will definitely have impact on sexual life. It can be due to infective causes and non-infective conditions. Another neglected topic is genital contact allergy. There are many causes of it. It is important to consider this neglected condition in cases having recurrent or intractable or unexplained pruritus. Even conjugal contact dermatitis can have impact on sexual activity, and high level of suspicion is required to label it. It is reported that seminal fluid can cause angioedema or urticaria in the male partner. So there are many such situations or something used or some lubricant or something, and one partner use it, another partner have problem, and in turn it will create a problem on their sexual activity. So proper diagnosis and management will have positive impact on sexual health. Next. Impact on of infective genital dermatosis. We all know that STI have tremendous impact on sexual health. In my present practice, or most of us, we are regularly getting herpes cases, genital herpes cases, particularly in young people, newly married couples, or about to marry person. They have a lot of concern about their sexual activity and having child and all this. That is to be addressed properly. Impact of infections like tinea, candida, intertrigo needs to be dealt with promptly and adequately. We must offer them prompt relief. Leprosy, tremendous impact on sexuality due to fear of contracting infection, neurologic deficit, deformity, and importantly, lepromatous cases can have lower testosterone level. We all know that. HIV and AIDS, I need not discuss, but will definitely have HIV, AIDS, ART will have tremendous impact on sexual life of the cases. Next. Then another important thing, appendageal conditions of genitalia. Like hyperhidrosis, bromhidrosis, chromhidrosis. This can be must be evaluated and managed properly. Antiperspirant, glycopyrrolate wipes, they have temporary effect and can be used, or sometimes some drugs particularly may be considered anticholinergic type of, not regularly, but during vacation or something like that. Adnexal tumors of genitalia may have aesthetic and visible impact. They are usually underdiagnosed or under-recognized and needs proper labeling and, if required, excision or surgical management. Hairy skin is more prone to folliculitis and other issues. So good, healthy-looking skin with good smell or odor will provocate or ignite sexual desire, and we should try to facilitate this type of milieu in our patient. Next. This is equally important and neglected. Drug used in many dermatologic management, they have impact on sexuality by lowering testosterone. For example, decreased Leydig cell testosterone production due to steroid or ketoconazole, binding to the androgen receptor, that is spironolactone, frutamide, ranitidine is affected. I mean, when patient is on those medications, decrease gonadotropin secretions. We all know about steroid, ACTH suppression, then estrogen, progestin, or even prolactin, or a drug that raises prolactin level. They may have such impact. Conversion of testosterone to dihydrous testosterone is affected by oral finasteride. Of course, by and large, such chances are very less, and now we are comfortable in using finasteride except in small number of cases. But this is always to be kept in mind. Next. Many other drugs which we use, like antihistamines, particularly first generation antihistamines, potent and sedative. I mean, then opiates, some NSAIDs, some vasoactive drugs we use in connective tissue disorder, nifedipine, enalapril, immunosuppressive agents. We all know about cyclophosphamide, which is not to be now given during, at least during reproductive age group, because of various reasons. Next. Yeah, circumcision and genital health. I think I attended this particular talk in the morning, and it was very much highlighted its importance. So circumcision improves genital health. It decreases the chances of acquisition of many STIs, including HIV, and WHO has recommended circumcision as an additional strategy to control spread of HIV. It improves prognosis of many non-venereal genital dermatosis, recurrent balanoposthitis, Huhn's balanitis. Overall, it improves quality of sexual interactions. Interestingly, majority of Indian males are uncircumcised as compared to other countries where by religion practices, many of the people, they go for circumcision. But overall, it has got positive impact of on genital health and sexuality. Next. So sexuality is a complex process coordinated by neurologic, vascular, endocrinal systems. Skin is richly
Dr.
supplied
Yogesh,
by,
I'm
yes,
sorry to
I think
intervene. You
one
left
minute.
3 minutes.
Skin is richly supplied by nerve endings, blood vessels, and it is highly active endocrinologically. It is the most important sex organ. Next. These are concluding slide. Skin and sex. What is the role of dermatologists? It is important that dermatologists, in addition to being sensitive to psychological significance of the skin, also pay attention to significance of human sexuality, the influence of skin on eroticism, and the role of dermatologic pathology on human relation and thus also sexual relations. I think with this, I conclude. Next slide. So I acknowledge organizers of ASTICON, Dr. Bhumesh Kumar. Many of the material I have taken from slide sets of Venkatramanna available on Dharma Gyan lecture series, IADVL. Thank you, Dr. Venkatramanna, and my PG student, Dr. Apexa and all. Thank you. Thank you very much.
Well, thank you very much. Am I audible?
Yes, sir.
Bhumesh, I'm sorry that time there was some problem in my this thing. So on behalf of myself, my Dr. Major General A.K. Jaiswal and my colleagues, Dr. Janardhan and Dr. Mohan Kumar, welcome you all to this very interesting session, the very last session. Our last session may be good news for some and maybe bad news for others. But then in this particular session, we are going to have some very interesting aspects like COVID-19 versus sex, skin versus sex has already been dealt with. And the interesting part that in this session, I have very good old friends of mine, all of them. Dr. Marfatia, Dr. Saple, Dr. Kaushik Verma, Dinesh Govil, my dear friend, Dr. Patnaik, Kavi Rashnan, Dr. Mohanlal, all of them are very good old friends. And we have been co-examiner very many a times. At the same time, I must compliment Dr. Marfatia for a very interesting and lucid presentation. Now, can I have the liberty to invite Dr. Saple?
Yes, sir.
Invite, sir. Invite.
May I have now the liberty to invite my good old friend again, Dr. D.G. Saple. He shall be speaking upon COVID-19 versus sex. May I have Dr. Saple select? Well, Dr. Saple needs no introduction. I think he is one of the known, very old figure in field of dermatology, especially STD and HIV and AIDS. Of course, as you can see on the slides, he's all vast achievements. Only thing I can say that he is a wonderful, very down-to-earth person,
very thorough academician and a widely acclaimed dermatologist and venereologist. Dr. Saple, may I have the honor to invite you to share your thoughts.
Saple sir. Saple sir is there? Saple sir. If Saple sir is not there, so we'll move on to the panel discussion. Tulsi, you invite Dr. Janardhan to introduce the moderator.
Request Dr. B. Janardhan sir to invite moderator Dr. G. Venkatramana sir to conduct the panel session.
Am I audible?
Yeah.
Very good evening to one and all. I thank the organizers for giving me an opportunity to chair this session, important session. I would like to invite Dr. G. Venkatramana sir, who is a well-known speaker from Telangana. He is former professor and HOD of Osmania Medical College. He has 19 publications to his credit. There are more than 576 presentations at various levels and forums in the conferences and many awards too. Brief. His areas of interest are sexology, STDs, HIV and AIDS. So today he will be moderating on the session sexology, which will include pornography, lifestyle, diabetes, obesity, etc. Over to Venkatramana sir to start the session.
Venkatramana sir, you put it in slide mode.
So thank you one and all for inviting me here. Today the topic is porno and its effects. Today porno is available everywhere, nook and corner, from gully to Delhi. So each and everybody is watching and observing this porno with astonishment initially, then interest and enthusiasm later on. This porno, now everybody is learning today, not from healthcare professionals. They are learning the sexology or sex education through pornography only. The time has arisen now. We healthcare provider should rise to this occasion to help them in separating the fact from fiction. They should realize which is real, which is real. This pornography can be defined as any material, a representation of human body or sexual activity with the goal of sexual arousal or sexual energy relief is considered as a pornography. Other definition is explicit portrayal of the sexual activity for the sake of sexual stimulation, usually through many forms like story books, story pictures, videos, etc. This pornography today has grown up into leaps and bounds, taking shape in almost every form of media with unlimited availability and a plethora of observers. My dear friends, today 26 million sites are dedicated for pornography. 260 lakh sites are there in the internet. 30% of web traffic is dedicated to porno. 40 million Americans are visiting the porno every day. 2/3 of men and 1/3 of women are observing. That means even woman race is also contributing 1/3 in the logging of porno. Most of the time, this porno is observed 7 p.m. to 3 a.m. On an average, Philippines are observing 9 minutes every day, whereas we Indians are observing, watching the porno for 8 minutes and 20 seconds. This is an average figure. So Indians, 30% females are watching the porno, 70% males. We are the highest. India has got this distinction, of dubious distinction, that women race is 30% highest in the world. Our woman race is watching the porno. Even the liberated country like America is only 25%, Canada 25%. Every second, this porno industry is earning billions and billions of dollars. For every 39 minutes, one new pornographic video is uploaded. It's earning 13 billions from the USA. See, so child pornography generating 3 billions per year. So huge revenue is involved in this porno, spreading its tentacles silently in epidemic way. And Indian, these are all the websites people are watching. As I told you, we are having highest number of women watchers for this. And in women, 8 minutes, 31 seconds average. Global average time is, we are above global average time. And these are all the porno sites and porno rates of male and female. India is the third largest consumer of porno. India is the third country, largest country who is consuming the porno. Apart of the first two countries being United States and UK, United Kingdom. Now, in order to know more about this porno and its effects, I invite the learned panelists here. The first one, the senior most, Dr. Kaushal Verma. I invite you, sir, a senior person, a physician from Royal College of Physicians, Edinburgh. And he is almost 150 research publications, 24 chapters. As a past president of various our associations, IADVL as well as IASTD. And he is a member of International Contact Dermatitis Research Group. He is a senior, well-informed person, eminent personality. Let's invite with a big hand Dr. Kaushal Verma. The next senior person, Dr. Dinesh Goyal sir. He is also a very senior man, having 34 publications, a lot of honors and achievements for him. He is also president, past president, IASTD, IADVL, president IMA Jhansi branch. Lot of, he has hugely contributed to the professional development and for the academic development of the PGs. I invite you, sir. Please give him a big hand, please. Now let us, after finishing north, I am coming to south. Let's invite our Kaviyarasan sir. He is from Chidambaram. He is professor and HOD there. He is also a well-informed person. He is editor-in-chief of Journal of Clinical Experimental Dermatology. And he has having more than 20 years of teaching experience. He has authored many chapters in IAGD textbook about leprosy. Welcome, sir. We invite you wholeheartedly. Give him a big hand, please.
Thank you, sir.
Then let's go to east. Now, Dr. Satyadarshi Patnaik is also professor in HOD from Berhampur. He is having 24 publications, lot of awards and honors for him, to his credit. So we invite you, sir. And he is president-elect for this IASTD. We invite you, sir. Give him big hand, please. Then the junior Turk, a more interested person, interested in area of STI and HIV, Dr. Mohanlal, who is associate professor from Usmania. We invite you, Mohanlal. Give him big hand, please. So now, my dear friends, we have chosen the panelists from east, north, south, east, west. Now you can pose any questions. As I have prepared certain questions, let us learn from them, from the panelists. The first question is, why do people watch porno? We'll go to first Verma sir. Kaushal Verma ji.
Thank you, Dr. Venkatraman, for having invited me, and my thanks to the organizing team, including Dr. Bhumesh and the entire the board of organization. I'm certainly not an expert in the pornography, and I have very little idea compared to several of you who might be having it. But now this is an interesting area. And why do people watch porn? People watch porn, I guess sex is the integral part of, say, the adult life. And people do want to have a pleasure and have, say, the excitement and entertainment in the form of pornography. And as we have seen in the previous lectures also, that this is an interesting and integral part of, say, the adult life. People have to practice sex. They want to have the pleasurable life. They want to derive pleasure out of, say, watching the online material, or seeing the books, or maybe reading through the books. So I think it is very important, and it's an integral part of adult life. So, and since it interests everyone, like you have shown the data from different countries and say from our country also, where it has shown that yes, large number of people are into this. And my guess is that even more would be there. This survey might have not say brought out the real pictures or the real numbers. There may be many more people who may be watching this and not included in this survey. So I think it's quite integral to the human health, and also it is to the emotional health and the sexual practices.
Thank you, sir. Yes, many people watch it is because of curiosity. Some people watch to beat the boredom. Some people watch for the sake of comfort. Some need a feel to feel powerful. Some watch because of peer pressure. Some watch because to escape the regular stress. Some watch for fantasy indulgence. Like this, there are various reasons. More or less, as you rightly said, sir, everybody is watching the porno. Somebody are admitting, many are not admitting. So selfishness, loneliness, male insecurity, poor body image, marital conflicts, weak spiritual life, sexual Italian philosophy, mistrust of the partner, woman or man, lack of sense of fulfillment. All these things are contributing factor for watching the porno.
Spiritual life may not have much to do with this.
The person who is more spiritual, he'll be less porno. less spiritual, more porno. This is vice versa, opposite side. The second question is, what are the benefits of watching porno? Why so many people watching means there are certain benefits are there. That's why they are watching. So what are all the benefits for watching this porno? We will go to Satyadarshi Patnaik, sir. Patnaik, are you there?
Yeah, he's there. He's there.
Patnaik? If not, then I will go to Dr. Kavira.
Yes, sir. Yes, sir. I am there.
Yeah. Please.
Thank you, sir. Thank you, sir. The benefits are there are people like women you told who do not know about sex, or they do not have the courage to ask their seniors or friends about sex and its intricate applicability. So they watch porno secretly to get knowledge from the pornographic films or journals. Next, those who are having weakness in arousal process, they also do not, they also turn to pornography for getting arousal, and they also achieve orgasm during watching or reading pornography. So people derive their pleasure out of pornography by achieving orgasm, by achieving arousal, and there are some people who want to take up different positions in sex life, so they want to experiment. For that also they search the pornography, and pornography also leads to achievement of sexuality in a total.
Yes. Thank you, sir. You rightly said, it increases the libido, it relieves the stress. If the person limits only up to watching, it is free from STDs and HIV, unless he does experimentation outside. It is an opportunity to explore the sexuality. So anybody, this is a very, very important benefit for the porno, because as a sexologist, I will get clients, that patients from well-educated background, but they don't know how the sex occurs in between in the bedroom. Lot of highly educated people, civil servants are there, but they're very poor in sex education. So this pornography, it gives an opportunity to explore that sexuality, provided if judiciously utilized. And another benefit is it is a safe unless we experiment outside. It's free from diseases. So just watching and relieving your stress, relieving from boredom, and at the same time, people, particularly couple who are not having satisfactory sexual life, both together watching a porno will reboot their couple's sexual life. Provided both should watch together. It gives good ideas, helps them to touch with each other, helps them to turn on, and make them to titillating effects and getting more intimacy in the couple relationship. So that's how you can take the advantage of watching this for the couple. At the same time, solitude will benefit your relationship, provided both should watch. Another benefit, it burns calories, enhances the sleep because of release of dopamine. It protects. The more you masturbate, the more semen you ejaculate, the more is the safe prostate. You will be protecting from carcinoma prostate. That's another advantage. So watching the porno, releasing the stress, burning the calories, so these are all advantages. Now today, this sexology or pornography has taken another turn called online sex. So what makes the online sex so popular and so exciting? Now we'll go to Govil Saab. Dr. Govil Saab.
Yes, sir. Again, I will repeat what Dr. Kaushal said. I'm not an expert, neither have much experience. And my thanks to the organizers to giving me this opportunity. The online sex, the cyber sex, as people call it, is safe. As you know, the sex is a natural thing. It's one of the most pleasurable thing in life. And every time any sexual stimulation is there, the sex is there for production of the next generation. And for that, the nature has made us in a way that any sexual thing attracts besides food, which is literally required for our living. Sex is also for the living of the next generation. So nature has made us in a way that any sexual stimuli is most pleasurable, and people take advantage of that. Even cyber sex, even talking to persons on cyber sex, gives arousal and even can lead to orgasm. So it's safe. There are hardly any chances of acquiring STI.
Yes, sir. Excellent, sir. Anonymity is the another advantage. That's why people will resort to online sex.
That is true. Accessibility, affordability, anonymity.
Anonymity. Yes, sir. Thank you, sir. Thank you very much. Now we'll go to next question. Watching porno is illegal in India. Dr. Mohanlal.
The Mohanlal is not available, sir, because he has some work. So
okay. We'll go to again Dr. Kabirasan.
Sir, actually, there is. It is not illegal to watch the porn materials when you are in a private position or in an individual separate room. And if you just see a video, then after that, if you store or share, then that is an offense.
Excellent.
And even India they wanted to they tried to ban the porn in 2015. It was unsuccessful. Even they tried in 2018, so that was also they're not successful, because you cannot restrict the porn watches. And every year, every day, watches are more than 8%, as you just quoted at the beginning. And it is like increasing day by day. And those days and all, when we were young, just I'm talking about 40 years back and all, and it is very difficult to see the thing. And even some people, they crave for the even books and other the literature for that thing. But nowadays it is
yes,
poor.
a lot of bills have been there in the Supreme Court. Supreme Court have heard elaborately on this subject, and it's clearly mentioned that it is interfering with the personal freedom, constitutional freedom given to the individuals. That's why they said we can't avoid porno, but we can restrict, we can abandon porno. Child pornography is abandoned.
Yes, sir.
In India. So these are all the top 6 states who are highest watchers of porno in India. The first being West Bengal, the second being the Gujarat, East and West, the third being Delhi, fourth being Meghalaya, and fifth being Punjab. Rest of the states are taking 6th to 20th positions. So as rightly said by our Professor Kavirasan, watching privately is legal, not illegal, but watching public places is illegal. Storing and transmitting and shooting and producing is illegal in India. We cannot do. Other countries, it is legal. At the same time, lot of laws are there apart from legal laws, that is Indian penal IPC laws. There are IT laws also will come into picture. IT laws, particularly law 16 and 17. So this is the world picture showing you all the green color things. It is legal to watch, to publicly exhibit, to produce pornography. Red color countries are, it is illegal to watch in public, to produce in public, to transmit in public. Yellow color is via media. Certain restrictions are there, not totally illegal. This is the total world picture I am focusing here. So publicly is illegal. Whatever you do, do it privately, individually. The section 14 of the POCSO Act deals with this. Section 15, it's illegal and it is a punishable offense of 3 to 5 years in jail. And additionally, IT section 67B deals with this. Is a punishment, it's a non-bailable punishment, and the obscenity comes into the picture there. So 67 Act, IT Act is a very powerful act. In that 67B is a punishable act. So watching the porno publicly, it's a criminal act. Now let us go to another area. Say for example, today, a patient may come to you, a lady patient comes to you and saying that, doctor, my husband is watching the porno. I am having a lot of ill feelings about this. So can you elaborate what are all the feelings the woman can feel when her husband is watching the porno? We'll go to again Kaushal Vermaji.
I think this has more to do from the cultural origin. It depends as to which culture or which background the people are coming from. There,
Yes,
in
sir.
certain cultures, like you have shown that yes, it is acceptable, and both the husband and wife, they watch and they enjoy together. In certain cultures, it is considered to be even watching pornography is not moral, immoral, and people don't. I mean, they don't. They attach a sort of kind of stigma to this. So the women who are coming from certain backgrounds, they feel that yes, if the husband is watching pornography, this is immoral. It is not right. When the wife is there, they can have the sexual contacts or sexual intimacies or the sexual feelings or sexual expressions with the wife, rather than having it through the other sources like online platforms or the books or maybe the other materials. So some women will feel not comfortable. I think majority in our culture, because they have been brought up in such a way that this considered to be immoral. I am not sure that we can call it unethical, but yeah, morality is attached to the sex.
These are all the feelings which I observed through my patients.
Yeah.
They feel deeply hurt and betrayed.
Yeah.
They feel that they are unattractive, sexually undesirable. That's why my husband is going to the pornography. is shifting his interest.
True.
And they feel that they are inferior. They become less, body image will become less for them. Because they cannot compete with the young women in the pornography.
And
At the same time,
they don't really realize that these are basically the models. And the best people are taken in those for the photography or for the picturizing those
and
scenes.
this woman, some woman will feel that it is a sign that he is not satisfied with her in the relationship.
True.
Some women will feel that it may not, I am unable to turn him on. Some appear that I am not enough for him. So these are all the various types of reactions the woman will feel when her husband, her partner is watching the porno. And certain women will feel that their husbands are untrustworthy. They are weak role models for their children. And many quarrel with them, and a lot of marital problems. Even certain cases will come to divorce also. How these women will react when they started feeling of the various varieties of feelings which you enumerated, how they react with the husbands who are watching. Now we'll go to Goyal Saab.
The feeling of reaction which I can understand is again the low self-esteem comes up because when they feel that they are not attractive to their husband, they will feel that low self-esteem will come up, and then the quarrel may set up in marital life.
Yes, sir. Some people, they ignore him and suffer silently. Some people, they start quarreling and they want to teach him a lesson. They too start seeing the porno so that that fellow will be taught a lesson. Some start great cheating and may go for divorce. So these are all how the woman may react. This woman is started want to teach a lesson to her husband. She started watching the porno. Arguments went on. This case went to divorce. And here this woman is suffering silently. Now let us go to our Satyendrasri Patnaik sir. How the husbands react when the woman is, their wives are watching the porno.
The husband feels that their wives are low integrity and they suspect them that they may be having extramarital affairs. So there is a situation of mistrust between both the partners.
Yes, sir.
The husband quarrels, arguments with the wife and suspects about her fidelity, and
yes, sir.
There is a tension growing between them.
Yes, definitely. Because ladies at least magnanimous enough to excuse the husband, whereas husband is a very poor fellow, very jealous fellow. This fellow will not excuse her and he feels more ill about her. He feels that I am not satisfying her. She needs variety. She is not trustworthy. She is a slut. So this is how the men race will react when their partners are watching the porno. Now let us watch the other side of the coin. Now having surfed over the benefits of it, what are all the ill effects? Is watching a porno is bad? We'll go to Dr. Kavirasan.
Yes, sir. Actually, too much of watching porn is bad. And a lot of people, they say it is kind of sex education.
Mm-hmm.
Yeah, and even a lot of the students and or at the time of this one, so they learn, and if you just see the porn, say they feel like a masturbation, other things. Suppose at the time of that age group, the tender age group, and so they feel they are relaxed, and the sex crimes and other things are less. And too much of watching, and it is associated with some they lost interest in other routine activities, the school performances,
yes,
and
sir.
they used to watch in the thing because smartphones and it has given way for everything. Almost
yes.
The entire thing is open for everyone, and I think too much is the addiction and other thing has to be controlled.
Yes. This porno doesn't have any love, affection, intimacy, foreplay, nothing. They will straight away jump into the action. So that is divide of relationship, divide of love, divide of intimacy. It reduces the desire for spouse. So the fellow easily attracted, easily stuck to the pornography and taking less interest towards the partner. So he's more attached to the porno, leaving the partner aside. So near yet so far. Porno makes you are a lousy lover because you want to get right into the act without any foreplay. Porno makes you more critical of your spouse and less in love. And porno makes you crave for more extreme sexual acts, keeps you from being tender because of the release of dopamine, tons and dopamine that takes up this forebrain and cortex. That's why you are not happy with satisfaction. You will be craving for more extreme acts. So porno is more abusive unless properly, judiciously used. So anything overuse is difficult. What are the psychological effects of watching porno? Again, a sub question in this is the psychological effects are becoming angry, hostile, irritable when the spouse asks this fellow to stop using porno because he is getting more involved in it. So anybody asking him to stop, don't watch, that fellow becomes angry, becomes hostile, becomes irritable, and it leads to a lot of secrecy in relationship. So instead of watching in the times he goes out or he goes into the room, locks up the room and watches it, or watching this cell phones. Like this, lot of secrecy comes into the relationships that spoil the relationship. It reduces the intimacy. It reduces the emotional distance. Overall, poor quality of relationship which sets in between the wife and husband. Being unable to abstain from porno, lot of working hours lost, disciplinary action, job loss will occur to that fellow. Lot of missing assignments for this IT people. For the students, a lot of skipping of their classes. Their grades will become decline. And not only the psychological effects, even the physical effects are also there. Dr. Patnaik, are you there?
Yes, yes.
What are the physical effects of watching porno?
The physical effects are they get tired and there is they are not able to concentrate on their work. There is decrease in appetite.
Yes,
and
sir.
There is more of pain, fatigue, and lethargic feeling.
Yes, sir.
And sleeping disturbances, of course, are there.
Yes, sir.
And,
because they will be watching prolonged hours exposure to the screen, ultraviolet rays, dry eyes, carpal tunnel syndrome, headaches, sleep disturbances, eating irregularities. These are all the neglected family and friends. Problem with the job and schools. So these are all the physical side effects of watching porno, and a lot of family side effects are all there because relationship is getting affected. Because of that, a lot of family problems do occur. And now many panelists have used the word too much porno, watching too much time. How much is too much? Now we'll go back to our first speaker, first panelist. Is there, senior man?
Yeah, are you asking
sir.
me?
Yes, sir, Kaushal, sir.
Dr. Govel is the senior most person.
Okay, sir. Anyone? Now next question will go to Govel. Now you answer
okay,
this.
Okay. I think there is no fixed time frame that yes, it should be this much, and it cannot be. Like stop after 5 minutes, or stop after 7 minutes, or stop after 10 minutes. But it should be a reasonable time which does not produce the psychological impact, the negative psychological impact. It should not produce the negative physical impact that we have been talking about, and not the negative emotional impacts. So it has to be balanced in such a way that it is healthy and it is practiced in a manner that it does not affect the other aspects of the life, whether these are personal, physical, social, emotional, or your workplace.
Yes, sir. Excellent. As long as your work is not affected, As long as a job is not at culprit, as long as your relationship is not at trouble, as long as a loss of track of time is not there, it is not too much. If you are losing track, if your job working hours are suffering, your relationship is suffering, your sleep is suffering, your health is suffering, or you are deeply ashamed and guilty, feeling depressed, then you are watching too much porno. So too much
no
is
fixed time.
No, it's subjective. Each couple, each person is having different time. Some people may get 10 minutes too much. Some people may be 6 hours too much. So these are all the signs that should be there to say that that person is watching too much porno. Say, this girl is watching up to 3:30 in the morning, early hours. So no sleep. So she is more prone for dry eyes, irritable eyes, sleep disturbances. As a result of less sleep, more hormonal disturbance will occur. Her circadian rhythm will be affected. So more hormonal disturbances will occur for her. So these are all the things will happen. Now our panelists are used the word porno addiction. Is really porno addiction is there as morally simply weak, selfish people or weak moral people are getting addicted to this. Now we will go to Dr. Govel Saab. Porno addiction.
Porno addiction word has been used, and people who cannot go away from watching. But some people have used the word compulsive behavior.
Yes, sir. Excellent, sir.
Almost 20% of people do have compulsive behavior in themselves. And as you mentioned earlier, if you cannot keep away from watching porno, then it's a compulsive behavior, or you may call addiction.
Yes, sir.
It affects the life of the person, the relationships of the person, even job of the person, and their family relations also.
This porno addiction is, as rightly said by our Goel Saab, it is classified as a addiction, compulsive behavioral disorder. And in DSM-5 by American Statistical Manual and our WHO ICD classification doesn't use the word porno addiction. They use the word compulsive behavioral disorders. So this is the compulsive behavioral disorder. So this compulsory behavioral disorder, a lot of psychological impacts are there, and men are, because why men are more becoming addictive or compulsive behavior is, men are usually visually stimulated easily. Viewing the erratic images releases more dopamine, and that creates a more feeling of excitement. That more excitement leading to orgasm and wants more desire. That more desire leads to more again surfing. More surfing leads to more dopamine release. More dopamine release to more desire again. So this is a never-ending process. As a result, this fellow will be totally immersed into the porno activity, neglecting the relationship, neglecting the job, neglecting the studies. That's how his compulsive behavioral sets in these persons. So it's a point at which porno starts a negative impact. As you develop tolerance, watching to certain extent, it won't give satisfaction to him. It puts a comma only. It won't put full stop there. So that fellow will be searching much more, then much more. So it goes on. That's why it becomes a compulsive behavioral disorder. This compulsive behavioral disorder leads to compulsive masturbating, or leading to sexual dysfunctions, or experimenting the extreme sexual activities what he watched in the porno. That's why more social calamities like sexual adulteries, rapes, all these things occur by certain only less than 1% of people are doing this because of the compulsive behavioral disorder sets in. Not all porno watchers are becoming compulsive disorder or porno addicts. There are certain reasons. Only less than 1% are becoming compulsive addictive disorders. Those are all the people who are behaving antisocially. So use of pornography negatively affects our sexual life, difficult to become aroused. As a result, there is one entity called porno-induced erectile dysfunction. This is the latest observation. For the last 3 years, throughout the world, sexologists are observing this. So when the people are watching porno excessively too much, or addictive, or behavioral compulsive state, then these people are manifesting physically in the form of erectile dysfunction because of the reduced response to erectile tissue. Because of the binge watching leading to dopamine release, decreasing it and not responding, leaving the mind not responding to this. Dopamine release not only for sex, even for food can release the dopamine. A good nutritious food. If our Kaushal Verma Saab offers a nice, nutritious, sumptuous lunch, so that feeling of sumptuousness will release the dopamine. So the first one, the curve in the first topmost curve is the food release. The bottom one is the corner release, nicotine release, cocaine release. The porno one is continuously releasing it because it never ends. The desire never ends. That fellow will be searching for some more new things, some more new things. So because of that, dopamine continuously shooting of dopamine in the brain will exhaust. Here afterwards, he won't respond to that. That's why you manifest in the form of erectile dysfunction. Porno-induced erectile dysfunction is a new entity of late. How today the lifestyles, particularly alcohol taking, obesity, comorbid like diabetes, affecting our sexual lives. Now we'll go to Satyadarshi Patnaik Sahab.
Sir, due to smoking and alcohol, there is loss of libido and erectile dysfunction in men. And in women, there is coital pain and arousal problems, or there is sexual dysfunction. So they feel irritated because of that. And all the newer, the younger generation, they get less of coital pleasure.
Dr.
and they're,
Patnaik, I'm sorry, just sorry to intervene. Dr.
Yeah,
Venkatramana,
I'm
we are
aware.
cutting close.
I'm
Yeah.
aware. We are
Thank you.
closing by
Thank you
2
very
minutes.
much.
Yeah. Over to Patnaik.
So there is loss of arousal, loss of libido, erectile dysfunction in men, and in women they don't feel the pleasure during sex.
Yes, sir. Our lifestyle today is because a lot of junk foods, Zomato, Tomato, so many apps are there. People are bringing it and using more saturated fats, more saturated drinks, producing a lot of obesity. Now India has become neo-rich, neo-obese, and we have got a dubious distinction of becoming diabetic capital of the world. Highest Indians are diabetics now. All these things are producing hormonal disturbance, less testosterone, more sexual dysfunctions. See the obesity. See the obesity. Morbid obesities. And this obesity will bring certain more comorbid conditions like diabetes, thyroid, prolactinemia, depressions, cardiovascular problems, liver problems, alcohol added to that liver problem, renal failure, so many things, substance abuse, particularly alcohol. This alcohol is such a culprit thing. Now you see, watch this slide. This fellow, once he gulps the alcohol, the girl looks pretty and tall. Once the effect of alcohol is over, the girl looks plumpy and short. In our Hyderabadi language, there is a शायरी on this. जब आप देश की शराब पीते हो, मुझे पारू कहते हो. जब आप देश की शराब पीते हो, मुझे पारू कहते हो. जब आप स्कॉच पीते हो, मुझे डार्लिंग कहते हो. आज क्या पिया है, मुझे शैतान कह रहा है. Then this fellow is answering, आज मैं होश में हूं, इसीलिए कि आप शैतान लग रहा है. That is the effect of alcohol. That's why Shakespeare says, alcohol will maketh and taketh away the action. It ignites the desire but takes away the performance. So that's another culprit is smoking. Direct vasoconstrictor, nicotine, so constrict the blood vessels. Pineal blood vessels are the smallest blood vessels in the body. So first the pineal blood supply will suffer. Our sleep patterns. Nobody today, in the present day lifestyle, nobody is sleeping 8 hours. Minimum 6 hours sound sleep is required. all irregular sleeps, thanks to computers, laptops, smartphones, or irregular duties, night working hours. So circadian rhythm is getting affected, and the medications are contributing. Today, our citizens are feeling, not only India, everywhere throughout the world, same thing. They feel that for every ill, there is a pill. They are consuming pills like anything. All these pills are affecting the sexual life. Painkillers, opiates, antihistamines, we dermatologists write left and right, muscle relaxants, chemotherapy drugs, histamine, H2 receptors, antidepressants, anti-epileptics, antihypertensives, corticosteroids, ketoconazole, flutamide, ethylene, estrogens, finasteride. All these things are affecting the sexual life of the individuals. That's why a lot of drugs which are coming is affecting us. Apart from the so many systemic conditions, and my dear friends, today we are all in the using endocrine disruptors, using lot of phthalates because of the plastics. These plastics and the pesticides food, estrogen, phytoestrogens, eating lot of soya, that is a pro-estrogen, that's causing lot of disturbance in the testosterone. So these injuries and operations, see how the people will go and travel prolonged hours together, compressing the perineal blood supply. See here the activities, risky activities. See the risky activities producing perineal injuries, compression of perineal blood supply. All these activities, Pulgore injuries, retroperitoneal surgeries, perineal surgeries, proctectomy, colectomy, sympathectomies. All these things are contributing for the sexual dysfunction. My dear friends, to sum up, good sex can stretch the bad relationship for a longer time. So we, our healthcare providers, should strive hard to get the good sex in the relationship. Porno, if watched judiciously, can peacefully coexist with the relationship. It will reboot the sexual life. We have to educate the patients that living in real life is essential, not on real life. Porno is a real life. We should appreciate the reality, real life to real life. With this, now, as I told, porno is it's a double-edged weapon. One has to use judiciously to deserve, to enhance the affection, love, intimacy, sharing, and caring. With this, I take leave. Thank you, and I thank all my panelists and all the participants for their silent observation and keen interest. Thank you very much. Back to organizers, please.
Thank you, sir.
Dr. Venkatramana, Dr. Murugan,
yes,
shall I add only one more thing? You are done. You have wonderfully, congratulations, informative. Only one thing.
Yes, sir.
That watching porno will make the spouse to expectations more regarding the size and time. And this is one of the thing which will lead to sexual problems and both men and women. So this is also very important, sir.
Yes, sir. Yes, sir. Yes, sir.
Thank you. Thank you very much. Very good.
Thank you, sir. Thank you.
Thank you.
Back to organizers,
Thank you.
please.
Superbly done.
Thank you, sir. Thank you. Thank you very much.
Thank you, Venkatramana sir, for a wonderful panel discussion on such a rare and something. I mean, it's not open topic, but you covered in a very decent way, sir. Thank you so much. Now to organizing committee.
Hi, Kaushal. How are you?
I'm good. How are you?
Very nice. Patnaik, how are you?
Thank you, sir. Thank you for a nice session. So we are at the end, fag end. So before going to the valedictory function, we have sensitized the younger generation, the PGs, with the PG quiz. For this, I invite the quiz master for this session, Dr. J. Tulsi. She's assistant professor from Government Medical College, Suryapet. And over to Dr. Tulsi.
Thank you, sir. It's time for PG quiz. I request the technical team to release the questions.
Instructions.
Okay. By this time, you may be aware of all the instructions, but still I repeat once again. Each session will have 10 MCQ questions and mark only one correct answer. 3 toppers will be selected for winners. Duration is 5 minutes of time. And the winner has to be submitted bona fide certificates from the HODs. Don't refresh. Slow. All the best to all the PJs. So meanwhile, we conduct the felicitation session. I request the chairpersons, Dr. A.K. Jaiswal sir, Dr. B. Mohan Kumar sir, and Dr. B. Janardhan sir to felicitate the moderator, panelists, and speakers.
And the quiz master.
And the quiz master. Dr. Venkatimana sir. Dr. Kaushal Verma sir. Dr. Dinesh Sikovil sir. Dr. Saturday Shipatnaik sir. Dr. P.K. Kaviraj sir. Dr. B. Mohanlal sir. Now I request organizing committee to felicitate chairpersons A.K. Jaiswal sir, Dr. B. Mohan Kumar sir, Dr. B. Janardhan sir. Thank you so much, the organizing committee, to making me a part of this wonderful ASTI conference. Thank you so much, sir, for giving me this opportunity. Now over to Dr. Bhumesh Kumar, sir.
Yeah, thank you, Dr. Tulsi. So now it's the time to validatory function. So we'll welcome to the validatory function of the e-ASTICON 2021. So we have come to the end of the session. So I invite all the EC and OC of this e-ASTICON. Please come onto the desk and occupy the chairs. And before giving a message from the President, Secretary, and Treasurer, so I request the senior, the former presidents and seniors, please express your views.
Can I?
Yes, sir. Yeah, please.
Well, friends, I think I've been a part of ASTICON conference almost since 1989, if I'm not mistaken. And I can tell you that this is one of the best ASTICON conference I have ever attended. Though it was a virtual, but then I think it gave the feeling almost same as a physical one. We could meet and see people after so many years and so many times. Only thing what we were missing was that evening banquet and dinner. I think that can also, Vimesh, yes. I can give you an idea that can also in future conferences, you can have some online packages dinners
virtually
at the faculty residence.
Yes,
so
sir.
that will complete the complete conference.
Yes, sir.
Being from the army,
we promise you, sir, next time physical conference occurs in Hyderabad, we are going to give that.
We are waiting for it.
Okay, Dinesh, nice meeting you. Another thing that being from the army, the best part which I liked was the value of time. And in spite of being a virtual, it was right to the dot to the time the conference went on. I think.
Thank you, sir. Thank you. We are honored. We are honored for that.
Thank you very much, sir. Thank you.
So all the best to each and everyone. My special thanks and gratitude and congratulations to Dr. Murugan, Bhumesh, both the Nasimha Rao brothers, Rajiv Singh, Mohan Kumar, Chandrasekhar Rao, and everyone. Wish you all the best and thank you for making our this day a special one. Thank you very much.
Thank you, sir. Thank you very much for your blessings, kind words.
Thank you.
Very nice.
We'll take Mathur. Dinesh Mathur sir also.
Yeah.
Yes, yes.
Can I
Yeah,
come
Tapa
in?
sir, go ahead.
Yes, sir. Tapa sir, namaskar.
Namaskar, sir. Namaskar.
Good evening, Dr. Thapa.
Good evening. Good evening.
Nice seeing you, Tapa.
Right, sir. Thank you. Thank you, sir.
Totally agree with Dr. Jaiswal's comments, and probably it is the best ASTICON I have attended, and very, in fact, it was very thought fearing in the sense what we have shifted our thinking to. If genital STDs they are listening, then probably they're talking about sex and all these things was very very much relative and this thing. Thank you very much.
We have to thank COVID, sir. Because of COVID, people are more in the houses, and because of that, more sex, more problems that they are coming to the healthcare providers. That's why our shift is towards the sex.
Oh, yes, and I liked it, and all
Thank you,
compliments to the
Thank you,
organization.
sir. We'll go to Thapa, sir. Thapa.
Yeah. It was a nice conference with the limitations which we have. We cannot physically meet that is the thing. But Bhumesh, you had chosen the right kind of the people, and the panel session which I attended was very spontaneously. I had to give answers. He has not given us any clue to the whatever things he is going to show us or not. We were testing our skills, and so that is a good part of it, that we were testing the skills of the experts and other people, and then we are learning from.
कभी-कभी प्रोफेसर का भी एग्जाम हो जाना चाहिए ना थापा साहब.
Yeah.
Thank you,
Rajiv,
Thapa sir. being associated with us.
Rajiv, you are wonderful. You are wonderful always.
अरे नहीं मैं तो कुछ
Yeah. No. You have a lot of clinical skills. We have to learn from you so many things. Even if I have, means we may be called as professor because I am on the teaching side, so you are on the other side. But you also does not have less skills than us. Okay, so that is how Bhumesh, very well done,
Thank
and
you, sir.
really nice and wonderful, and we hope to
With
see
all your
in
support and
action.
blessings.
Yes. Thank you very much for giving
Thank
me
you, sir.
this.
Thank you.
Great.
Umesh, I would like to say this, that you have done a wonderful job. You have been keeping us on toes with continuous messages, continuous information. And this conference being virtual also has been flawless. As Dr. Jaiswal mentioned that certainly we have enjoyed from morning till this time.
Thank you, sir. Thank you.
Thank you, sir. Thank you very much, sir. Datta, sir.
Bhumesh, it was a fantastic preparation. The organizing part was really excellent. It's very difficult to find any fault. And one more thing, it was on time because 3 minutes before you tell that you have to stop. And that way you could maintain the time. And the quality of the papers were fantastic. The whole thing overall, it is one of the best conferences which is being held or other which I have seen till date. Really fantastic, and congratulations to team e-ASTICON 2021. Fantastic, Bhumesh and the others. Thank you very much.
Thank you, sir. Thank you very much. Yeah, Sitaram, sir. The president is the last.
Okay.
Excellent. Namaste. Excellent, Bhumesh, the entire ASTICON team, Dr. Ramanagaru, Dr. Natsarao, Dr. Netha Natsarao, and all of you. And I think it was a very meticulous planning. I mean, the continuous communication and everyday reminding and following up and things, and the CVs, whatever it is. It is almost everyday communication from you, Dr. Bhumesh. It needs a tremendous energy. So, I mean, I think I congratulate you on that part. All the sessions were interesting. I was there sitting all through since morning. And it's really a wonderful job and a wonderful academic feast today. So thank you. Thank you very much for the entire team show.
Thank you, sir. Thank you very much for your kind words. Rajesh, sir. Rajesh Sharma, sir. You are muted, sir. You are muted.
Okay, Bhumesh, thank you for making me a part. I enjoyed the whole day and I learned a lot of things which I had forgotten, apart from what I know. But it was wonderful coming back to e-ASTICON. I have been attending the conferences, but this was a real academic feast, and your planning and your session planning was excellent. And the last session was wonderfully done. The topic was so sensitive, but wonderfully handled.
Thank you, sir. Thank you, sir.
Thank you, sir. Mahadevan, sir, are you there? Madhubabu, sir.
He's muted.
Close, Jesse.
Yeah, wonderful conference, Bhumesh. Excellent conference, and kudos to all the e-ASTICON team members, to President and to yourself and to Venkatam sir, all the scientific committee member, everybody. And it's very pleasure to see all the senior most people after a long time, after 1 year, and having the interaction with all the people, and very nice to listen all the lectures. Thank you one and all for giving us a wonderful opportunity of the highly academic feast. Thank you, sir.
Thank you. Thank you. Narasimharam, Neta, sir. Neta, sir.
Good evening, all of you, and thank you one and all for giving your cooperation. Help, because of you, we could do it and made it to success. Thank you one and all. Thank you very much.
Anybody is there before treasurer, sir? Treasurer and secretary and president, anybody want to express their views? Yeah, treasurer, sir. Chandrasekhar Rao, sir.
Mohan Bhav.
So,
Yeah.
Sumit, sir, please.
Yeah, hi, Bhumesh, wonderful. You do it so meticulously. Yeah, I have attended many e-conferences, but the way you take it so seriously and energetically, very few people do it that way. And I'm afraid that we are holding our Asia Pacific Congress, and you set such a high standard of organizing that you make me feel a little nervous.
So, no, sir, you are so experienced. Nothing is a blessing for the Bhumesh.
No. I just messaged from Delegate Link that next time we want to meet in person in Film City or somewhere in Hyderabad.
Yes, sir. Yes, sir. We are planning.
Sure.
Next year, same thing. We are planning, sir.
Thank you. Thank you so much once again. Thanks for everything.
Thank you. Thank you for your words, sir. Treasurer, sir. Chandrasekhar. Please don't go away. We have a national anthem. After that, vote of thanks followed by national anthem.
Opportunity to attend all the 45 national conferences. I am only the member who has attended. Every conference is in its different way. But this conference is unique in perfectly planned, excellently executed, successfully succeeded in its purpose to pool the knowledge to be disseminated to the members. It has succeeded really. And it is very difficult to talk about STI and HIV in 9 hours period, but the organizers have managed to give the essential essence, and all the speakers have cooperated and done well. I don't know whether Bhumesh is Chettiar or not. I see that pride in him. I just wondered in this pandemic period, without the delegate fee and without the support of the pharma companies, how could he generate the fund to conduct this conference? It's really hats off. And we should appreciate the technical staff who has helped their services to be recognized. And Bhumesh and group really deserve a standing ovation. But as it is not possible now in this e-ASTICON, with the permission of the President and Organized Committee, we will just give a loud appreciation. Thank you.
Thank you. Thank you, sir.
Thank you. Thank you so much, sir, for your kind words. Secretary, sir.
Sir, we can request the Dinesh sir and Gaviyasan sir too.
Yeah, please.
Sir, I have to thank Professor Dr. Bhumesh sir for involving me. Actually, I was more associated with our IADVL association. I'm the vice president. And because after involving in this from the morning till evening, and I have a feel that I missed so much in my life. And almost all the talks, all the speakers, all the topics, and everything was informative and more learned. And you conducted in a meticulous way that it was so professional and highly perfect way. And I have to thank Professor Dr. Murugan for his book. And after reading that book only, I think so much of what we miss in my life. And we are so mechanical. And this one, I feel more younger also. I have to thank Dr. Venkatramana for such an informative session. And really, I enjoyed, sir. So many slides, but all the things are like that without wasting time and to the point. And it was so informative. And Dr. Mohan and my guru, Dr. Thapa sir, and my mentor, Sitaram Kolapadi sir, and he is such a man. So I'm really inspired by his talks and other things. It was conducted in such a nice way. And I have to congratulate all the faculties. And I have to thank the lephrologist, living legend, Dr. Narasimha Rao. And I think it is a great team effort. And kudos to the e-ASTICON team 21. Thank you so much.
Thank you, sir.
Thank you, sir. Mohan Kumar,
So
sir.
Umesh, my wife just want to convey her little blessings. Will you allow her?
Hi, definitely. Madam, thank you, madam.
Thank you so much.
नमस्ते और आप सबों को प्रेजेंट कलीग को
थैंक यू मैडम
एक बात बताना चाह रही हूँ कि फ्रॉम फर्स्ट सेंचुरी हर सेंचुरी में रिक्वायरमेंट इज द सेम डिफरेंट एंड पास्ट प्रेजेंट एंड फ्यूचर और हमारे भारत संस्कृति में पहले जब क्राइसिस हो गई थी सेक्स की तो मंदिरों में इसका एजुकेशन दिया गया था तो खुजराओं के और पुरी के ये सब में था तो सेम थिंग नाउ इज द सेंचुरी इज डिफरेंट एंड कोरोना इज विथ that's why you people are doing this but our Indian culture already जब सेक्स की कमी हो गई थी तो ये हुए थे तो दिस इज द गुड फॉर द प्रेजेंट पास्ट प्रेजेंट एंड फ्यूचर तो बस ब्लेसिंग फॉर द ऑल द यंग जनरेशन विद द यंग problem and it is very knowledgeable. Sex education should be good in the school also and everywhere. Wish you all the best. Thanks and good luck for the future.
Thank you, madam. Thank you.
Mohan Kumar, sir.
Thank you, madam.
Thank you. We can get the blessings.
After Mohan Kumar, the president will talk, then followed by the results of physics quiz, then the vote of thanks and the anthem.
Or Dinesh Goyal, sir. Goyal, sir.
Goyal, he already he spoke.
Spoken.
Yes, sir. Okay, sir. As a secretary of IAS study, I am very much honored to the part of the second e-ASTICON also once again. We are very much happy and elated with the efforts from Hyderabad team, led by Professor Nasim Rao sir, assisted by Umesh sir, and the guidance from Venkatramana sir, Nasim Rao sir, is make this opportunity to younger generation like us to take this torch in a better manner. Once again, from the association part, I am thankful to the technical team, the hetero technical team who made this live stream in a better manner, especially in the all our local association members are very much happy. They are part of the both YouTube link and the routine link. It's very nicely displayed without any hindrance. They are able to see. They are sharing in their friend circle also. So anything personally, I am saying that all our seniors are taking this sexually transmitted infections. We are not now treating only the infections. We are taking our platform of knowledge sharing to the health also. So sexual health is more than the infections. So we are carrying the torch. Once again, my best wishes to the Hyderabad team. We are awaiting the 2020 conference in Hyderabad, sir. Thank you.
Thank you. Now it's the time to the president. After this, we have a results, quiz results.
Good evening, everybody. After the last e-ASTICON, we were hoping for a physical conference. But due to the pandemic extending, we were not, and we were deciding that about e-ASTICON 2021 just 1.5 months back. We fixed a date just 1.5 months back. Within the span of 1.5 months, Umesh and his team, Dr. Narasimha Rao Neta's and team, done wonders. They meticulously prepared the topics, faculties, and coordinating with everybody in a nice way, planning everybody, not every minute, every second they have been planned. And they also formed WhatsApp groups, faculty groups, and individually each session group. A wonderful, marvelous, and communication. Then and there, they have contacted us. They have and instructions how to form, how to go. What the first chairman has to do, second chairman has to do. Everything planned meticulously and wonderful way. I salute the Hyderabad team very much. And I have to thank Hetero Healthcare and the technical people, that is CV team, time management team, everything was wonderful and cannot be expressed. So this way, we are expecting, so what will be the physical conference? So it will be fantastic and
Definitely it will be fantastic.
And hospitality, and we are very much eagerly awaiting for this. And at this time, I, on behalf of IAST Study and AIDS, wants to honor the organizing team base. And first, I asked Dr. Narasimha Rao Neta to come to the dais. Umesh, how to conduct this? That is honoring. Any way?
Umesh, direct the IT people.
Srinivas.
Srinivas.
On behalf of Narasimha Rao Neta, chairman of e-ASTICON 2021, with our applause and praise. Thank you very much, sir.
Thank you very much.
Next. I congratulate, I salute Dr. Bhumesh Kumar and team for his excellent conduction of this e-ASTICON 2021. Thank you, Dr. Bhumesh.
Thank you, sir. Thank you very much.
Scientific committee.
Yeah, so thank you, sir. Thank you very much. For,
I also congratulate and thank immensely the scientific committee team and co-chairman Dr. Rajiv Singh and Dr. Venkat Ramana and Narasimha Rao Neta very much profusely. Thank you one and all. Very good evening. Thanks a lot.
Thank you, sir.
Thank you very much, sir. Now it's the time to the release of quiz results. So now we have come to the end. Third prize goes to Vignesh Narayan from Postgraduate Institute of Medical Sciences and Research, PGI. He will get 3,000 cash, application certificate, memento, immunity kit, 1 pulse oximeter, 1 magnifying lens, and 1 Botany color atlas of STD. Second prize goes to Sachin Gupta from AIMS Delhi. The prize it contains the ₹5,000 appreciation certificate, memento, immunity kit, 1 pulse oximeter, 1 magnifying lens, 1 Bhushan Kumar test book of STD. And the first prize goes to Fatima Safar from Deccan College of Medical Sciences. The first prize, ₹7,000 cash, appreciation certificate, memento, immunity kit, 1 pulse oximeter, 1 magnifying lens, and 1 King K. Holmes pocket textbook of STD. Thank you, hearty congratulations to all the PGs. And in fact, more than 1,000 PGs they have participated, and hearty congratulations. And everybody has done excellent job. hearty congratulations to the PGs and their faculty and their HODs and the institution. So, and vote of thanks. So it's a time to say it's yeah. And on behalf of organizing committee, so we thank you very much to the EC, our president, secretary, treasurer, and whole EC for your unconditional support and for making this a program a grand success with a lot of take-home messages. And a big thanks to all the faculty members, more than 70 faculty members, and for your valuable time and the sharing scientific knowledge in the field of STD and AIDS. And we thank all the quiz masters for your participation and making the quiz a grand success. And thank you very much to all former presidents of this ISSTD. So we lost Dr. A.K. Bajaj sir. Last time he was there. So thank you very much for all the presidents and all the very big thanks to all former secretaries. And very, very big thanks to all the delegates, the delegates, they are almost including PGs and delegates, they have crossed to 2021. So that is our target. So we achieved it. It is more than that, but very, very big thanks from morning in spite of a busy schedule on Sunday. So almost everybody was there till the end. Thank you very much for all the delegates for your active participation. And as I said, our EC, a very big thanks to Hetero Healthcare team for your unconditional support as a knowledge partner. So whole team, almost more than 3 months, we were behind them, almost even midnight also. I used to call Chiranjeev, I used to call Srinivas, I used to call Guru Prasad, I used to call Vijay. So all the time, so almost maybe I'm the one of the biggest enemy for them, maybe because almost I have scolded so many times. A very big thanks. And from IT team, Chiranjeevi and the Srinivas, they are worked relentlessly without taking any rest. Very big thanks, special thanks to all the team of EC and Vijay and Guru Prasad. So without you, this conference could not be possible. So very big thanks. At the same time, we need the same support in future also. Even this hetero team, they are helping for the even all Dharmanars. They are taking care of all Dharmanars for Telangana also. Thank you very much. And very on behalf of EC, a very big thanks to all of you. And if you have done any by knowingly, unknowingly, any mistakes or anything is there, so please excuse me with your big hearts. So whatever we have done our level best. And one thing I would say, I have a right hand and left hand, our Neta, my chairman, always anytime, sir, shall we go this? Yeah, go ahead. And Venkatamana sir, always, sir, shall we go? Yeah, go ahead. And even Rajiv sir and P. Narasimha, all are there, so behind us, whatever we'll do shall go ahead. So with all this, without them, this could not be possible. Thank you very much. With this, we will wind up this the e-ASTICON. So concluding remarks, and we will close with a vote of thanks with our national anthem.
Well, thank you, Murugan, Dr. Venkat Ramana, Vice Dean.
Thank you, sir. Thank you, sir. National anthem, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you very much, all of you. God bless.
All the best.
Thank you.
Please join for one group photo. Please, all of you, those who are there, please come out. We'll take one group photo.
Thank you very
Thanks
much.
all of you.
Thank you. Nice,
It was
sir.
Thank you, Aaron.
fantastic. Simply fantastic.
How are you, Aaron?
Okay. Fine, fine.
Good, good. Thank you, Madhu.
Okay.
Thank you, sir. Thank you very much. Srinivas,
Yes, sir.
good job you have done. Thank you. So we'll have one day dinner is a physical.
Yes, sir. Thank you, sir.
Congratulations.
Hearty congratulations.
Thank you,
Once
sir.
again,
Mohan Kumar sir, one day we
Umesh.
will come to Chennai.
Wonderful job.
We will meet physical, sir. We will definitely host the lunch, sir. Lunch or dinner, as you wish, sir. Thank you. Welcome, sir. Welcome, sir.
Thank you. Srinivas?
Sir.
PG ఉంది కదా స్లైడ్స్ 3 నాకు పంపించేసి.
Yes, sir. Okay, sir. Okay, sir.
Right.
Fine. Okay.
రిమూవ్ పడుతున్నాను ఇంకా
ఎవరిది
మోటో ఫై
తీసి రిమూవ్ చేసి అందరూ వెళ్ళిపోయారు భూపేష్ కూడా వెళ్ళిపోయాడు లీవ్ ద మీటింగ్ కొట్టేసామ్మా